We got a long day, don't we?
We do.
All right.
Long day into the night.
I hope not, but maybe. The subcommittee will come to order, and the chair will recognize himself for an opening statement. Today, we're marking up legislation to help support moms and babies, promote access to life-saving therapies for rare and life-threatening diseases, and to bolster our ability to effectively respond to emerging biological and pathogenic threats. We're also continuing this committee's work to address the fentanyl and opioid crisis. First, we'll be marking up legislation that I'm leading alongside Representative Custer to reauthorize key provisions from the 218 Support Act for Patients and Communities Act before their expiration on September 30th. This bill, H.R. 4531, the Support Act of 2023, would provide access to life-saving treatment and recovery support services, prevention programming, and long-term recovery services for individuals seeking help overcoming their substance use disorder. This bill also includes the scheduling of xylazine. Xylazine, known as Tranq, is an animal tranquilizer that is increasingly found in illicit opioids and other drugs. It does not respond to overdose reversal medications like naloxone, which can make overdoses more fatal. This bill places xylazine in the Schedule 3 of the Controlled Substances Act, which will help our law enforcement keep this substance off our streets while maintaining access for veterinarians and ranchers to use on animals. The bill would also lift unnecessary barriers to treatment for vulnerable populations by promoting sustained access to medication, assisted treatment for Medicaid beneficiaries, and access to long-term and recovery services for individuals. H.R. 4531 also includes solutions that will promote access to long-term recovery services like workforce training and peer support services. This also includes reauthorizing a key priority of mine, the Comprehensive Opioid Recovery Centers Program, which provides targeted resources to communities that are significantly impacted by the overdose epidemic. Next is a set of bills to ensure our public health system is prepared to respond to emerging health threats. Mr. Hudson has two bills to address the emerging threats: H.R. 4421, Preparing for All Hazards and Pathogens Reauthorization Act, and H.R. 4420, Preparedness and Response Reauthorization Act. These two bills will accomplish several goals. First, both pieces of legislation will streamline our response infrastructure within the Administration for Strategic Preparedness and Response, or ASPR. Additionally, these bills include efforts to shore up our diagnostic testing infrastructure and domestic manufacturing capacity for medical countermeasures during a future public health emergency. Areas of weakness in our current system that we all saw firsthand falter during our initial response to the COVID-19 pandemic. On top of that, these bills also contain several provisions focused on improving our national strategic stockpile, including clarifying ASPR's responsibility over the strategic national stockpile. Many of the provisions incorporated in H.R. 4420 and 4421 are bipartisan, and I appreciate Mr. Hudson's longstanding leadership on this issue. Despite these significant improvements to our public health system, is it disappointing that these bills and overall efforts to authorize many of these programs is not going forward bipartisan, and we'll say the Republicans have sought to work together as we move forward. We have been clear about the need to address drug shortages, which is why in March of this year, we sent a letter to the Food and Drug Administration requesting information related to certain drugs in shortage, as well as how the agency has used its existing authorities to address and ensure that these drugs can get to patients as quickly as possible and ensure there are no future shortages. Chair Rogers and Senator Crapo also released a request for information to solicit feedback from a wide range of stakeholders and identify thoughtful, targeted solutions to address these shortages, and announced yesterday we're hopeful to release a discussion draft in coming weeks. Committee Republicans stand ready to address this important issue, but we have made clear on countless occasions that this is not the process to engage on those. Finally, there is a set of public health bills that reauthorize programs that provide support for patients and their families. These include H.R. 3391 for Mr. Bilirakis to help identify the root causes of pediatric cancers and other conditions. H.R. 3226 from Dr. Miller Meeks and Ms. Eshu to support better outcomes for preterm babies, in addition to legislation to advance our knowledge of rare diseases that will help lead to the availability of therapies for these diseases. In closing, I'm proud of the legislation we're marking up today, and I look forward to advancing these important bills to the full committee. And I yield back. The chair now recognizes the ranking member, Ms. Eshu from California, for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and good morning, members. We have a full day ahead of us, and I look forward to engaging with everyone on the 17 health bills that are being taken up. 8 of these bills are bipartisan policies that continue successful programs, including my PREEMIE Act, which aims to reduce premature births. We're also voting on a bipartisan reauthorization of the SUPPORT Act to continue addressing the deadly scourge of the opioid epidemic by increasing access to prevention, treatment, and recovery for patients with substance use disorder. Urgent action is needed since about 300 Americans die every day from a drug overdose. Today's SUPPORT Act reauthorization is a good start, but more needs to be done to address overdoses, including passing Mr. Tonko's Medicaid Reentry Act to help connect people who are leaving incarceration with treatment. People who are released from jail and prisons are 12 times more likely to die of an overdose than the general public. I'm really, it's a dramatic word, but I'm going to use it. I'm shattered that we've missed a critical bipartisan opportunity to craft a comprehensive Pandemic and All Hazards Preparedness Act, the PAPA reauthorization. Since November, I've worked with Representative Hudson and Chairs Guthrie and McMorris-Rogers on drafting PAPA. Together, we issued a bipartisan RFI that received over 250 responses, showing the clear demand from stakeholders for improvements to the legislation. But despite that positive start, the process has turned increasingly partisan. The resulting product is a disjointed package of underfunded health programs that do not, in my view, meet our nation's needs and will leave us unprepared for the next public health emergency. Instead of a single comprehensive PAPA bill with the typical ASPR, CDC, and FDA policies, the bills we're voting on today are fragments of what's needed. First, we'll consider a bill reauthorizing ASPR programs that includes partisan policy tying the hands of BARDA and ASPR that will keep them from nimbly responding to an emergency. Second, we'll consider a CDC bill that does the bare minimum and locks the CDC programs at low funding levels for 5 years. The Republican CDC bill does nothing to address our public health data needs or reduce the public health workforce shortage. Third, the Republican bills completely ignore FDA policy. PAPA has always had an FDA section, but because of the majority's opposition to FDA policy to address drug shortages, they've dropped everything related to the FDA. This is not good policy making. We'll also vote on 3 partisan bills that inject politics into public health. Instead of working with Democrats on a bipartisan PAPA bill, Republicans crafted hyper-partisan bills that will be subjected to what I think will be chaotic floor fights. It didn't need to be this way. We still have time between this subcommittee markup and the full committee. You know, when you look at what this committee did previously on PAPA reauthorizations, it passed with voice votes, and on suspension, obviously suspension is passing with the 2/3 of members of the full House supporting it. Finally, we're also voting today on legislation that will damage the Children's Hospital's graduate medical education program irreparably. by making hospitals choose between providing the standard of care for children experiencing gender dysphoria or losing funding that keeps them afloat. For nearly 25 years, the CHGME program has been the gold standard in our country and has trained half of general pediatricians and a majority of pediatric specialists. It's difficult for me to comprehend why my Republican colleagues are subjecting children's hospitals to what I think is a manufactured culture war that puts politics between parents, children, and their pediatricians. I joined the Energy and Commerce Committee in 1995, and I've always taken great pride in our ability to pass bipartisan legislation. Some of the bills today make me question whether we'll be able to continue that important legacy. With all of that, Mr. Chairman, thank you, and I yield back.
Thank you. The gentlelady yields back, and the chair now recognizes the chair of the full committee, Chair Rogers, for 5 minutes for an opening statement.
Good morning. Good morning, colleagues, everyone. I'm glad that we are here today, moving so many important pieces of legislation. Our markup and work today is yet another example of the Energy and Commerce Committee plowing the hard ground necessary to legislate. We're doing the work to carefully review and reassess government programs to make sure that they best serve the American people. That is our job as the people's representatives. So thank you to everyone leading on bills today. Not only are we ensuring federal programs are accountable to those we serve, we are helping to improve people's lives. For example, we're making sure moms and their babies get the support that they need at all phases of their lives. We're reauthorizing important programs to rescue people from despair and recover from substance use disorders. We're building on our work to stop fentanyl poisonings, and we're making sure hospitals can train the next generation of pediatricians. And we're also bringing accountability to the CDC. In addition to all of this, we're making progress today on reauthorizing key authorities to help protect Americans from chemical, radiological, biological, nuclear, and cyber attacks. For months, we've been working to bring everyone to the table so that it could be a bipartisan bill. These programs to ensure America is ready to respond to all hazards has expired before. And I made clear my top priority was doing all that I could to get these programs reauthorized on time. So I'm glad that we are moving Mr. Hudson's legislation today, and I hope and invite the Democrats to come back to the table and support this legislation so that America is prepared to respond to public health threats from catastrophic natural disaster to biological threats to cyber attacks. Not every bill is going to contain every member's priority, and we may have different views on the best path for success. But by putting everything into one bill is not the way forward. It's not the best way to legislate. As I said yesterday, we're carefully reviewing more than 100 responses we received in response to our request for information on the underlying causes of the drug shortages. We need to address this, and we will. Our next step is a discussion draft that we will be releasing in the coming weeks. The problem demands more attention than rushing a few broad FDA bills through committee. And I hope today Democrats will agree with me to join in working on this with a more thoughtful, comprehensive approach to address the root causes of the drug shortages, whether it's looking at FDA authorities or how Medicare and Medicaid pay for medicines. Let's work together. With that, I will say again, thank you to all my colleagues who are leading on bills, leading on solutions. Reviewing all these programs takes time, and it's a lot of work. Energy and Commerce has this reputation of attracting the best members. I'll say it, because we're up to the task. And I look forward to today's discussion and moving these solutions to the full committee to consider. Thank you. I yield back.
Thank you. The chair yields back. The chair now recognizes the ranking member of the full committee, the gentleman from New Jersey, Rep. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. I regret that today we are considering a partisan reauthorization of the Pandemic and All Hazards Preparedness Act, or PAPA, something that has never been done in PAPA's history. It's clear from the legislation before us today that the Republican majority has learned all the wrong lessons from the COVID-19 pandemic and the ongoing drug shortage and medical supply chain crisis. Our government was not prepared for COVID-19, and we've not done enough to be ready for the next threat. The bills before us today will leave us unprepared going forward and put politics over public health and science. The bills include no funding increases and no improvements to public health data. Republicans also do nothing to address the medical supply chain, a critical failure of our COVID-19 response that continues to cause problems with the ongoing drug shortage crisis. Now, last week I held a roundtable in my district to discuss this crisis. I heard from patients who have been unable to fill prescriptions and from doctors who are being forced to ration care. One oncologist, Dr. Eleanor Teblinsky, described how she has found herself sitting across the room from patients and their families, telling them that she could not guarantee they would receive their next chemotherapy on time, if at all. By refusing to address the drug shortage crisis as part of PAPA reauthorization, committee Republicans are putting American lives at risk. Democrats have put forward common sense proposals that would improve our ability to quickly identify and respond to future pharmaceutical and medical device shortages. Those provisions should be included in the PAPA reauthorization bill today. Republicans' claims that FDA policy is outside the scope of PAPA defy reality, considering that all previous PAPAs have included FDA policy. Meanwhile, Republicans are pulling out all the stops to provide themselves with political cover and pretend like they're taking action with the partisan RFI they put forward, and an announcement last night that the chair intends to circulate a discussion draft for comment in a few weeks. Patients are demanding action now, and Republicans are giving them an IOU for a rough draft. It doesn't have to be this way. Work with us. Drug shortages are a clear and present emergency right now, and there is simply no good excuse for inaction. Now, while I'm disappointed in our lack of progress in PAPA, I am pleased that the same is not true for the Support for Patients and Communities Reauthorization Act. 5 years ago, this committee worked together to pass the Support Act to address the ongoing opioid epidemic. Today, we'll consider a package that will reauthorize critical programs included in the Support Act and some additional provisions to expand treatment options and response efforts to the opioid epidemic. This markup does not include some important policies that will help justice-involved populations access Medicaid, but we're continuing to work in a bipartisan fashion on those policies. It's important that we act, and we have the support of 31 state attorney generals of both red states and blue states in support of the Medicaid Reentry Act and the Due Process Continuity of Care Act. The state AGs write that these bills, and I'm quoting, represent one of the 118th Congress's strongest opportunities to increase public safety and improve public health outcomes nationwide. And I strongly support these policies, and I'm hopeful that between now and the full committee, we can find a bipartisan path forward on these provisions. We're also working together on strategies to address the rising threat of xylazine, and we'll be considering a version of H.R. 1839. I remain concerned about whether this approach will really do anything to address the underlying epidemic and the harms posed by xylazine. But further criminalization of substances does nothing to connect people to treatment and recovery, and instead is likely to perpetuate a cycle of incarceration, broken communities, and rising overdoses. But the language in the bill represents an improvement over the bill as introduced, and I look forward to receiving stakeholder feedback on our proposed approach. I am disappointed, however, that Republicans have included H.R. 4056. This bill would weaken protections for foster children and create a financial incentive to place them in large institutional settings. I'm concerned that it would undermine federal law that encourages placing foster children in the most family-like settings while effectively exempting these institutions from important beneficiary protections in Medicaid. And finally, I'm deeply disappointed and actually appalled that Republicans are using reauthorization of the Children's Hospital Graduate Medical Program as a vehicle to peddle their dangerous and discriminatory attacks against transgender youth. Democrats have pushed for a clean reauthorization of this important program, which, like PAPA, has traditionally been done in a bipartisan fashion. Yet my Republican colleagues insist on making this a partisan battle over extreme and destructive language to ban medically necessary care for transgender youth. So thank you again, Mr. Chairman, and I yield back.
The gentleman yields back. The chair reminds members that pursuant to the committee rules, all members' opening statements will be made part of the record. Are there further opening statements? The gentleman from Texas is recognized for 3 minutes for an opening statement. Mr. Burgess, the gentleman from Texas.
Thank you, Chair Guthrie, and I want to thank you for advancing three critical pieces of legislation to the markup: the PREEMIE Act, the Preventing Maternal Deaths Act, the Sickle Cell Disease Research, Surveillance, and Prevention and Research Act of 2023. At our last hearing, I mentioned that my middle daughter spent some time in a neonatal intensive care unit on a ventilator. That was in 1976. The treatment of the very small premature infant has vastly improved and increased over time, and the PREEMIE Act that we have in front of us today is going to help us with advanced innovation and research. I want to thank everyone involved in the process for working on the bill, and I hope to see advances in how we can prevent, address, and treat premature babies. I'm also grateful that we're considering the Preventing Maternal Deaths Reauthorization Act. This important bill reauthorizes assistance to states for maternal mortality review committees to better understand the burden of maternal complications and mortality through research, education, and best practices. I appreciate my fellow members, Representative DeGette, Representative Carter of Georgia, Representative Kelly, Representative Kamick, and Representative Castor for working with us on this. And lastly, I am grateful to the partnership of Congressman Danny Davis of the Ways and Means Committee and Buddy Carter on this committee for our sickle cell reauthorization legislation. I can remember back in the middle 1970s as an intern at Parkland Hospital, treating patients in sickle crisis, and then here on this committee, decades later, learning that there had been no new FDA-approved therapy for sickle cell disease in 40 years. Now, fortunately, that has changed since 2016, and there have been significant advances made, but progress toward a cure for this disease, we need to build on that momentum and do all we can to help raise awareness and invest in research that will one day provide a cure for these patients. I'm also glad to see the committee will be advancing important public health preparedness reauthorizations to improve our nation's medical countermeasures and ensure threat protection and strengthen our strategic national stockpile. I've advocated for many of these vital policies to ensure that this nation is prepared with the diagnostics, therapeutics, and life-sustaining technologies in the case of a public health emergency. A bipartisan bill, the Disease X Act of 2023, which is also included, allows BARDA to support advanced research and development of countermeasures for emerging viral pathogens and viral families with significant pandemic potential. I am grateful for the reauthorization of the Support Act. Although it didn't make it into the cut this time, I'm hopeful that a bipartisan bill to look at removing the IMD, the Institute for Mental Disease, exclusion in Medicaid can go forward. I think this is an important part of establishing the proper care of treatment with patients with mental illness. Thank you, Mr. Chairman, for the recognition, and I'll yield back.
The gentleman yields back. Are there any other members on the Democratic side seeking an opening statement? On the Republican side? I'll remind the members as well, we just figured it out. We had the clock set for 5, so I was going to stop you at 2, but now they're set for 3, so we figured out the clock. So thank you. So the chair now recognizes the gentleman from North Carolina for 3 minutes. Mr. Hudson, you're recognized.
Thank you, Mr. Chairman. Today's a great day because today we do the important work the American people expect us to do with the 4th generation of Papa moving through regular order. I am disappointed that we're still without my colleague, Representative Eshoo, who has championed this legislation for decades and who knows as well as anyone the importance of emergency preparedness. Without Papa and these key authorities and programs, the attention and foresight of Representative Eshoo and previous champions of this bill and our leaders who put these operations in place, we would be in a different place as a country right now. There would have been no Operation Warp Speed, no partnerships between government and industry, no opportunity for more efficient distribution of tests and therapeutics, PPE, and vaccines. And as bad as the recent pandemic was, I shudder to think of how much worse it would have been without the authorities and the legislation of previous Papa. This bill is urgent and it is essential. After the lessons we learned from COVID and months of bipartisan discussions, there are numerous issues that we address through this legislation. Government oversight and accountability, communication between public and private partners, supply chain viability and response efforts, just to name a few. The drug shortage issue right now is devastating. I've repeatedly emphasized my commitment to working with Representative Eshoo, Pallone, and my colleagues across the aisle to address it. Our chair, Ms. McMorris-Rodgers, has laid out a process. We will have a discussion draft, and once that's out, I'll work with the chair and any Democrat colleague that wants to roll up their sleeves and get to work. This issue deserves our careful and thorough attention, and PAPA also deserves to get across the finish line in a bipartisan way as quickly as we're able to do it. I heard the concerns my colleague mentioned, including that this legislation may tie the hands of bureaucrats. Well, I disagree with her characterization, because I think what we're doing is we're demanding more transparency from ASPR and BARDA. We're wanting to create a better relationship for these public-private partnerships that in the last pandemic proved to be essential. It was also mentioned that we don't address the workforce shortage, but that's not true. We're giving additional powers to ASPR to hire in times of emergency. I think that's critical. Where we disagree is I'm not prepared to give a whole lot of new authority to the entire enterprise at HHS, but I'm open to those discussions. It was also said that we ignore FDA completely. Well, in the past, in PAPA authorizations, FDA has been addressed, but it's been addressed in terms of facilitating medical countermeasures and what authorities and requirements were necessary so that we would get better public-private partnerships, because that is the sweet spot. That is, to me, one of the greatest lessons learned from the pandemic. This country was saved by public-private partnerships, by a robust private sector and a federal government that was nimble enough, because of emergency powers, to work with that private sector to bring forth the solutions we needed. And so I implore my colleagues, please work with us. We want this to be bipartisan. We want to get this right. My arms are extended, my hands are open. The American people demand it. Please, let's work together. And with that, I yield back.
Thank you. The gentleman yields back. Are there any further opening statements? Seeing none, I will now move, we'll call up our first bill. The chair calls up H.R. 824 and asks the clerk to report.
H.R. 824, a bill to amend Title 27 of the Public Health Service Act, the Employee Retirement Income and Security Act of 1974, and the Internal...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek to be recognized on the bill? What purpose, the gentleman from New Jersey seek recognition?
To strike the last word.
Gentleman is recognized.
Mr. Chairman, I have strong concerns with H.R. 824, which would expand accepted benefits and allow employers to offer telehealth as a separate standalone policy, exempt from most of the Affordable Care Act's critical consumer protections. This would mean that employees would receive only telehealth and no other healthcare services like hospitalization or drugs. The ACA included a comprehensive set of measures to protect pre-existing conditions. Under the aims offered by my Republican colleagues, accepted benefits would still be exempt from most of the ACA's consumer protections, including limits on out-of-pocket costs and other key patient protections. I'm very concerned, as is the broader patient community, made up of 31 patient organizations, such as the Heart Association, the Lung Association, Leukemia and Lymphoma Society, and many more, that these changes are still inadequate and insufficient. This bill weakens ACA coverage and consumer protections in the name of competition. These plans, unfortunately, don't offer better care at a lower price, like true competition in the insurance market does. Instead, it means expanding options that would leave American families with inadequate health care coverage and at risk of surprise medical bills. And that is what the Trump administration's rule on junk plans did. It allowed for short-term limited duration plans to be offered essentially parallel to the ACA market, except without regulation. These plans provide grossly inadequate coverage. Similarly, a telehealth-only accepted benefits policy would be virtually unregulated and would likely include both coverage limitations and financial limitations on the telehealth benefit covered. And I'm concerned that consumers who enroll in these products and fall sick could incur huge, potentially financially ruinous medical costs. I'm also very concerned that this could be deceptively marketed to Americans as comprehensive coverage, or that consumers would simply be confused, particularly in marginalized communities. While the AINS includes a notice requirement that accepted benefits is not minimum essential coverage, I believe the notice is insufficient. The Trump administration included a similar notice requirement for STLDI plans, but studies show that these plans often provide consumers with misleading information and that limitations are not always made clear in marketing materials, making it extremely difficult for consumers to understand what they are purchasing. And I want to emphasize that nothing in current law prevents employers from offering telehealth to their employees. They can and should offer telehealth as part of comprehensive health insurance. I'm very supportive of telehealth, and I think it's an important mode of healthcare delivery. The ability of Americans to access telehealth services, including in particular behavioral health services, since the COVID-19 pandemic has been a game changer. But I believe telehealth should be part of an integrated, comprehensive healthcare plan. Unfortunately, telehealth-only plans don't provide that. So I believe this bill would undermine the ACA, offer inadequate protection against medical costs, and expose American families to massive medical bills. I urge my colleagues to oppose the AINS and the underlying bill, and with that, I yield back, Mr. Chairman.
The gentleman yields back. Anyone seeking recognition to speak on the bill? Seeing none. The chair recognizes Mr. Sarbanes for, what purpose is the gentleman from Maryland seek recognition?
Move to strike the last word, speaking.
Gentleman is recognized.
Thanks very much, Mr. Chairman. I just want to echo the concerns that were just expressed by Representative Pallone. I have strong concerns as well with this bill, the Telehealth Benefits Expansion for Workers Act, which sounds good on its face, the name, but really runs contrary to what that name implies. It does not expand access to comprehensive health care coverage. Instead, it would put workers at risk of losing their access to comprehensive health, including telehealth coverage. In other words, if we want telehealth to be a strong component of the services that we offer to people out there, and certainly we do, and have coverage for it, let's build that inside of comprehensive coverage that offers benefits, protections, and consumer protections to people so that telehealth can really be a robust option for people. That's not what this bill does. As Chairman, as Ranking Member Pallone said, we all support providing patients access to telehealth services. That's been proven very, very successful for patients and providers alike during and after the pandemic. We saw a real movement in that direction as a result of the pandemic's effects on all of us. But this bill today is not the way you expand American workers' access to telehealth services. In fact, our concern is it would undermine efforts to do that. The way you expand access to quality, affordable, and comprehensive health care coverage, including telehealth, is you build in a stronger structure and foundation for it with all of the protections that we want to make sure consumers, patients have out there. At the subcommittee's recent hearing, I raised similar concerns that the plans supported by this legislation accepted, that's EX, not AC, accepted benefits plans do not provide adequate coverage and are actually a form of junk plan. We've seen these junk plans come and go, and they're really destabilizing to our insurance coverage system. That's what these would be. They would not be subject to the strong patient and consumer protections that are provided by the ACA. While the amendment offered by the majority today would make some changes to subject the plans provided under this bill to some ACA protections, it still doesn't make the plans comprehensive by any measure at all. And it may actually, in some cases, harm individuals' abilities to access the ACA tax credits that allow them to obtain quality, affordable, comprehensive coverage in the marketplace. Why would we want to do that? Why would we want to deprive some people of those very important tax credits that put comprehensive coverage within reach for them and their families? I just want to observe in closing, just last week, the Biden administration took action to crack down on certain forms of junk insurance that fail to truly protect Americans from the high cost of healthcare services when they need it most. I applaud the President for doing that, for taking that action. I wish this committee would, instead of considering legislation to continue and expand junk plans, this committee should take similar action to what the President did, strengthen Americans' access to comprehensive coverage. So for all these reasons, and again, echoing my colleague, Representative Pallone, I urge my colleagues to oppose H.R. 824. And Mr. Chairman, I yield back.
Anyone, the chair will recognize itself to strike the last word on the bill. And I was going to speak to the amendment, because the amendment does take put some changes into place that was brought up in the hearing by the Democrat side on the other side. And I want to say what this bill does, it allows employers to offer telehealth benefits to their employees who currently don't have any benefits. They're largely part-time, they're largely seasonal workers, and this group of workers are the architects of the Affordable Care Act, exempted from the employer matter, or not required. The employers aren't required to offer the full coverage, because if they meet the standards or the requirements of the Affordable Care Act, they wouldn't fit this category, because the employer would be required to offer full coverage in the employer mandate. But during the COVID-19 pandemic, the Trump administration allowed employers this flexibility to increase access to care for workers who might not have other options. And I said I'm speaking to the amendment that's going to be offered, because we did move to address, and what we moved to address, the amendment that I'm going to offer includes important protections for patients. These include protections for individuals with pre-existing conditions, ensuring that telehealth benefits are compliant with mental health parity requirements, and additionally require employers to provide, and my colleagues brought this up, a notice, and they said it's not sufficient, but the employers, when they offer this, have to provide a notice to their employees that receive these telehealth-only benefits that simply states these plans are not major medical insurance, and then these workers may still be eligible for the major medical benefits through the exchange. So if you look at the way the Affordable Care Act was designed, it had an employer mandate, but realizing there are some employees who don't work full-time, and they work seasonal, so the Affordable Care Act does not require the employer to provide any health coverage to them. So if they're exempted out, they can go to the exchanges and have access to the subsidies. And nothing in this telehealth bill, if it's so, it certainly is not intended to, and if so, we will absolutely fix it, but I don't think it's accurate to say that if they receive these telehealth benefits, this takes away any qualifications they have to apply for individual health benefits on the exchange. So we're talking about employees who do not get coverage through their employer, who are fully capable of, or have the eligibility to go to the exchange. What this allows is additional benefits that the employer may offer for them to have. It's not intended to be a substitute for major medical coverage, it's intended to be an additional benefit to major medical coverage that the employee may have access to. So simply put, this amendment increases access to care. We have taken in accounts that was brought up before by ensuring pre-existing conditions are covered, mental health parity are covered, and that people have notice that they still have access to major medical health insurance through other means provided by the Affordable Care Act. So it's not intended at all to undermine anything. It's intended to assist people who are part-time or seasonal employees, most of them struggling, and that's what this is intended for. And so I will, this is the amendment that I will offer when it comes. I just wanted to go ahead and address what's been said before. Time for the amendment. I will.
I move.
Anybody want I will yield back, and you want my time, or you mean your own time?
No, I would like my own time.
Okay, I will, no one want my time, I will yield back, and the chair will now, what purpose the gentleman from California?
I move to strike the last word.
Gentleman is recognized.
As a physician who represents a medically underserved district and have practiced in medically underserved communities, I fully support the greater utilization of telehealth services to relieve the gaps and the barriers that many communities have in accessing healthcare. Access to healthcare services is critical to overcoming those barriers to healthcare, like having to take off work or find transportation to get to a doctor's appointment, or living in areas where there is severe physician shortages, especially specialists. That said, consumer protections still matter. Making sure that patients still have coverage for the actual healthcare services that they need still matter. And unfortunately, this bill does not contain adequate consumer protections, or in other words, enough healthcare benefits that would be covered. This bill would allow employers to offer workers standalone telehealth-only insurance plans that are exempt from many of the key consumer protections, in other words, healthcare benefits required under the ACA compliant plans. They don't have to cover essential health benefits like hospitalization, emergency services, or prescription drugs. And they don't have to limit out-of-pocket costs. Yet employees who get these plans might not realize that they are buying junk plans. You know, you pay for a plan, you don't get the services that you think you're going to get. That doesn't offer comprehensive coverage. And they might not realize it until it's too late and they get a massive surprise medical bill. I said it, surprise medical bill. You see, I say that and I emphasize that because we ended surprise medical bills last Congress. You remember that? We ended it last Congress. This bill will create a whole new set of surprise medical bills that we would have to address. So for a service that they didn't realize was not covered. So these telehealth-only plans were created in the public health emergency when going to the doctor for many people with pre-existing conditions could have been very dangerous during a pandemic. They cannot be a substitute for good medical coverage, comprehensive plans. And 31 patient and consumer advocacy organizations share these same concerns as outlined in this letter they sent to the chair and ranking member of the full committee yesterday, and I ask unanimous consent to insert this letter into the record. And as my constituents continue to face many barriers to care, I will continue to fight to get quality health coverage regardless of where they live or how much money they make, including integration of telehealth into comprehensive health coverage. So I urge my colleagues to vote no on this bill and instead work towards expanding comprehensive, affordable care to our most vulnerable populations and all of Americans in our nations. With that, I yield back.
Gentleman yields back. Anyone seeking recognition for discussion on the bill? We're going to do the amendment. Are there any bipartisan amendments to the bill? Seeing none, are there any other amendments? I have Mr. Chair, well, I'm in the chair. I will recognize myself for, I have an amendment at the desk. I ask the clerk to report.
Amendment in the nature of a substitute to H.R. 824, offered by Mr. Guthrie. Strike all after the
Without
enactment
objection, the
clause.
reading of the amendment is dispensed with, and I am recognized for 5 minutes in support of the amendment. So I appreciate what everyone has said here, and we want people to have access to full coverage, and there is no intent, and this bill does not undermine, it does not offer this as an alternative to comprehensive care. If you look at the Affordable Care Act, seasonal employees and part-time employees employers were not mandated to provide this coverage, so the criticism of people in this group not getting coverage from their employer would be more towards the Affordable Care Act than what is happening here, because people in this category either don't have coverage or they go to the exchange or other opportunities. This is an additional benefit on top of comprehensive coverage, not provided by the employer, but what this employee has access to. And so I just want to say, if you say that they're getting surprise billing, they're getting other things because they don't have access to coverage through their employer, the Affordable Care Act exempted this group of people. This is what it is targeted for. And so what this amendment does, specifically the bill, we want to clarify that it has to cover pre-existing conditions, any telehealth has to, any pre-existing conditions, any telehealth provided by the employer as an additional benefit has to have mental health parity, and that they're brought forward, well, what if people think this is comprehensive coverage, that the employer has to let their employee know this is not comprehensive coverage. They're not mandated by law to provide them comprehensive coverage. That's not in the notice, but this is not comprehensive coverage. They have access to comprehensive coverage through the exchanges, and having these benefits, I think has been mischaracterized as that this can risk your eligibility on the exchanges, because there's nothing in the underlying bill. If someone can say, well, if you read the word a certain sideways or a different way and you apply this, like some of the think tanks do that come here and try to go after our legislation that we're trying to move forward, then we'll look at that language and fix it when it comes before the full committee. Because the intention is not to supplant, nor does the bill, it's not even the intention, the bill does not supplant comprehensive coverage. It gives additional coverage to employees who are not authorized legally, employers can offer their employees who are not legally required under the Affordable Care Act to provide comprehensive health insurance for their employees. The amendment does address some of the concerns moving forward. I know we addressed it in the bill, and moving forward, anyone want to see any more time? I will yield back, and the chair will recognize the gentlelady from California. Well, let me say it again. For what purpose, gentlelady from California, seek recognition?
The last word, Mr.
Gentlelady is
Chairman.
recognized.
Thank you. Telehealth, I think, is one of the, really the silver linings of the pandemic. It made it easier, faster, safer for people across the country to meet with their doctors. And I'm very proud, and I think every single member of the Energy and Commerce Committee is proud that we were all champions on the issue of telehealth. And I consider myself as one of those champions, and worked hard to pass laws to continue Medicare coverage for telehealth services. So this has, I know pre-COVID at Stanford Hospital in the heart of my congressional district, they had about 9% participation in terms of telehealth services. And when COVID hit, it kept moving up, went up to over 90%, 90%. And people were polled to see what they thought of it, and those that were the most hesitant, they became champions of telehealth as well. So, but I don't think this is about telehealth. This is an insurance policy. Anyone that thinks that the American people have deep affection and regard for insurance companies in this country really needs to revisit that notion. It simply is not the case. And if a new insurance, a form of insurance is going to be offered to people, whether they're part-time, full-time, they deserve consumer protections. This would allow these insurance policies and the standalone telehealth-only plans not to have the consumer protections that everyone deserves. And out-of-pocket costs, every single member here has heard from their constituents. It's a drumbeat across the country in terms of their complaints about out-of-pocket costs. So if there's no protection, what do you say to people? Well, we just allowed that. It's telehealth. You know what? That won't be a source of comfort to them. And there is an increasing level of insurance companies relative to rescissions. And we have to pay very, very close attention to that. So this is going to put patients at risk for high out-of-pocket costs. Can anyone guarantee here that there won't be any high out-of-pocket costs? No one is addressing that here in this legislation. And I think that's why blue chip patient organizations like the Lung Association, the American Cancer Society, and the Heart Association opposed the bill. So we're all champions of telehealth, and bravo to all of us for the work that we did on that. I think it would be wonderful to have telehealth services, but I think what has to accompany any kind of new insurance relative to health care needs to have the American people deserve consumer protection, and that's where this really falls short. And with that, Mr. Chairman, I yield back the balance of my time.
The gentlelady yields back. Any other person seeking recognition on the amendment? Seeing none. If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. You want to roll call on this amendment or the full bill? Both? The bill, okay, so we'll do the amendment and then all those opposed say nay. In the opinion of the chair, the ayes have it. Are there any further amendments offered? Seeing none, the question now occurs on forwarding H.R. 824 as amended to the full committee. A roll call has been requested. All those in favor will vote by saying aye. All those opposed will vote by saying no, and the clerk will call the roll.
Guthrie. Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshue. Miss Eshue. Miss Eshue votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Custer. Custer votes no. Kelly. Dingell votes no. Kelly. Kelly votes no. Badagan. Badagan votes no. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes no. Pallone. Excuse me, Ms. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers. Aye. Chair Rogers votes aye.
Any members not recorded? How is Mr. Latta recorded?
Mr. Latta is not recorded. Mr. Latta votes aye.
Any member not recorded? Seeing none, the clerk will report.
Chair Guthrie, on that vote, we had 16 ayes and 11 noes.
With 16 ayes and 11 nays, the amendment is agreed to. Or the bill, I'm sorry, we're on the bill. The bill is agreed to. The chair calls up H.R. 3226 and asks the clerk to report.
H.R. 3226, a bill to reauthorize the Prematurity Research Expansion and Education for Mothers Who Deliver Infants Early Act.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek to be recognized on the bill? For what purpose does the gentlelady from Iowa seek recognition?
Move to strike the last word. And
Gentlelady is
offer
recognized.
amendment. Mr. Chairman, I have an amendment at the desk.
You speak on the bill or you don't offer an amendment? Right.
Offer an amendment.
Offer an amendment. We'll offer amendment just so, anybody want to speak on the bill? Gentlelady from California is recognized.
Thank you, Mr. Chairman. Colleagues, we're going to take up many contentious issues today, but there's one I think we can all really agree on. Every baby deserves a healthy start, and swiftly reauthorizing the PREEMIE Act will help us toward that goal. Every day, 1 in 10 infants are born premature in our country, putting them and their mothers at an increased risk of complicated health problems. America's prematurity rate is one of the highest in the world, and it's leading cause of newborn deaths. Even babies born just a few weeks too soon can face serious health challenges. In 2005, I introduced the original PREEMIE Act with former Chairman Fred Upton, which was the first and remains the only law to focus solely on the prevention of preterm births. And I especially appreciate the comments that Dr. Burgess made in his opening statement, comparing the time that it was your daughter, Dr. Burgess, the birth of his daughter, and where we are today. Since it was first passed, the PREEMIE Act has helped researchers and doctors identify the causes of premature births and work to prevent them. This year's reauthorization will improve future policy by studying what could have led to the recent surge in preterm births, and how we can address this. We saw a significant 4% increase in preterm births in 2021, the highest recorded rate since 2007. The PREEMIE Act will help prevent newborn death and disability, expand research into the causes of preterm birth, and promote the development, availability, and use of evidence-based standards of care for pregnant women. I'm proud to have worked on this legislation, to have given birth to it legislatively in 2005 with our former chairman, Fred Upton, and proud of that it's on in our markup today. And I think this is something that every single member can vote for with pride. With that, I yield back, Mr. Chairman.
The gentlelady yields back. Anybody speaking reactions on the bill? Gentlelady from Illinois is recognized to strike the last word.
I'd like to strike the last word. Preterm births have continued to increase at startling rates across the country, impacting 383,000 babies each year. Premature babies tend to have more health problems or need to stay in the hospital longer than babies born on time. Some of these babies also face long-term health effects like problems that affect the brain, lungs, hearing, or vision. Due to the lack of any cures for pregnancy complications, all practitioners and parents can do is deliver and try their best to care for babies born preterm. Furthermore, each year, about 21,000 babies are stillborn, and significant disparities are seen within Black, American Indian or Alaskan Native, and Native Hawaiian and Pacific Islander populations compared to white women. We cannot sit complacently. We must act to better understand the cause of preterm birth, which is causing this shocking increase, and what we can do to prevent preterm birth to allow our moms and babies the best start at life possible. These inequities in the maternity care system have a real-world impact, where maternity and newborn care account for a large category of hospital payouts for most commercial insurers and state Medicaid programs. With Medicaid as a primary payer for 42% of births in the United States, the federal government has a major responsibility for ensuring the quality and value of maternal newborn care. That's why I'm honored to co-lead the PREEMIE Act with my colleagues, Chairwoman Eshoo, Reps. Burgess, Blunt, Rochester, Kiggins, and Miller Meeks. The PREEMIE Act will help reduce preterm birth, prevent newborn death and disabilities caused by preterm birth, expand research into the causes of preterm birth, and promote the development, availability, and uses of evidence-based standards of care for pregnant women. I encourage my colleagues to support this bill. Thank you, and I yield back.
The gentlelady yields back. Anyone seeking recognition on the bill? Seeing none on the bill, are there any bipartisan amendments to the bill? Are there any other, any other amendments? Gentlelady from Iowa is recognized.
Thank you, Mr. Chairman. I'd like to speak in favor of my amendment to H.R. 3226, which makes technical fixes to the bipartisan, bicameral.
We need the
PREEMIE
clerk to report the amendment, and then we'll, thanks.
Amendment to H.R. 3226, offered by Mrs. Miller Meeks of Iowa.
Without objection, the reading of the amendment is dispensed with, and the gentlelady from Iowa is recognized for 5 minutes in support of the amendment.
I'm proud to lead this legislation with my friends and colleagues, Representatives Eshoo, Burgess, Kiggins, Blunt, Rochester, and Kelly. As a mother and a physician, I understand the harmful health implications of preterm birth and recognize the importance of public health programs like PREEMIE, which seek to address the root causes. In fact, as a director of the Iowa Department of Public Health, I help to promote and advance these programs. In 2021, Iowa mothers gave birth to almost 3,700 preterm babies, which represented 10% of all births in the state that year. Not only do preterm births pose great health risk to the mother and the baby, but they're also very costly to our healthcare system. Over 28% of infant deaths are preterm related, and the average cost associated with preterm births in Iowa is $58,000. This legislation will provide crucial funding to address and reduce this public health epidemic, and I urge my colleagues to support my amendment and the underlying bill. I yield back.
Back. Is there further discussion on the amendment? Seeing none, all those in favor will vote. Now, the chair will now vote the amendment. The vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All opposed, nay. The ayes have it, and the amendment is agreed to. Are there any further amendments? Seeing none. Seeing none, the question now occurs on forwarding H.R. 3226 as amended to the full committee. There will be a roll call vote. All those in favor will designate by saying aye. Those opposed will say no. The clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon.
Aye.
Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo. Eshoo votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Badagan. Badagan votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Chair Rogers. Chair Rogers votes aye.
How is the gentleman from New Jersey recorded?
Mr. Pallone is not recorded. Pallone votes aye.
Anyone else seeking to answer the roll? Seeing none, the clerk will report.
Chair Guthrie, on that vote, we had 26 yeas and 0 noes.
With 26 ayes and 0 noes, the ayes have it, and the bill is agreed to. The chair calls up H.R. 3838 and asks the clerk to report.
H.R. 3838, a bill to amend Title III of the Public Health Service Act to reauthorize federal support of states in their work to save and sustain the health of
Without objection, the
mothers.
first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anyone seek to be recognized on the bill? Are there bipartisan amendments to the bill? Are there other amendments to the bill? For what purpose the gentleman from Texas seek recognition?
Thank you, Mr. Chairman. I have an amendment at the desk.
The clerk will report.
Amendment in the nature of a substitute to H.R. 3838, offered by Mr. Burgess of Texas.
Without objection, the reading of the amendment is dispensed with, and the gentleman from Texas is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. It was 2018, this committee actually did pass Jamie Herr Butler's bill that was signed into law by President Trump in that year. So it is now necessary to reauthorize, and this bill is a reauthorization. The amendment in the nature of a substitute increases the authorization amount to $108 million for each of fiscal years 2024 through 2028. The maternal mortality rate in the United States rose yet again in 2021 to over 32 deaths per 100,000 live births, compared to a rate of 23 in 2020.
Is Larry ready?
It is reported in the literature that 80% of pregnancy-related deaths are preventable, but we all know one death is too many. The Preventing Maternal Deaths Reauthorization Act for 2023 reauthorizes the assistance to states for maternal mortality review committees to better understand the burden of maternal complications and mortality through research, education, best practices, and prevention efforts. Through these state maternal mortality review committees, this body was able to discover that 53% of pregnancy-related deaths happen between 7 days and 1 year, leading to the critical extension of postpartum coverage for Medicaid beneficiaries. This amendment increases the authorization amount to be consistent with the amount provided in fiscal year 2023 for CDC Safe Motherhood and Infant Health programs. So this amendment was a result of technical assistance from the agencies, and I urge members to support the amendment in the nature of a substitute, support the underlying bill on the subsequent vote, and I'll yield back.
Gentleman yields back. Is there any other discussion on the amendment? The lady, for what purpose the gentlelady from Illinois seek recognition? Gentlelady is recognized.
One of the most glaring inequities in our country is the disparities in maternal health outcomes. Frustratingly, the number of women dying of maternal health causes continue to rise. Over 1,000 women died in 2021 due to maternal complications compared to 861 in 2020 and 754 women in 2019. What's even worse is that the color of your skin determines whether or not you are more likely to become a maternal mortality statistic. Black women are nearly 3 times more likely to die from pregnancy-related causes as non-Hispanic white women. Indigenous women are more than twice as likely to die from pregnancy-related causes as non-Hispanic white women. This is unacceptable. We are all aware of the problem, but I'm glad that we are here to discuss a promising solution for addressing the maternal health mortality crisis. The Preventing Maternal Deaths Act would strengthen and expand federal support for maternal mortality review committees, or MMRCs. State-fashioned MMRCs are tasked with identifying maternal deaths, analyzing the factors that contributed to those deaths, and translating the lessons into policy. I would like to thank my colleague, Rep. Burgess, for including a piece of my mama's bill in the Preventing Maternal Death Act, and I will continue to lock arms with anyone who wants to make this country the safest place to give birth. I encourage my colleagues to support this bill. Thank you, and I yield back.
Thank you. The gentlelady yields back. Anyone seeking recognition? The gentleman from, what person, gentleman from Georgia seek recognition?
Mr. Chairman, I move strike the last word.
Gentleman's recognized.
Mr. Chairman, I'm pleased to see the Preventing Maternal Deaths Act, which I am co-leading with Dr. Burgess, is included in this markup. Our nation's maternal mortality crisis, which severely impacts Georgians, which baffles me, is alarming and trending in the wrong direction. In 2021, the maternal mortality rate increased in the U.S. to almost 33 deaths per 100,000 live births, compared to a rate of 20 in 2019. For women of color and people living in rural communities, those numbers are much higher. In Georgia, maternal death rates have doubled since 1999. This is despicable, it's unacceptable, and we have to do something about it. The U.S. is trending in the wrong direction, and we need to understand why moms are dying despite us spending $4.2 trillion on health care every year. As a father, a grandfather, and a healthcare professional, I believe that we can and we must do better. It's time for this to become a national priority, which is why I'm proud to be co-leading the Preventing Maternal Deaths Act with Dr. Burgess. This legislation will ensure continued support for the critically important work that the state maternal mortality review committees have in addressing the maternal mortality crisis. State maternal mortality review committees are crucial to collecting data so that each state can form a plan to address maternal health issues impacting their community. This bipartisan bill is an important step towards ending the maternal mortality crisis in the U.S. We value women, we value life, and this bipartisan bill prioritizes both. I'd like to thank Dr. Burgess for working with me on this important issue, and I would like to ask all my colleagues on this committee to support this legislation. Thank you, Mr. Chairman, and I yield back.
The gentleman yields back. Are there any further discussion on the amendment? Seeing none, adopt the amendment. So there's no further discussion on the amendment. The vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All opposed, nay. The ayes have it, and the amendment is agreed to. The question now occurs on forward in H.R. 3838 as amended to the full committee, and the clerk shall call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter.
Aye.
Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo. Eshoo votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Barragan. Barragan votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye. Mr. Griffith votes aye.
Any other members that wish to have their vote recorded? Seeing none, the clerk will call the roll.
Chair, on that vote, we have 28 yeas and 0 nays.
The ayes have it, and the bill is agreed to. Here, the chair calls up H.R. 3843 and asks the clerk to report.
H.R. 3843, to amend Title III of the Public Health...
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any time. So ordered. Does anyone seek recognition on the bill? For what purpose does the gentlelady from Illinois seek recognition?
I'd like to strike the last word.
Gentlelady is recognized for 5 minutes to strike the last word.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding today's markup and including H.R. 3843, the Action for Dental Health Act, that I'm proud to co-lead with Rep. Mike Simpson. Oral health is a critical part of our overall health, and preventative dental care can reduce costs for families and help so many people live better lives. Oral disease is a common risk factor with chronic diseases such as cardiovascular diseases, cancer, diabetes, and respiratory diseases. Additionally, oral health affects our ability to eat, speak, smile, and show emotions. Oral health also affects a person's self-esteem, school performance, and attendance at work or school. Regular preventive dental care is essential for good oral health, so one can find problems earlier when they are easier to treat. Unfortunately, many don't get the care they need. More people are unable to afford dental care than any other types of health care. Children, low-income Americans, minorities, and the elderly are especially at risk for having limited dental care and poor oral health outcomes. We must address the barriers to oral health care services. The more we can address early diagnosis, intervention, and preventative dental treatments, the better off our patients and our healthcare system will be. I encourage my colleagues to support this bill. Thank you, and I yield back.
Lady yields back. Does anyone else seek recognition? Seeing none, are there any bipartisan amendments to the bill? Are there any other amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 3843 to the full committee. Clerk will call the roll.
Chair Guthrie. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter.
Aye.
Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo. Eshoo votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Badagan. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
How is Mr. Griffith recorded?
Mr. Griffith is not recorded. Griffith votes aye.
How is Mr. Guthrie recorded?
Mr. Guthrie votes aye.
Any other members wish to be recorded? Seeing none, the ayes have it. The bill is agreed to. Actually, report the vote first.
Dr. Ruiz?
Mr. Ruiz is not recorded.
Dr. Ruiz, okay.
Ruiz votes aye.
At the last minute, Dr. Ruiz, yes, got it. Okay, the clerk will call the roll. We'll report the vote.
Chair, on that vote, there were 27 ayes and 0 noes.
The ayes have it. The bill is agreed to. Chair will now call up H.R. 3884 and ask the clerk to report.
H.R. 3884, to amend Title 11 of the Public Health Service Act to reauthorize the program providing for sickle cell disease and other heritable blood disorders research, surveillance, prevention.
Without objection, the first reading of the bill is dispensed with. The bill will be open to amendment at any point. So ordered. Does anyone seek to be recognized on the bill? Anyone? Are there any bipartisan amendments to the bill? Are there any amendments to the bill?
Mr. Chairman, I have an amendment.
The gentleman from Texas is recognized to introduce his amendment.
I have an amendment at the desk.
Clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 3884, offered by Mr. Burgess.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes to support the amendment.
Thank you, Mr. Chairman. This amendment, the nature of a substitute to H.R. 3884, will increase the authorization level to the last enacted appropriated level of $8,205,000 for each of the fiscal years 2024 through 2028. Speaking to the underlying bill, the 70,000 to 100,000 Americans who have sickle cell disease. It's the most common inherited blood disorder. The disease, which is present in individuals at birth, causes the production of an abnormal hemoglobin, which causes their red blood cells to take on a typical sickling manifestation. We cannot prevent sickle cell disease, but we can prevent the complications of the condition. Since the landscape of how we treat and manage sickle cell disease continues to evolve, we need to prioritize funding for research and investment into better treatment options for individuals who are suffering. In addition to the increase in authorization level, this amendment would make technical changes to allow for admittance into a contract grant or cooperative agreement with an entity to serve as a national coordinating center for the demonstration program under the legislation. Currently, the National Coordinating Centers operates as a contract under existing statute. Having the flexibility to use a grant mechanism would allow the National Coordinating Center to provide assistance to grantees and communities. So I would urge support of the amendment as well as the underlying legislation, and I'll yield back.
Gentleman yields back. Is there discussion on the amendment? Recognize the gentleman from Georgia, Mr. Carter.
Mr. Chairman, I move to strike last word.
Gentleman's recognized.
Mr. Chairman, I'm pleased to support the Sickle Cell Disease Reauthorization Act, which I'm co-leading with Dr. Burgess. As a pharmacist for over 4 decades, I've seen firsthand the heartbreaking toll sickle cell disease takes on patients and their families. Unfortunately, Georgia is home to one of the largest sickle cell disease populations in the country, which is why it's so important that we act quickly to save lives and prevent further pain. The bill before us today reauthorizes critical sickle cell disease programs so that patients have the support and resources they need to battle this terrible disease. I've always and will continue to put patients first, and I believe these programs do just that. I encourage my colleagues to support H.R. 3884, the Sickle Cell Disease Reauthorization Act. Thank you, Mr. Chairman, and I yield back.
Gentleman yields back. Is there any other member wishing to seek recognition on the amendment? If there's no further discussion, the vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All those opposed? The ayes have it, and the amendment is agreed to. Question now occurs on forwarding H.R. 3884 as amended to the full committee. The clerk will call the roll.
Chair Guthrie. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter.
Aye.
Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshue. Ms. Eshue. Eshue votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Badagan. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
How's Mr. Griffith recorded?
Mr. Griffith is not recorded. Mr. Griffith votes aye.
How's Mr. Guthrie recorded?
Chair Guthrie votes aye.
How's Mr. Crenshaw recorded?
Mr. Crenshaw is not recorded. Crenshaw votes aye.
Any other members wishing to record their vote? Seeing none, the clerk will report the result. Doesn't say.
Chair, on that vote, we had 28 yeas and 0 noes.
The ayes have it, and the bill is agreed to. The chair now calls up H.R. 3821 and asks the clerk to report.
H.R. 3821, to reauthorize the Firefighter Cancer Registry Act of 2018.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? The gentleman from New Jersey, Mr. Pallone, is recognized. 5 minutes.
Thank you, Mr. Chairman. This legislation would reauthorize the National Firefighter Cancer Registry that has been implemented by CDC to identify trends, risk factors, and other important information that may help provide greater data on the impacts of firefighting on cancer risk and exposure and help guide prevention, detection, and treatment efforts in the future. I'm pleased we're considering this bill today, and I want to thank my New Jersey delegation and colleague, Representative Pasquale, for sponsoring this important bill. I'm also glad we were able to hear from a representative from the International Association of Firefighters during our hearing on the bill, who testified on the importance of the registry and reauthorizing it in order to fully understand the risks that firefighters undertake and how to identify important trends in the future. This bill is supported by the International Association of Fire Chiefs, the National Volunteer Fire Council, and National Fallen Firefighters Foundation, among others, and I urge my colleagues to support this important bill and yield back, Mr. Chairman.
The gentleman yields back. Anyone else seeking recognition to speak on the bill? Are there any bipartisan amendments to the bill? Are there any other amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 3821 to the full committee. All those in favor say aye.
Aye.
Aye. All those opposed say no. A roll call vote has been requested, so the clerk will call the roll.
Chair Guthrie. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon.
Aye.
Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter.
Aye.
Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo. Eshoo. Sarbanes. Sarbanes votes aye. Cardenas. Mr. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Buttigan. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
How's Mr. Griffith recorded?
Mr. Griffith is not recorded. Mr. Griffith votes
How's
aye.
Mr. Guthrie recorded?
Guthrie votes aye.
Any other members wishing to be recorded? Seeing none, the ayes have it, and the bill. The chair calls up H.R. 2365 and asks the clerk to report. Oh, you need to announce the result of the vote. Sorry about that.
Yes, sir. Chair, on that vote, we had 28 ayes and 0 noes.
The ayes have it, and the bill is agreed to and referred to the full committee. The chair now calls up H.R. 2365 and asks the clerk to report.
H.R. 2365, a bill to direct the Secretary of Health and Human Services to carry out a national project to prevent and cure Parkinson's, to be known as the National Parkinson
Without objection, the
Project.
first reading of the bill is dispensed with, and the bill will be open to amendment at any point so ordered. Does anyone seek recognition on the bill? The gentleman from Florida, Mr. Bilirakis,
Thank
is
you, Mr.
recognized.
Chairman. I appreciate it very much. I move to strike the last one.
Gentleman's recognized.
I'm so grateful to have the National Plan to End Parkinson's Act, H.R. 2365, included in today's markup. I really appreciate it. I want to thank the full committee chair, the ranking member, and of course, the chair of the subcommittee, you, Doctor, as well, and of course, my friend, the ranking member of the subcommittee. This no-cost legislation will, for the first time, unite the federal government in a mission to cure and prevent Parkinson's, alleviate financial and health burdens on American families, and reduce government spending over time. I've been proud to work with Mr. Tonko on this bill for almost a year. It's time that we take proactive measures, ladies and gentlemen, and the National Plan to End Parkinson's Act will do just that by creating an advisory council comprising members of federal agencies that support research, care, and services for Parkinson's disease, plus patients, care, and again, care partners. They'll be part of it, researchers, of course, clinicians, and other non-federal experts. It is time for a national effort and strategy to support research and development recommendations with the goal of treating and curing Parkinson's disease once and for all. We must end Parkinson's disease, as I said. The National Plan to End Parkinson's Act is the best way to start. And by the way, this is supported by the Michael J. Fox Foundation as well. This is it's very personal to me, Mr. Chairman. I understand the tolls that the family, what they face on a daily basis, as I just recently lost my brother, Dr. Emmanuel Bilirakis, a great physician and a wonderful, wonderful human being. He battled Parkinson's disease for many years prior to his passing. I also have other family members who have Parkinson's. This disease impacts patients and their families, I want to emphasize that, physically, emotionally, and financially. The lack of treatment options leave patients, families, and the American taxpayer in a terrible predicament. We have to solve this. It is time to act. I know there's more work to be done, but I look forward to working with all of us, especially Congressman Tonko, who's the co-sponsor of this bill, to have this legislation ready for full committee markup. And with that, I yield back.
The gentleman
Would the
yield?
gentleman yield?
Yes.
I was gonna, did you,
Yes.
I just wanted to say,
Okay.
from the committee's perspective as the chair, that our thoughts and prayers are with you. I know your father was on this committee and beloved by so many people that knew him prior to your service here, and our thoughts and prayers are with you. I yield back to the gentleman.
Thank you.
Would the
Thank you. I
gentleman
yield to
yield?
the gentlelady.
I want to thank the gentleman for offering the legislation, and I'd like to make a suggestion that you name the bill after your brother.
We need to work on that between now and full committee then.
Thank you so very much.
Fitting tribute.
I yield back.
Gentleman yields back. Is there any discussion on the bill? Any further discussion on the bill? Are there any amendments to the bill? Seeing none, we'll move to the passage of the bill. This will be a voice vote. We'll do a voice vote unless there's no request for a roll call. This will be a voice vote. All those in favor for the bill, the question now occurs on forwarding H.R. 2365 as to the full committee, not as amended, to the full committee. All those in favor will say aye. Aye. All opposed will say no. The ayes have it, and the bill is agreed to. The chair calls up H.R. Congratulations, our good friend from Florida. The chair calls up H.R. 3391 and asks the clerk to report.
H.R. 3391, a bill to extend the Gabriella Miller Kids First Pediatric Research Program at the National Institutes of Health and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill?
Mr. Chairman? Oh,
Gentleman from Florida on the bill, or I know you have an
well, actually on the amendment.
Okay, anybody on the bill? Seeing none, does anyone have are there any bipartisan amendments to the bill? Are there other amendments to the bill?
Yes.
The gentleman from, what purpose, gentleman from Florida?
It's
seek
a
recognition?
bipartisan amendment, but I have an amendment at the desk.
The clerk will report the amendment.
Amendment in the nature of a substitute to H.R. 3391, offered by Mr. Bilirakis of Florida.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman, I appreciate it. I'm very excited to put forth the aims for the Gabriella Miller Kids First Act 2.0, H.R. 3391, a piece of legislation I co-lead with Representative Wexton, Representative Cole, and Representative Dingell. I want to thank them all for their leadership on this particular bill, but the entire committee has worked on this issue, and we appreciate it so much. This bill will reauthorize the important pediatric research initiative at the NIH, where they are working to develop a large-scale data resource to help researchers uncover new insights into the biology of childhood cancer and structural birth defects, including the discovery of shared genetic pathways between these disorders. This work is imperative, and this strong bipartisan piece of legislation will help transform the landscape of pediatric cancer. We have seen improvements in survival rates, but still, thousands of children are lost to cancer each year, and many more encounter life-threatening complications related to harsh chemotherapies. Sadly, cancer is the single leading cause of death of children in the United States, of any disease. More than 15,000 children are diagnosed annually, unfortunately. We still have a long way to go to understand and improve survival rates for these patients, our children who are diagnosed with brain tumors, prevalent cancers, and other pediatric rare conditions. I know we've made a lot of progress, but a long way to go. Children have significantly fewer treatment options than adults, and oftentimes must rely on treatment regimens developed for adults. That's unacceptable, because pediatric-specific treatments simply do not exist for many pediatric cancers and rare diseases. This foundational research is critical for facilitating a better understanding of pediatric cancers and other pediatric conditions, and holds the promise for the development of better treatments and possible cures. I still have some time. So as a longtime advocate for children and rare disease patients, I'm proud to join my colleagues in pushing for the continuation of the critical research, really crucial research, and I want to thank Ellen Miller, Gabriella's mom, who has bravely continued her advocacy for this noble cause. Simply put, we must continue to allow this program to conduct the critical research needed to improve outcomes and accelerate treatments and cures. I look forward to seeing this bill move through subcommittee, and I urge passage of the aims and the underlying bill, and I don't know if there's anyone that wants my time, but you can sure have it. All right. Now I'll yield back the balance of my time. Thank you.
Gentleman yields back. Is there discussion of the amendment? The gentlelady from Michigan, what purpose do you seek to be recognized?
Mr. Chair, I move to strike the last word to speak.
Gentlelady is recognized.
Thank you, Mr. Chairman. A cancer diagnosis imparts unimaginable physical, emotional, and financial strains that no one should have to endure, let alone a child who should have a full life of opportunities ahead of them. It's critical we confront pediatric cancer with the urgency it requires, and this begins with supporting efforts that spur new research endeavors that inspire new treatments and cures. I am proud to join Representatives Wexton, Bilirakis, and Cole in introducing the Gabriella Miller's Kids First Research Act 2.0, which will reauthorize the Gabriella Miller Kids First Pediatric Research Program at the NIH through fiscal year 2028. I have to admit I'm disappointed this AIMS is only a straight reauthorization of the program, I really do believe this program deserves increased funding to expand upon its important mission, but we absolutely cannot allow this program to lapse at the end of this year. It's critical that we reauthorize it without delay. The bill was named after Gabriella Miller, a childhood cancer advocate who lost her battle with DIPG when she was 10 years old. For those who may not know, DIPG is a terrible, terrible pediatric brain tumor that's almost always fatal. The average overall survivor for children diagnosed is less than 1 year. I unfortunately have known and worked with families, closely with families, who have struggled with the horrors of this, like the Carr family, who sadly lost young Chad Carr at the age of 5, the grandchild of the University of Michigan football coach, and Jack Demeter, a young boy who lost his battle with DIPG at the age of 3. I've lived with these families through the beginning to the end. With this legislation, we can drive life-saving research of treatments and cures for childhood cancer forward. I urge all of my colleagues to support the aims. Thank you, Mr. Chair, and I yield back.
Thank you. The gentlelady yields back. Any further discussion on the amendment? Are there any amendments to the amendment nature of a substitute? Seeing none, the vote occurs on the amendment. All those in favor this will be a voice vote. So all those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the amendment is agreed to. There's a request for a roll call vote. The question now occurs on forwarding H.R. 3391 as amended to the full committee, and the clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter.
Aye.
Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshue. Eshue votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Kelly. Kelly votes aye. Buttigan. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
Is there anyone seeking to be recognized to vote? Seeing no one left to call the roll, we'll ask the clerk to report.
Chair Guthrie, on that vote, there were 27 yeas and 0 noes.
With 27 yeas and 0 nays, the bill is agreed to. The chair calls up H.R. 4421 and asks the clerk to report.
H.R. 4421, a bill to reauthorize certain programs under the Public Health Service Act with respect to public health security and all hazards preparedness.
Without objection, the
response.
first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek to be recognized on the bill?
Mr. Chairman,
For what purpose, gentleman from Ohio, say
strike
recognized?
the last word.
Gentleman is recognized.
Thank you, Mr. Chairman. Today, this subcommittee is moving in the right direction and appropriately doing our jobs to reauthorize the Pandemic and All Hazards Preparedness Act. I'm proud that my bipartisan legislation, the Healing Response Act, of which I'm co-leading with my colleague, the gentlelady from Illinois' 2nd Congressional District, is included in PAPA's reauthorization. This important legislation aims to help rapidly produce medical countermeasures in the event of a public health emergency. In our effort to advance this legislation, I understand that some of my colleagues have expressed concerns surrounding shortages of our nation's drug supplies. Please know that I share these concerns as well. Sadly, I've heard from hospitals and countless constituents who have had to change their cancer treatments due to these shortages. This should not be happening in the United States. We owe it to those facing such difficulties to help alleviate those burdens. I'm pleased that our chair of our full committee, the gentlelady from Washington, announced last night that we are currently working on a discussion draft surrounding drug shortages. I look forward to working with my colleagues on both sides of the aisle to find a solution. With that said, PAPA is not an appropriate vehicle for drug shortage policy. I've been a member of this committee for the last 2 reauthorizations and appreciate this committee and the work that the gentlelady from California's 16th District has done in her bipartisanship and leadership on this issue. Today, we must move forward. It is our duty to make sure PAPA is reauthorized within the scope and in a timely fashion. That is why I'll be voting aye and encourage my colleagues to do the same. Again, I want to thank the gentleman from North Carolina for his leadership and hard work on this reauthorization. Mr. Chairman, I yield back the balance of my time.
Gentleman yields back. Anyone seeking recognition? The gentlelady from California is, for what purpose does the gentlelady from California seek recognition?
Seek recognition, Mr. Chairman, to strike the last word and speak
Gentlelady's
on
recognized.
HR 4421. Thank you. Colleagues, I spoke in my opening statement this morning about how 8 months ago I entered into, in good faith, to draft a bipartisan PAPA reauthorization. Today, I'm frustrated. Instead of negotiating a set of bipartisan policy priorities, the majority is set on locking our nation's public health programs into 5 years of underfunding. Beyond low funding levels, the main substantive policy changes in this policy will tie the hands of our preparedness professionals and hinder decision-making. First, the bill will require BARDA to issue contracts for a minimum of 5 years. This will keep BARDA from being able to nimbly respond or change course during an emergency and will waste taxpayer money. I know something about BARDA. It was my legislation that created it, and it has scored A's across the board because of the way it not only established, but its nimbleness in and effectiveness with the dollars that we invest in it. Secondly, the bill will provide industry stakeholders with unprecedented influence on the public health emergency medical countermeasure enterprise, creating more bureaucracy and confusion. COVID showed us that what we actually need is faster, streamlined decision-making during an emergency rather than more cooks in the kitchen. Additionally, and this is another very deep concern, this policy seems unworkable since it would require giving an industry representative who is not a government employee access to classified national security information as well as proprietary information from other businesses. According to Pew surveys over the past year, most Americans agree that the U.S. was unprepared in its response to COVID. I'm one of them. I've spoken about how sick I felt, and I think we all did, when we watched nurses wearing black plastic garbage bags wrapped around themselves as PPE, or as I tried to help my local hospitals find working ventilators. I continue to feel sick as I pick up the newspaper each day, hear from the hospitals in my district, and parents of children who have cancer, and read about them having their cancer treatments delayed due to drug shortages. We were unprepared for COVID. We've had hearings in this committee describing the mistakes and the errors that led to our nation losing more than 1 million lives to the virus. This bill, in my view, ignores, and many professionals, ignores those lessons and is essentially choosing unpreparedness. It chooses to fund the strategic national stockpile at less than half of what experts say is needed to protect our country. It chooses to underfund our hospital preparedness grants so that if a mass casualty event were to occur, what we'll have is chaos and overcrowding. It chooses to not replicate the success of Operation Warp Speed and does not give ASPR the contract authority it says it needs to continue that progress. So, everyone, you've heard what lane I'm in. I'm still holding out some hope that we can come together on making this a bipartisan bill, because we have some time between now and the full committee markup. But these are serious shortcomings. These are serious shortcomings, and as Mr. Hudson said, count me in. My hand is open, but we can't, the issues that I'm raising, I don't believe can really be ignored. That's why I'm speaking out. That's why I'm, obviously, my upset is deep and broad, and I wish the case were otherwise. With that, I yield back, Mr. Chairman.
Gentlelady yields back. Anyone seeking recognition on the bill? Mr. Hudson. Mr. Hudson is recognized. What purpose does Mr. Hudson seek recognition?
Strike the last word.
Oh, Mr. Johnson?
Johnson.
Mr. Johnson, okay. What purpose does Mr. Johnson seek recognition?
Mr. Chairman, I seek to strike the last word.
Gentleman is recognized.
Thank you, Chairman Guthrie. H.R. 4421, the Preparing for All Hazards and Pathogens Reauthorization, is vital to our emergency health care response. I'm very proud of the bipartisan work that Rep. Shire and I have done on the Doctors at the Ready Act, which is included in this legislation. This will provide the National Disaster Medical System, or NDMS, with the flexibility and authority to ensure that they are properly staffed in case of an emergency. We can't effectively manage a healthcare crisis without the proper medical professionals on the ground, saving lives. This legislation makes sure that NDMS continues to be able to do just that. Thank you to Representative Schreier for working with me on this, and I urge all of my colleagues to support this reauthorization. Thanks, Mr. Chairman, and I yield back.
Gentleman yields back. Is anyone seeking recognition? The gentleman from New Jersey, what purpose do you seek recognition?
Strike the last word.
Gentleman is recognized.
Thank you, Mr. Chairman. I'm speaking in opposition to H.R. 4421. Mr. Chairman, the bill in front of us today will leave us unprepared for the next public health emergency and is not a serious attempt to reauthorize critical programs. When negotiations on PAPA reauthorization began early this year, we all agreed that it was important to reauthorize expiring provisions on time. The reason why we write expiration dates into law is to ensure that the committee reviews how programs are working before allowing them to continue and offer new ideas that can help our preparedness and response going forward. In this case, Democrats put forward several new policy ideas to help us prepare for the next public health emergency. Ranking Member Eshoo and Representative Hudson also requested feedback from stakeholders and received hundreds of responses. One of the most common responses we got is that RFI is that we should update funding authorization levels to be realistic about how much it costs to prepare for a public health emergency. Congress spent trillions of dollars responding to COVID-19 because we were unprepared in a number of areas. Now, with our first opportunity to update these authorization levels, we're leaving funding flat, with some programs at levels that were set before COVID-19. We also heard from the administration on a number of important policies public health experts like the Assistant Secretary for Preparedness and Response believe will make us more prepared in the future. Unfortunately, these policies, like stronger workforce policies and enhanced contracting and construction authorities, are also not included in the bill. Democrats have also offered solutions to address drug shortages and other supply chain vulnerabilities. Every member of this committee heard from constituents during the height of the COVID pandemic about a shortage of medication, whether that was antibiotics, pain relievers, or albuterol inhalers. These problems have continued to this day, and they've gotten worse. And as we heard at our PAPA hearing, many patients throughout the country are facing rationed access to chemotherapy drugs and are being told they may not receive their treatment on time, if at all. Democrats have put forward policies to help FDA address these drug shortages through prevention and mitigation, yet the majority refused to even have a conversation with us about these bills. Similarly, we all remember the struggle to ensure that hospitals had access to ventilators and common medical equipment. Medical devices continue to face shortages, including an ongoing shortage of tourniquets used in surgery. Representative Castor has offered legislation to improve our knowledge of these shortages to help FDA prevent them from going forward. We also heard Commissioner Califf explain to us once again the risk we're taking by not granting FDA the authority to recall dangerous drugs. I've heard from many of my colleagues that they just assumed that FDA had this power already. However, during the pandemic, some drug manufacturers based overseas with dangerous contaminated hand sanitizer took over a month to pull their products from the shelf after FDA asked them to do so voluntarily. In that time, these products were sitting out for purchase, putting children at risk of serious harm, and yet Republicans are unwilling to discuss fixing this glaring issue. I've heard my Republican colleagues try to explain that these policies are outside the scope of PAPA, but that's not true. The original PAPA legislation in 2006 required FDA to establish a team of experts to start work to help prevent or alleviate drug shortages, and every PAPA reauthorization since then has included FDA provisions. This bill before us, in my opinion, is an outlier, and I truly do not understand why my Republican colleagues are so afraid to have a conversation about how FDA can do more to address vulnerabilities in our supply chain. Why are we protecting drug companies operating in China who do not want American patients to know that their drugs are being made overseas? Maybe my Republican colleagues are beholden to the far right wing of their party, who vote against every public health measure that comes before them. Regardless of the reason, it's a disservice to patients across the country that Republicans have refused to even engage on this issue. Now, the failures of this legislation are reason enough to vote against them. But this bill goes further down a partisan path, including by potentially allowing big corporations to weigh in on the public health strategy developed by HHS through a new private advisory committee at the FEMC and by tying the hands of contractors at BARDA. It's a shame we're considering this partisan bill today, as we easily could have come together on a much more successful package had Republicans agreed to consider just some of the priorities Democrats were bringing to the table. Instead, we'll vote on this bill today, which is unlikely to successfully pass the House, with the far right continuing to jam the floor. It's happening with NDAA. That had a bipartisan consensus in committee, but is now being torpedoed by Republican extremists on the House floor. And it's going to happen again with PAPA unless my Republican colleagues accept that they will not be able to pass good policy while catering to the extremist wing of the party. With that, Mr. Chairman, I yield back.
The gentleman yields back. Anyone seeking recognition? Mr. Hudson, what purpose do you seek recognition?
Strike the last word.
The gentleman from North Carolina is recognized. 5 minutes.
Thank you, Mr. Chairman. As you all know, my colleagues and I have been preparing for this legislation for years now. We've received hundreds of pages of information, feedback from response to our request for information. We've had countless discussions, meetings, phone calls, briefings, hearings, and now we're reaching the final steps here in the committee. Unfortunately, partisan politics that have nothing to do with PAPA threaten to derail this process. And, you know, I appreciate the comments from my colleague, Ms. Eshoo. I think she's expressed some legitimate concerns here today. But after years of working on this, today is the first time I've heard her raise some of those specific issues. For example, the question about BARDA and the 5-year contracts. I think that's something we ought to talk about. But what we heard from industry is if we want them to invest the huge amounts of money you've got to invest to produce PPE, to produce medical countermeasures, it takes a huge investment financially. And if you don't have a long-term contract, at least a 5-year contract, then it's hard to get the resources to make those investments. It's hard to make the business case. And so it's crucial that we have these long-term contracts. But I'm happy to talk about some of the concerns you have about whether that ties the hands of BARDA to make moves that may be necessary within that 5-year window. Another concern that was raised was given the private sector access to classified information. I'm happy to have a discussion about that, but DOD does that every day. I represent Fort Bragg, Fort Liberty, the epicenter of the universe. We have contractors, tens of thousands of contractors that work on that base that have access to classified information. Maybe not that many have access, but the thousands have access, and that's workable. I think this is something we can work through. The issue that was raised about SNS funding is not enough. I agree. I'd like to increase the funding. I'd love to work with you on that. And I would love to hear your ideas of some areas that aren't as important that we can cut to comply with House rules to offset the expense of increasing funding. So these are all things that can be overcome by talking. We've spent the last 3 weeks talking about the timing on addressing drug shortages, which is something that we've said is a priority. But let me also talk about the things that are in the bill. I mean, throughout this process and in this legislation, we've included a number of bipartisan measures. Permitting ASPR to enter into contracts with clinical labs, critically important. Pilot programs for state stockpiles. Plans for development and distribution of testing capacity during a public health emergency. Disease X programs to anticipate future pandemics. Reviews and reports of effectiveness of countermeasures. Military and civilian partnerships for trauma grants. And eliminating the sunset for appointments to the National Disaster Medical System. I've been proud to see the hard bipartisan work that's gone into these bills, and I would love to continue this conversation and continue in a bipartisan fashion going forward, but it takes two partners. I've had my arms extended. I've offered opportunities to have these conversations. I continue to make that offer. I want this to be a bipartisan bill. I want us to move forward in a bipartisan way before we get to full committee markup. As I mentioned in my opening statement, if we do not reauthorize and build on these programs now, we will be tying the hands of the experts who have the knowledge to respond successfully to future public health emergency. And there will be a future emergency. We don't know when it's going to be, but it is our obligation to the American people to put in place the lessons we've learned from the last pandemic so that we are better prepared to prepare for the next one. Something else that's included in the base text of this language deals with the FEMC Advisory Committee. The goal of the Advisory Committee is to improve the communication between these agencies and our industry partners to ensure that our nation is receiving the most efficient and effective response efforts and treatments. I think this is vitally important. This concept was reiterated in our RFI responses dozens of times. Unfortunately, the bipartisan work of PAPA has been drowned out, and by Democrats claiming that Republicans don't want to address drug shortages. Now, I think our chair, Kathy Morris Rogers, made it very clear that this is a priority for her. She's laid out a path and a plan through a discussion draft that she'll be releasing. And despite the partisan attacks, we encourage our colleagues to join us in this process. Let's make it a bipartisan process. We believe that this shortage deserves the attention, the time, and this well-thought-out plan from Kathy Morris Rogers. And we hope that our Democrat colleagues will join us in this because we agree this is a huge problem that needs to be addressed. And it's not just FDA. We think the problem is much broader, and we think we also have to address the underlying economic issues. So, again, I commit to working with my colleagues, and I look forward to continuing this discussion. And with that, I yield back.
Gentleman yields back. Anyone seeking recognition on the bill? The gentleman from Maryland, what purpose you seek recognition?
Move to strike the last word.
Mr. Sarbanes recognized for 5 minutes.
Yeah, I just had a couple of questions for council, if I might, just to clarify some things and get them on the record. Section 106 of the bill addresses the strategic national stockpile, and in several places it amends language by striking, quote, "the secretary in collaboration with the assistant secretary for preparedness and response," end quote. So it strikes that language and it changes it to, quote, "the secretary acting through the assistant secretary for preparedness and response," end quote. Specifically, the changes in 106A1A, that starts at the bottom of page 9, lines 23 through page 10, line 9, and then 106A1C, which is page 10, line 15 through page 11, line 2. So the question is this: what does the language, "the secretary acting through the assistant secretary for preparedness and response," mean?
Thank you for the question. My understanding is that they're working with the other secretaries. Is there? That is
Well,
what the text reads to me, if you would like to.
I think, as I'm reading it, it would mean that the particular authority or responsibility is being shifted from the secretary and then delegated to the assistant secretary.
The gentleman would yield,
for
I'd be happy to
preparedness.
try to answer that.
Well, I'm asking, I just want to get council's perspective.
If you'd like to ask the person who wrote the bill, I'd be happy to answer.
Okay, is that what it means?
What we're doing is clarifying, because a change was made previously to move the stockpile from CDC to ASPR. And so this language is just tightening that up to make it clear that the intent is that ASPR directs SNS.
Okay, so that would mean, counsel, then, that the particular authority or responsibility is being shifted, in this instance, from the secretary and then delegated to, as I understand what was just said, delegated to the assistant secretary for preparedness and response.
Delegated to ASPR, correct? That's what the text
Yeah.
says. Thank you.
And so then the ASPR, the assistant secretary, will have that authority to take certain actions that previously were reserved for the secretary. Is that correct?
ASPR has this.
Yeah, would
authority.
have that authority.
Is that your question?
Yes.
That's my understanding of the
Okay.
text, yes.
And there's some additional provisions that are being inserted that also include similar language. For example, it appears twice on page 17, lines 7 through 17, which I guess that's the same situation there, so that, again, ASPR, the assistant secretary, will be the one responsible for the duties that are prescribed in the statute.
Yes, my understanding is that it effectuates the policy currently as ASPR managing the stockpile.
Okay.
Does that answer your question?
Yeah, so in the parts of the bill where we see that language, that means the ASPR would have the authority, responsibility to take those actions without the need for additional action by the secretary.
My understanding is that currently, this is current law, and this is a clarification of ASPR's current responsibilities.
But the
Under-
ASPR would have that authority to take those actions, given this language, the acting through language, without the need for additional action by the secretary, because it's a delegated authority to ASPR. Is that correct? Yeah.
That is my understanding.
Okay. Now, the reason I'm asking you all these questions is because the same language, this acting through language, appears in the Public Health Service Act as amended by 21st Century Cures to give the director of the NIH authority to appoint directors of the NIH centers and institutes. But the majority of Republicans have been going around huffing and puffing and investigating on that topic, suggesting that the director of NIH doesn't have that authority when that acting through language is clearly in that statute as well. So they've ignored the portion of the statute that says that the secretary makes such appointments by, quote, acting through the director. So I wanted to be sure we all understood how this language operates, what it means before we are introducing in this bill the same language here and creating any more confusion on that issue. So I appreciate you clarifying the language for me here and what it means so that we can understand that going forward and avoid that confusion. With that, Mr. Chairman, I'll yield back.
Gentleman yields back. The chair will recognize gentleman from, there we go. The chair recognizes the gentleman from Indiana for 5 minutes. Oh, the gentlelady from Washington, the chair.
Thank you, Mr.
5
Chairman.
minutes. What purpose does the gentlelady from Washington seek recognition?
I seek recognition to strike the last word.
The chair is recognized for 5 minutes.
Thank you. I appreciate some time here. I would just like to clarify that I believe there is a distinction between the acting through language that's being referenced in this bill and the acting through language of NIH when it comes to the appointments, because the appointments, when you are appointing someone, that triggers the appointment clause of the Constitution. And in the case of the appointments of the IC directors for NIH, Health and Human Services Secretary Becerra failed to follow the Constitution and the law in making those appointments that should have been made back in December of 2021. I yield back.
The gentleman,
Gentlelady yield.
Will the gentlelady yield?
Yes, I'll yield.
Yeah, I'm just going to make a brief comment. As a practicing physician, we've dealt with drug shortages for decades. It is a serious problem that needs serious solutions. It's multifaceted. It's a very difficult problem to address and solve, and each drug is different. And adding that to PAPA is just not the appropriate place to address that. We need to have a longer bipartisan discussion on that issue, and so I firmly believe that including that type of language in this legislation is misplaced and should be addressed at a later date. I yield.
Okay, reclaiming my time, today's markup continues the legislative process to ensure that the federal government is better equipped to handle any threat the American public, whether it's chemical, nuclear, biological, radiological, or cyber type attack. I'd like to thank Representative Hudson for introducing H.R. 4420, the Preparedness and Response Reauthorization Act, and H.R. 4421, the Preparing for All Hazards and Pathogens Reauthorization Act. And I'd like to thank my colleagues on both sides of the aisle for working hard on a number of bipartisan policies in these bills that will bring thoughtful and targeted reforms to ASPR and CDC. These two bills continue critical programs that make targeted improvements so that we are better prepared. We saw early in the pandemic how the federal government could have been better positioned to leverage public-private partnerships to scale up the much-needed diagnostics and therapies. And the message is clear in this bill that the federal government needs to be a better prepared and a better partner to the amazing innovators we have here in the United States of America. I also want to thank Mr. Hudson for including a provision that was a priority for me, addressing crisis standards of care. During the COVID-19 pandemic, it was so concerning to see states put protocols in place for hospitals to permit the rationing of care in a way that discriminated to those with disabilities. It is clear that there's more that we need to do now to put in best practices and model guidelines so this doesn't happen again. H.R. 4421 and 4420 reflect a clear bipartisan effort to examine ways to streamline authorities and enhance transparency and accountability across CDC, ASPR, and BARDA so that they will be better positioned to respond and lead effectively for future threats. It is critical that we work together to advance the legislation before us before September 30th and that expiration that will take place. And I am committed to continuing to work with bipartisan support. I also want to quickly speak on the FDA drug and device policies not included in either H.R. 4420 and 4421, which the minority has thus far cited as the reason for turning this into a partisan bill where it should not be. It is true that historically, reauthorizations of these authorities have included FDA policies targeted to facilitating the development of medical countermeasures or drugs and devices necessary to respond to a threat, such as smallpox vaccines, anthrax antitoxins, and medicines necessary for radiological and nuclear emergencies. Clearly, the clinical trials in demonstrating these products as safe and effective is different than those drugs with commercial markets. And Congress asked FDA to put out specific guidance and provided special authority for FDA for those products. No such bipartisan priorities have been raised thus far by the majority or the minority. The device and drug bills grant sweeping authority to the FDA to demand information, duplicates information they already have, and is no way limited to public health emergency response. I'm committed to addressing drug shortages and have announced intentions of releasing a discussion draft. I'm happy to work with my Democrat colleagues. This must be addressed, but we must root out the cause and the economics behind this these shortages. I have more to say, but I've run out of time. I will yield back and look for another opportunity. Thank you.
Gentlelady yields back. Anyone seeking recognition for purpose of speaking on the bill? The gentlelady from Massachusetts, what purpose do you seek recognition?
I move to strike the last word.
Gentlelady is recognized.
Thank you, Mr. Chairman. As a co-founder and co-chair of the Bipartisan Pandemic Preparedness Caucus, I've taken every opportunity in this committee to highlight the unique opportunity we have before us to take the lessons learned through the COVID-19 pandemic and apply them in a way that better prepares our healthcare system to respond to future unknown threats to public health. At the beginning of the pandemic, every member on this committee heard countless cases of nurses and doctors reusing masks and wearing trash bags to protect themselves. We all saw states racing against each other and the federal government for shipments of PPE. And we saw our hospitals begging ventilator companies for just one more device to help keep a patient alive. In order to prevent a scenario like this from ever happening again, it's critical that we use this reauthorization as an opportunity to legislate thoughtfully. There are good parts of the legislation before us. I'm glad that my bill, the Disease X Act, is included in this reauthorization so that we can better develop medical countermeasures for future viral threats with pandemic potential. But I am worried that as drafted, this reauthorization will fail to better protect us from the next pandemic. A number of proposals to strengthen policies that would address drug shortages that we saw then and we're faced with right now, as well as strengthen our supply chain, were excluded. And the funding levels, as Congressman Hudson indicated, they risk being far too inadequate. Coupled together, I fear that with the reauthorization as drafted, we are dooming ourselves to repeat the dark days of the pandemic. And it's for that reason that I plan to vote no today. However, it is my hope that the majority on this committee is willing to work with us to improve this reauthorization before the full committee markup. We have a chance to do what most other committees in this chamber fail at time and time again, to pass a bill with bipartisan support that will save American lives. And I compel my colleagues on the other side of the dais to seize this opportunity. Indeed, it is our job to apply the lessons learned from the past 3 years so that we're better prepared the next time around. Let's work together and make this bill better. I encourage my colleagues to oppose this reauthorization as written, and I yield back the balance of my time.
The gentlelady yields back. The chair now recognizes Mr. Carter. What purpose do you seek recognition?
Move to strike the last word.
Gentleman's recognized.
Mr. Chairman, in response to my colleague on the other side of the aisle, Mr. Sarbanes, and his questions about some of this legislation here, I'd like to read a letter from the Department of Health and Human Services from the Assistant Secretary for Legislation, Melanie Egerin, and it says, NIH IC directors are recommended for appointment by the NIH director and approved for appointment by the Secretary of the Department of Health and Human Services. It goes on to say, once a suitable candidate has been identified, a selection package is forwarded to the HHS Secretary for review and approval. After the HHS Secretary approves the appointment, ethics and security clearance checks are conducted, and NIH processes the appointment action. I think this clears up the questions that were being brought up about this, and I'd like to submit this for the record. Yield back.
Gentleman yields back. Anyone seeking recognition on the bill, on the Democrat side? Seeing none, the chair will recognize himself. I first want to thank our council. This is a good time to make a nice announcement. Caitlin Peters, thanks for being here and substituting. She got called off the bench because we had our council that has worked on this bill since the beginning, left a few weeks early than we thought she was going to leave, but I'm proud to announce, according to social media, Molly Lolly, our council, and her 4.5-pound baby are doing amazing according to social media. So we're proud of her, and thanks for stepping in at the last minute and being here for today. And we appreciate your work, and congratulations to us, all of our staffs. We get to know and appreciate all of our staffs, and this great time in Molly's life. And it appears everything's going well, even though the baby's a little early. So that I will now yield my time to the chair of the full committee, Ms. Rogers, Chair Rogers.
Thank you. Yes, congratulations, Molly. One of those premature babies that we were talking about a little bit earlier. And I just wanted to add just a little bit more on the drug shortages. You know, I'm here as, yes, I have the honor of serving as the chair of this committee. I'm also a mom. I've read the stories, heart-wrenching stories of the drug shortages, the families, especially pediatric oncology, when you hear the stories of kids that don't have access to the drugs. I am absolutely committed to addressing the issue around drug shortages and believe that we must, as a committee, work on this. Obviously, this committee has jurisdiction over many programs that are major payers of drugs in shortage or programs that affect the price of these necessary medicines. We did an FDA-only approach to shortages in this committee a little over 10 years ago in the 2012 user fee bill. A number of drugs in shortage in 2012 are in shortage again. And I don't want to be having this conversation 10 years from now. Let's move these important reauthorizations forward in a bipartisan way. And then let's turn back and look at all the programs across the board and come up with a comprehensive solution to the drug shortages. As I said earlier, I believe that we need to get to the root causes and the economics behind these drug shortages, and to make sure that for our U.S. patients, they have the access to the drugs that they need, and we are not continuing to be dependent upon so many other countries, the APIs, and the manufacturers in America. So with that, I'm ready to get to work. I yield back.
Gentleman, the lady is back to me, and I just want to say that, you know, hopefully, as we talk about what's going on, what our discussions of what's going on with the appointments with the secretary, that all of us would defend the legislative branch first. The law clearly states the HHS secretary needs to make these appointments, and we tried to work with them to make the appointments. We got to, I guess they've kind of acknowledged, because they were reporting on post after the fact. And so how do you reappoint Dr. Fauci when he was retired? And those are the kind of things that we need to get at. And hopefully, and if my side of the aisle has the presidency next time, we stand up for the law that we pass in the legislative branch where we are first and foremost. I will yield back. And any further discussion on the bill? Seeing no further discussion, are there any bipartisan amendments to the bill? Seeing no bipartisan amendments to the bill, are there other amendments? The gentlelady from California, what purpose do you see recognition?
Mr. Chairman, I have an amendment at the desk.
The clerk will report.
Amendment to H.R. 4421, offered by Ms. Eshoo.
Without
Mr. Chair,
objection. The gentleman from Indiana is recognized.
I reserve a point of order against the amendment.
The point of order is reserved. Without objection, the reading of the amendment is dispensed with, and the gentlelady is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. The crippling inadequacies of America's drug supply have become a life-threatening crisis now, especially for small children with cancer. I've been a broken record on this, but it is essential to be one. In order to address critical drug shortages, our country needs to know where drugs and their ingredients are originally sourced from. My amendment addresses this lack of transparency and directly improves our nation's public health security and all hazards preparedness and response through two, I think, very solid policies. First, it requires the HHS secretary to issue a regulation that all foreign drug manufacturers involved in the preparation of a drug for sale in the United States shall report their identity and the amount of drugs, active pharmaceutical ingredients, or other critical ingredients they're producing. The purpose of this policy is to finally shine a light on China's grip on our pharmaceutical drug supply chain. This is a national security issue that demands Congress's immediate attention. And I'm not a newcomer to this issue at all. I know colleagues know the number of years that I've been on this. As Rosemary Gibson, a senior advisor at the Hastings Center, testified to our subcommittee, quote, if China shut the door on exports of medicines and their key ingredients and raw material, U.S. hospitals and military hospitals and their clinics would cease to function within months, if not days. So far, our efforts to take back control of our nation's drug supply chain have been stymied because our government is in the dark about exactly what manufacturers we rely on for our critical medicines. If we pass this transparency policy, our government and other experts could monitor the country's upstream pharmaceutical supply chain to identify potential trigger points that could lead to supply chain vulnerability and predict and prevent drug shortages before they happen. The amendment's second policy will also help secure and prepare our nation by using market forces to bring drug manufacturing back to the United States. The policy will require drugs to include on their public label the name and place of business and the unique facility identifier of the original manufacturer of the drug and its API. This will close the U.S. Customs law loophole, which, unlike other products, doesn't require that the sources of a drug's ingredients be disclosed. This will help move the market back to the United States because patients, wholesalers, and hospitals would be able to make the informed choice of buying a product that's made in America, or if they so choose, made in China. Are my Republican colleagues going to vote against a bill that will finally put Made in America on our drugs? I think that's where we are. So, Mr. Chairman, as the sole original author of PAPA remaining in the Congress, both House and Senate, I know that these policies are directly in line with the intent and the purpose of the PAPA legislation, and will go a long way toward making our nation more secure, more prepared, and less dependent. I know that there is an issue with placing this in the legislation. Republicans don't want it in the underlying bill. They don't want it in the CDC. I don't think it's appropriate to be in the CDC bill. And don't want it in ASPR. So it's just, it can't be behind door one, it can't be behind door two, it can't be behind door three. Now, the chairwoman has said she's a discussion draft and whatever. We want to take on the entire drug industry between now and September, or before we leave here. It's not going to get done. It really isn't. I respect the fact that there's a recognition that we have a crisis, but the fact of the matter is we're not doing anything about it. And the people in our country, patients across the country, deserve so much better. This is a must-pass bill. Why not put something in it that should be passed relative to the drug shortage crisis in our country? So with that, I yield back the balance of my time.
Gentlelady yields back. Anyone seeking recognition? Gentleman. Gentleman from North Carolina, what purpose do you seek recognition?
Move to strike the last word.
Gentleman's recognized.
Thank you, Mr. Chairman. Unfortunately, the amendment before us and its companions overlook the sheer amount of authorities Congress has already given FDA over the last several years aimed at improving the drug supply chain, and the fact that economic reasons are the primary drivers of the tragic drug shortages we're hearing about every day. We must examine what information FDA already has access to and what they're doing with this information to meaningfully mitigate shortages. More information alone is not going to solve this problem. For the vast majority of drugs currently on the drug shortage list, a company must list its API suppliers as part of getting the drug approved. For every drug with an approved application, FDA knows the API suppliers. And if a company wants to add a new API supplier, the FDA must be notified before the company can switch to that supplier, allowing FDA the chance to inspect the facility. I understand the FDA may not know how reliant a drug manufacturer is on any one of the listed facilities, and that may be an area to consider targeting. with targeted, actionable steps to get the information FDA needs in the least burdensome way. And I'm open to working with my colleague on this. Maybe we can find door number 4. In addition to these basics on how drug registration and listing works, FDA already has a number of authorities through drug shortage notification requirements and know your supplier good manufacturing practices. Ultimately, the amendment before us would impose burdensome requirements on manufacturers while yielding limited value on return, given that it is not evident how FDA is utilizing its current authorities over the supply chain. There may be more targeted solutions we can work together on API. If my Democrat colleagues would join us in working on a separate drug shortage discussion draft, I am wide open to doing that. I think it's really important. And so I oppose including this amendment, H.R. 4421, and recommend my colleagues do the same.
Would the
With
gentleman
that,
yield?
I'd be happy to yield.
Would the gentleman yield to me?
I'd be happy to yield.
I mean, the problem that I see is we went through the COVID period, right? We saw all these problems with the supply chain and the shortages that are with us now. I mean, I mentioned, I had a roundtable last week at St. Peter's Hospital in New Brunswick, and literally oncologists came there and said, I have to ration the drugs. I tell my patients the drugs are not available, chemotherapy. So, I mean, I don't want to put words in the gentleman's mouth, but you seem to suggest that, not that everything's okay, but that FDA already has the authority, they can deal with this supply chain problem, but that's not the case. And I think that we have an obligation now, not in 2 weeks, not in September, not whenever, to address this now.
Well, reclaiming my time, I appreciate the gentleman's comments, and I'm certainly not saying everything's fine. I'm with you. The house is on fire, and we need to do something about it. But what I'm suggesting is to just say, let's get more information to FDA, and then wipe our hands and say we've solved the problem. Now all API is going to be made in America. We're lying to ourselves. That's not going to solve the problem, especially when FDA already has all this authority to collect all this information already, and it's not clear to us what they're doing with that information. Why are they not already addressing some of these issues? And so what I'm simply saying is, let's not just throw a whole lot more information authority to them. Let's take a very thoughtful look at what are the authorities they already have, where are their shortfalls, and maybe we need to give them additional authority. And I'm open to that, but I think we need to do this in a very careful, thoughtful way. Let's not just throw a whole lot more authority to them so they can collect a whole lot more information, putting burdens on private sector, and then say, oh, we've done our job, wash our hands, pat ourselves on the back, when it's not going to have any impact. And so that's where we are. I'm open to this discussion. I'm open to Democrat ideas, but I want to do this in a way that's going to make a difference. I don't want to just do something so we can pat ourselves on the back and say we did something. We need to solve this problem. And so with that, Mr. Chair, I'll yield back.
The gentleman yields back. Anyone seeking
Mr. Chair.
recognition? So whose time would be the next?
Mr. Chair.
Let me the gentleman from New Jersey, and then we'll. Gentleman from New Jersey, what purpose is he recognition?
To speak in support of the issue.
Okay, your gentleman's recognized.
Look, the problem that I see here is we have this drug shortage crisis. It's real. It's here. It's not, something that's down the road. We had 5 bills that we proposed, which the majority refuses to consider today. And I suspect they're going to argue germaneness, but we'll see. They don't want to consider them. And these are things that the FDA says that they support. They need these additional authorities in order to address the drug crisis. Now, you may say, well, I don't believe the FDA. They don't know what they're talking about. I think this is the problem. I think the problem that I see here is that increasingly what we see on the Republican side, and not necessarily from all of you, but from the more extremists, which are not here, thankfully, on the committee, that just think that all the actions that federal agencies take or everything they do is incompetent, somehow not, they don't trust the agencies. And to be honest, when I go before the Rules Committee, and some of you have been before the Rules Committee, and we see some of the, I say extremists there who are now on the committee appointed after the speaker, made his agreement in order to get the votes to be speaker, they literally say they don't trust the agencies. They don't trust the FDA, they don't trust CMS, they don't trust the FBI, they don't trust anybody and therefore they want, Congress is supposed to do all this on their own, right? We're not supposed to give any authority to the agencies because they don't know what they're doing. And I mean, I'm concerned that this extreme right-wing attitude towards saying that the agencies don't know what they're doing, and let's not give them additional authorities, even if they ask for it, is now permeating this committee. And that's why you don't want to include these bills, not because you personally think they're a bad idea, and you haven't actually said that. You said, oh, we need more time, we'll look at this, and we'll get back to you after Labor Day, whatever, I don't know. But I mean, the problem is we can't go down this path where the tail's wagging the dog, where these extremists, whether on the Rules Committee or wherever they are, dictate policy. We know there's a drug shortage. It has to be addressed. The FDA has said that this is a way of addressing it. I'm not saying that these 5 bills are going to solve all the problems, but it's certainly a rational way to proceed. And it's certainly something that the FDA, in a rational way, has explained why they need these authorities. And for you to say, no, we're not going to bring it up, I think it's just a political decision because the extreme right in the party won't allow it, and you're afraid that if it goes to the floor with those, they're going to scream and holler, whatever they do, or it rules. So I don't want to denigrate you, Mr. Hudson, or anybody else, because I think you're well-meaning. But at some point, somebody on the other side of the aisle is going to have to face the reality. You're either going to work with us to come up with rational, sound policy, or you're going to give in to these extremists because you're afraid how they're going to, what they're going to do or what they're going to say about you. I don't know. But I just think to suggest that what we're putting forward needs more study or hasn't been looked at enough is not accurate. These are what we're proposing in our 5 bills are not anything that really are that difficult to go along with. They're just rational ways of addressing this drug shortage problem, which is at a crisis right now. And with that, I'll yield. I support Ms. Eschew's amendment and hope that there's not an effort to exclude it on procedural grounds.
Gentleman yields back.
Mr. Chair,
Gentleman from Indiana, what purpose you seek recognition?
I insist on the point of order.
The gentleman will state his point of order.
Mr. Chair, the amendment violates Clause 7 of Rule 16 of the Rules of the House because it is not germane to the underlying bill. Specifically, this bill will reauthorize programs to support public health during times of insecurity due to international threats, cybersecurity attacks, and other public health emergencies. It is designed to ensure that we have a strategic national stockpile, countermeasures for health emergencies, and other protections against the unknown. This amendment, on the other hand, attempts to lump in what has sadly become a chronic, in fact, decades-old issue into a bill concerning preparing for extraordinary circumstances. Clearly, there are market failures that need to be addressed to stop the pattern of shortages with cancer drugs, with infant formula, with children's cold medicine, and so on. But that is not the subject matter or the purpose of this bill. In offering this amendment to a bill on hazard preparedness, Democrats are conflating a broad drug shortage du jour with preparing ourselves against threats. They're trying to add a separate individual proposition to the individual proposition of hazard preparedness. Mr. Chair, the amendment is not germane. I yield back.
Would
Does
the
any
gentleman
member
yield?
wish to be heard on the
Would the
amendment?
gentleman yield? Would the
You
gentleman?
wish to be heard on the amendment? Gentlelady is recognized for 5 minutes to be heard.
No, thank you, Mr. Chairman. I would just like to state that medical countermeasure is a drug.
I'm just going to hear on the point of order.
Yeah, you want to speak on the point. You want
That was it. That's all I wanted to say for the record. Go ahead.
Oh, all right.
anyone
I'll
be heard on the
restate
point
it.
of
A
order?
medical countermeasure is a drug.
Okay.
You yield the rest of your time to Frank. I guess you got
Oh, you want to yield to
4
me?
minutes, 58
Okay.
seconds.
Well, let me just say, what was just said by my Republican colleague about how we are inflating, I think he said that we're inflating the problem. I don't think that's true. We're not.
Conflating.
Unflating?
putting two issues that are not germane with each other. Excuse me.
Okay. All right, maybe I didn't understand unflating versus inflating. Okay. Well, I'm not.
For
I'm not
clarification.
inflating or unflating, okay? As you know.
Or deflating.
Or deflating. As you know, the germaneness requirement of Rule 16, Clause 7 requires that the amendment be on the subject of the text proposed to be amended. While most of the provisions of H.R. 4421 are limited to the public health emergency preparedness and response subject matter traditionally associated with PAPA, the subject matter of the bill is broadened to public health measures due to the inclusion of the reauthorization of the Mission Zero Grant Program. Section 202, the Military and Civilian Partnership for Trauma Readiness, reauthorizes a grant program that is focused on increasing the availability of medical staff at civilian trauma centers to meet the needs of patients who use these centers each day. According to the committee report for the standalone version of the Mission Zero Act, which was subsequently incorporated in the last reauthorization of PAPA, the purpose of the bill is to, quote, establish a grant program for military-civilian partnerships in trauma care, which will allow both sectors to benefit from the other's expertise and experience, unquote. Further, quote, increasing military-civilian partnerships is a critical step towards achieving the goal of zero preventable injury deaths, as highlighted in the 2016 National Academies of Sciences, Engineering, and Medicine report, a national trauma care system integrating military and civilian trauma systems to achieve zero preventable deaths after injury. While strengthening trauma systems as a part of preparing for public health emergencies, the goal of the grant program authorized by this provision is much broader. The amendment offered by Ms. Eshu would help the Department of Health and Human Services to better prepare for public health emergencies by requiring drug sponsors to report their suppliers to the Secretary and include suppliers of active pharmaceutical ingredients on drug labels. By bringing transparency to the drug supply chain, the amendment will improve the Secretary's understanding of our nation's drug supply and will inform the Department's actions responding to drug shortages and supply challenges caused or worsened by pandemics and other emergent public health threats. If we lose an API facility during as a result of a public health emergency or CBRN threat, the Secretary will not know the impact of the plant closure on the drug supply chain and will be unprepared to act. So it's clear that the subject matter of this amendment falls within the public health measures subject matter of the underlying bill. Therefore, the pending amendment should be ruled in order. And with that, I yield back I yield back to Ms. Eshu.
Gentlelady,
Time.
And I yield back.
Gentlelady yields back. Anyone seeking recognition on the point of order? The chair is ready to rule. Dr. Bouchon makes a point of order that the amendment offered by Ms. Eshu of California is not germane. Clause 7 of Rule 16, the germaneness rule, provides that no proposition on a subject different from that under consideration will be admitted under the color of amendment. The legislation we are considering would amend the Public Health Service Act to reauthorize programs addressing public health security and all hazardous response. It proposes reauthorizing the administration for strategic preparedness and response. However, the amendment proposes adding an entirely different individual proposition to address the origin of pharmaceutical ingredients, which already has a bill, which is H.R. 3810, and so it's kind of Mr. Griffith's classic apples and oranges. It proposes updates that would normally be under the purview of the Food and Drug Administration and be added to the Federal Food, Drug, and Cosmetic Act. Although the amendment avoids addressing the FDA, it still seeks to add a new and unrelated proposition to the bill. The chair finds that the amendment, which has a different subject matter and adds a separate individual proposition to the underlying bill, is not germane, and the point of order is sustained. Are there any other amendments to the bill? The person gentleman from Maryland, seek recognition.
Have an amendment to the desk.
The clerk shall report.
Amendment to H.R. 4421, offered by Mr. Sarbanes.
Without objection, the reading of the amendment.
Mr. Chair,
The gentleman from Indiana, seek recognition.
I reserve a point of order against the amendment.
The point of order is reserved. Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Thanks very much, Mr. Chairman. As we've been saying, but it's worth saying again, PAPA reauthorization offers us the perfect opportunity to take the lessons we learned from the public health crises over the past 3 years and apply them to reforms that will make sure all of our public health agencies are more prepared to effectively respond to current and future challenges. That's why I'm offering an amendment today that would have a tangible impact on a current challenge we're facing, that is, as it stands, completely unaddressed by the PAPA reauthorization bills my Republican colleagues have put forward. Drug shortages. I mean, this is a theme here, obviously. It's something we feel very strongly about. This is the appropriate place and opportunity to build in provisions and measures that can address drug shortages, not in a week or 2 weeks or 4 weeks or whatever it is, but now. Under existing law, drug manufacturers are required to notify FDA when a drug is facing a shortage because of supply-side issues. For example, a shortage of ingredients or a production plant shut down. But manufacturers are not required to notify FDA when a drug is experiencing a shortage due to demand-side issues, which is just as important if you think about it. In some ways, maybe even more important, because if demand's going up, it shows there's a real need for something under particular circumstances. This can leave FDA without the information it needs to be able to leverage its expertise to ensure that patients do not lose access to necessary, and in many cases, as we know, life-saving drugs. Every day, we hear more stories of patients struggling to access their medications, be it the stories of parents who couldn't find pain medication or antibiotics for their children during the triple-demic of flu, RSV, and COVID-19 last year. We are all familiar with those stories. Or those of the cancer patients who are having to skip or delay chemotherapy treatments. These types of shortages impact patients every single day, and in public health emergencies, they are only exacerbated. My amendment is one of several proposals that committee Democrats, as you know, are putting forward to address drug shortages. In fact, it reflects the text of a bipartisan bill that Representative Sarah Jacobs introduced, the Drug Shortage Prevention Act. Simply put, it would require manufacturers to expediently notify FDA when critical essential medicines they produce experience spikes in demand that are sustained for 6 consecutive weeks. This amendment would thereby empower FDA to act to alert patients and providers and ensure manufacturers take the necessary steps to improve demand predictability. This is a common sense solution. It's one with bipartisan support. It's really unconscionable, Mr. Chairman, that we as members of this committee would not use the opportunity presented to us today by the PAPA reauthorization process to address FDA policy as we've done historically in every other PAPA reauthorization. And it's unconscionable that we would not take expedient action to combat drug shortage issues before they continue to worsen. It's something that we have to do, and we have to do it without delay. So I urge my colleagues to support this amendment, and Mr. Chairman, I yield back my time.
Gentleman yields back. Anyone seeking recognition on the amendment? Mr. Hudson, what purpose do you seek recognition?
I move to strike the last word in opposition to the amendment.
Gentleman is recognized.
Thank you, Mr. Chairman. I urge my colleagues to reject this amendment. Once again, Republicans are committed to addressing the root causes of the drug shortage issue, but it's not clear how this amendment would help. Experts, stakeholders, even the FDA all agree that economics are the driving underlying factor of the drug shortage we're facing. The fact is, government and market incentives have made it economically difficult for companies to have a business case for manufacturing many of these generic drugs. In 2020, we gave the FDA additional authorities to address shortages through data collection. However, as reported in STAT just this morning, They have not taken advantage of these new authorities. Despite the fact that FDA isn't using their existing authorities, Democrats are saying the way to solve the shortage issue is to give the FDA more authority to collect even more data. This amendment will require manufacturers to submit data to HHS anytime they experience any increase in demand for a drug that is likely to lead to a shortage. All this is going to do is flood FDA with massive amounts of notifications that could only divert resources away from responding to an actual shortage. Drug manufacturers are already required to report meaningful disruptions in supply of a drug in the United States and are required to have risk management plans that identify potential supply chain risks. So I urge my colleagues to reject this amendment and join Republicans in our efforts to actually address drug shortages. And with that, Mr. Chairman, I yield back.
Gentleman yields back. Anyone seeking recognition for discussion on the amendment? What purpose is the gentleman from New Jersey seek recognition?
Speak in support of the Sarbanes.
Gentleman's recognized.
Thank you, and I don't intend to speak very long, but look, what I found at my roundtable, again, I keep referring to a roundtable I had in my district last week, is that there are many aspects of this that right now the FDA does not have the authority to address, and one very serious one is the demand. Now, I don't want to criticize Mr. Hudson. He's not like some of these extremists on the Rules Committee, that's for sure. But the fact of the matter is, we have to trust the agency to some extent that when they say they need additional authority to address demand, that should be addressed, that we should give them that authority. The problem is we can't look at public, and I'm not saying you are, Mr. Hudson, but we can't look at public health in, as if it's just, a capitalist situation. I'm not saying I'm a capitalist, but the point I'm trying to say is that what happens a lot of times, and this came out at the roundtable, is that all of a sudden there's an increased demand. It may be because all of a sudden something seems like it's going to be curative, and so doctors and everybody decide we want to use it, right? It may be because of hoarding. There was a lot of discussion at my roundtable about hoarding where, hospitals or doctors begin to think, oh, this drug isn't going to be available, so I better stockpile it, and that increases the demand. I mean, demand is a serious factor in this drug shortage situation. And if the FDA doesn't have the ability, and they say they don't, I know you seem to think they do, but it's not the case, then that becomes a tool that they don't have to deal with this shortage crisis. So that's why I think this is important and why we need to support Mr. Sarbanes' amendment. And with that, I'll yield back, Mr. Chairman.
Gentleman yields back.
Will the gentleman yield for?
Gentleman yield to the gentleman from Texas.
Sure.
I would only ask that the gentleman, when you refer to the extremists on the Rules Committee.
That doesn't include you.
If you would single me out and name me as the extremist on the Rules Committee, I'll be happy to accept the responsibility.
I'm taking my time back right now and make it clear that you are one of the most rational, thought-provoking persons on the Rules Committee, and I watch you sometimes when those extremists speak, and you're like, can't believe what they're saying. So no, not at all.
Mr. Ranking Member, with
Not
all
at all.
respect, I will have a primary coming up, and I would appreciate it if you would refer to me as the radical Republican on the Rules Committee.
I cannot in good conscience do that, Dr. Burgess. I yield back.
Yield back.
The gentleman yields back.
Mr. Chair,
What purpose the gentleman from Indiana seek recognition?
I insist on the point of order, Mr. Chair.
A point of order. The gentleman will state his point of order.
Yep. The amendment violates Clause 7 of Rule 16 of the Rules of the House because it is not germane to the underlying bill. Again, specifically, this bill will reauthorize programs to support public health during times of insecurity due to international threats, cybersecurity attacks, and other public health emergencies. It is designed to ensure that we have a strategic national stockpile, countermeasures for health emergencies, and other protections against the unknown. This amendment, on the other hand, attempts to lump in what has sadly become a chronic, in fact, decades-old issue into a bill concerning preparing for extraordinary circumstances. Clearly, there are market failures that need to be addressed to stop the pattern of shortages with cancer drugs, with infant formula, with children's cold medicine, and so on, but that is not the subject matter or the purpose of this bill. In offering this amendment to a bill on hazard preparedness, Democrats are conflating a broad drug shortage problem with preparing ourselves against threats. They're trying to add a separate individual proposition to the individual proposition of hazard preparedness. Mr. Chair, the amendment is not germane, and I yield back.
On the point of order amendment, gentleman from New Jersey, you're recognized.
Thank you, Mr. Chairman. And of course, I do believe this is germane. As you know, the germaneness requirement of Rule 16, Clause 7 requires that the amendment be on the subject of the text proposed to be amended. As I explained previously, the subject matter of the bill is broadened to public health measures due to the inclusion of the reauthorization of the Mission Zero grant program, and this amendment falls within that subject matter. Furthermore, contrary to your ruling on the last amendment, none of these amendments amend the Federal Food, Drug, and Control Act. However, it is clear to me that ruling our amendment out of order is a continuation of efforts to ignore the public health crisis affecting patients across this country, and that's the shortage of cancer and other drugs. Despite the fact that we're facing the worst drug shortage in years, with the number of drugs in short supply increasing by 30% last year alone, with chemotherapy being rationed in physician offices across the country, this opposition to treating the PAPA reauthorization as an opportunity to address this crisis, I think, is wrong. Not only did the Republicans not work with us to include provisions on drug shortages in the basic text, but you've also introduced 5 separate public health bills in order to limit the subject matter test for amendments. As you know, consolidating the PAPA measures into a single bill would mean drug shortage provisions would clearly be germane. But what are you afraid of? We've heard so much of how you are committed to regular order, but here you're refusing to notice drug shortage bills for a hearing and then structuring a bill to limit our ability to put forth our ideas on drug shortages, a public health crisis affecting all of our communities, and bring them for a vote. Why don't you want your constituents to know where each of us stands on addressing this important issue? The people are not crying out for discussion drafts or requests for information. They want action. And the time to act is now, and I think Republicans are standing in the way. So in closing, like Mission Zero, this is a problem patients are facing each day while they're seeking treatment in our nation's healthcare system, and that should be addressed in this bill. And again, I urge you to rule that this amendment is in order, Mr. Chairman. I yield back.
The gentleman yields back, and the chair is ready to rule. Dr. Bouchon makes a point of order that the amendment offered by Mr. Sarbanes is not germane. Clause 7 of Rule 16, the germaneness rule, provides that no proposition on a subject different from that under consideration shall be admitted under the color of amendment. The legislation we're considering would amend the Public Health Service Act to reauthorize programs addressing public health security and all-hazard response. It proposes reauthorizing the Administration for Strategic Preparedness and Response. However, the amendment proposes adding an entirely different individual proposition to address drug shortages, which is H.R. 3008. It proposes updates that would normally be under the purview of the Food and Drug Administration and be added to the Food and Drug Administration Act. Simply removing the words FDA does not make this any more relevant to an ASPR bill. Although the amendment avoids addressing the FDA, it seeks to add a new and unrelated proposition to the bill. The chair finds that the amendment, which has a different subject matter and adds a separate individual proposition to the underlying bill, is not germane, and the point of order is sustained. Are there further amendments to the bill? For what purpose does the gentlelady from Michigan seek recognition?
Mr. Chairman, I have an amendment at the desk.
The clerk will report.
Amendment to H.R. 4421, offered by Mrs. Dingell.
Without objection, the reading of the
Mr.
amendment
Chairman.
is dispensed with.
Mr. Chairman.
The gentleman from Virginia seek recognition.
Mr. Chairman, I reserve a point of order against the amendment. I'd be happy to discuss the motion on germaneness now, if we'd like to do that, and cut out all the interlude in between. But for comedy purposes, this committee generally allows a lot of
We'll allow the lady
superfluous
to
language.
present her amendment, and
All right.
unless if she was so like, but so the
All right.
Without objection, the amendment is dispensed with and is recognized for 5 minutes to support.
I love my colleague from Virginia, but I don't think this subject is a comedy in any way, shape, or form. I've been in hospital rooms.
He wants to
If
clarify
the,
his
if the
word.
gentlelady would yield for just a minute, what I attempted to say, but my accent might have clouded it, was COMITY, comedy,
Okay,
friendliness.
okay, that's better. That did upset me. All right, thank you, Mr. Chairman. The reauthorization of PAPA is coming at a critical moment in our nation's history. We're emerging from one of the worst public health crises America's ever endured. And by the way, people are still getting COVID, people are still dying. I get to go to another funeral. And we've got an obligation to ensure we are better prepared to address future threats. I'm glad this bill contains several important policies to improve preparedness. This includes provisions from the Ensuring Sufficient Supply of Testing Act, legislation I led with Rep. Dunn to strengthen our clinical lab testing capacity to meet the needs of the SNS during surges. But as my other colleagues have expressed, this bill falls woefully short of what's necessary to address drug shortages. And we had drug shortages during the last crisis, and it is something we need to be ensuring we do not experience again. I remain seriously alarmed by the growing drug shortage crisis that's actively harming patients now across America. As we speak, cancer patients nationwide are struggling to access the medication their doctors believe necessary for their treatment and even remission. Just last week, I talk to my hospitals every week. I know exactly how many medicines they're short every week. But an ovarian cancer patient called me in total distress and had come to this hospital to be in the community and was outright going to die if she didn't get this. We were able to connect her with an emergency supply of carboplatin, but cancer patients shouldn't be having to panic about whether they can get their medicine and find it. The drug shortage is leaving thousands of other patients across the country and in Michigan in despair and hopeless with nowhere to turn. It's forcing doctors, I know some of you have, to make these gut-wrenching decisions on who to give the limited supply. And I love my colleagues, but if you're a cancer patient who wants to live, thoughtfulness and care doesn't mean anything to them. They need the medicine now. The reauthorization of PAPA is a clear opportunity to address the drug shortage crisis. I have to admit I'm disappointed and perplexed why we are not using this opportunity to strengthen our pharmaceutical supply chain and address the drug shortage crisis head on. We need to be able to better predict, address, and prevent drug shortages before they put patients at risk. That's why I'm offering this amendment, which includes provisions from a bill also being led by my colleague, Rep. Alyssa Slotkin, who's working to address this dire crisis. And I want to thank Rep. Slotkin for her tremendous work. This amendment will expand the supply of usable drugs by requiring manufacturers to label drugs with the longest scientifically supported expiration dates. In the wake of a drug shortage, maximizing the shelf life of life-saving drugs is critically important. It will help keep life-saving medications on shelves, ensuring patients can access their necessary drugs without undue delay. We know we had shortages of drugs and we didn't have this. We need to work to make sure this is there before you all attempt to say this isn't relevant. I think it very much is. And right now, patients' care isn't just being delayed, it's being denied. Their appointments are being canceled. Let me repeat this. Cancer patients' appointments are being canceled. They're saying, sorry, you may have ovarian cancer, you may die, but we can't help you. I don't think any of us want to do this. It's unacceptable. I urge all of my colleagues to support this amendment. We owe it to patients nationwide. Thank you, Mr. Chairman, and I yield back.
Anyone else seeking discussion on the amendment? What purpose is the gentleman from North Carolina seek recognition?
Move to strike the last word in opposition to the amendment.
Gentleman's recognized.
Thank you, Mr. Chairman. I urge my colleagues to oppose this amendment. As I have made clear repeatedly, Republicans are committed to addressing the drug shortages our country is facing by addressing the root causes of the shortages. This amendment would not only not address the problems causing shortages, it could make the problems worse. Chair Rogers and Senator Crapo recently received over 100 responses to the RFI on addressing shortages. And the overwhelming response from the experts and the stakeholders was that the economics are what are driving this issue. As STAT reported just this morning, the FDA's own report in 2019 on root causes of drug shortages in 2019 determined, quote, most shortages occur in generic injectables that are complicated to make and are too cheap for big profits, end quote. This amendment would make it even harder for companies to make a business case for manufacturing these already challenging drugs by instituting financial penalties for failing to conduct new studies or turn over new data on shelf life extension at any time for any reason. The fact is, the FDA is already failing to use their existing authorities to address shortages that we gave them during the pandemic in 2020. FDA was required to put out guidance on shelf life extension studies in December and has yet to do so. Again, Republicans are working to address the actual economic causes of drug shortages that experts, stakeholders, and even the FDA all agree are driving this crisis. And look, our colleagues ask questions like, why are we not addressing this problem head on? Don't say this is irrelevant. We talk about our constituents who have cancer, who are desperate for these drugs. We all understand this is a crisis. But I'm not willing to pass something that I know is not going to help. And it might even make it worse, so that I can pat myself on the back and I can go lie to a constituent and tell them we've solved your drug shortage problem. I'm not willing to do that. What I'm saying we're going to do is Republicans are going to address this issue in a serious way. We're going to figure out what the root causes are, and we're going to find solutions that solve this problem once and for all. And I really hope, I truly, sincerely hope my Democrat colleagues will join us in this, because frankly, I think we'll get better outcomes, better policy if we work together on this. And so let's stop the name calling, let's stop the finger pointing, let's stop saying one side doesn't care about children with cancer who can't have access to drugs, because we both care. I know that my colleague from Michigan cares deeply about this. But what we're saying is, let's not just put a Band-Aid on it and then claim victory and go tell our constituents we've solved this problem when we know this is not going to solve our problem. And in fact, this amendment, I would argue, may make the problem worse. So I ask my colleagues, let's vote down this amendment, let's move forward with PAPA, and then let's work together to address this drug shortage problem in a real way, in a way that we're not back here a year from now talking about it again, in a way that we can go home and look our constituents in the eye and say, we did the job you sent us here to do. And I ask my colleagues to work with us on this. And with that, I'd be happy to yield back.
Gentleman yields back. Any further discussion? Gentleman for Virginia?
Mr. Chairman, I insist on my point of order.
The gentleman will state the point of order.
Mr. Chairman, this amendment violates Clause 7 of Rule 16 of the Rules of the House because it is not germane to the underlying bill. Specifically, this bill will reauthorize programs to support public health during times of insecurity due to international threats, cybersecurity, attacks, other public health emergencies. It is designed to ensure that we have strategic national stockpile countermeasures for health emergencies and other protections against the unknown. This amendment, on the other hand, attempts to lump in what has sadly become an everyday issue with preparing for extraordinary circumstances, and that would be expiring pharmaceuticals, and it's conflated it with preparing for extraordinary circumstances. Clearly, there are market failures that need to be addressed to stop the pattern of shortages with cancer drugs, with infant formula, with children's cold medicines, and so forth. But that is not the subject matter or the purpose of the bill. In offering this amendment to a bill on hazard preparedness, my colleagues are conflating a broad drug shortage du jour with preparing ourselves against threats. They are trying to add separate individual proposition, drug supply shortages, et cetera, to the individual proposition of hazard preparedness. And a lot of times when I was describing the changes that we made in the germaneness rule, because I was one of those extremists who fought to get this change into the rules package, I would talk to people and say, look, we need to have bills that deal with single subjects. Sometimes they can be large bills, like our NDAA that we have coming up. But they shouldn't always be, everything shouldn't be lumped in together. This is a serious problem, but it is one of those situations where we need another bill. Now, the gentlelady has a bill, and in fairness, I have a bill, which is not proper. My bill wouldn't be proper to add to this bill either. And then comes up the question of, well, why aren't we moving that bill today that deals with drug shortages? And the answer is, as Mr. Hudson pointed out, we want to make sure we're getting it right. The bill, even as I have introduced it, may need some corrections and some adjustments that we need to work on together as a team so that we can solve the drug shortage problem for the American people. But this is not the proper place to put it, and we do need to move forward as a committee on this, but not on this bill. And so, Mr. Chairman, I hope that you will rule that the amendment is not germane, because I can assure you it is not. I yield back.
Does any
Oh, I meant to say, and my good friend, another extremist, Dr. Burgess, was working with me behind the scenes on all these crazy rules changes that I came up with. I yield back.
The gentleman from, anybody wish to be recognized? Gentleman from New Jersey, recognized for 5 minutes, or recognized to speak on the germaneness.
I don't really know what to say about this rules extremist. Neither you or Dr. Burgess are extremists, even though you want me to say you are. You're not, but whatever. Let me just say that my germaneness argument, and I'm not going to repeat it again, is all based on Mission Zero being included in that grant program, and that's not about extraordinary circumstances. It's about the daily traumas that occur, including gun violence, another provision that that unfortunately I don't think is being addressed by the other party. So I don't see how you can argue, Mr. Chairman, that if Mission Zero is included in this, that our provisions on drug shortages should not be. But I'm not going to belabor the point. I yield back.
Gentleman yields back. The chair is prepared to rule. Chair is ready to rule. The member from Virginia, Mr. Griffin from Virginia, makes a point of order. The amendment offered by Ms. Dingell of Michigan is not germane. Clause 7 of the Rule 16, the germaneness rule provides that no proposition on a subject different from that under consideration shall be admitted under color of amendment. The legislation we're considering would amend the Public Health Service Act to reauthorize programs addressing public health, security, and all hazards response. It proposes reauthorizing the Administration for Strategic Preparedness and Response. Is that the FDA again? However, the amendment proposes adding an entirely different individual proposition to address expiration dates for certain drugs. That's also Bill HR 3793. It proposes updates that would normally be under the purview of the FDA and be added to the FDA Cosmetic Act, Food and Drug Cosmetic Act, although the amendment avoids addressing the FDA, simply removing the words FDA does not make it more relevant to ASPR. It seeks to add a new and unrelated proposition to the bill. The chair finds the amendment, which has a different subject matter and adds a separate individual proposition to the underlying bill, is not germane, and the point of order is sustained. Are there any other amendments to the bill? Yes. You have an amendment? The gentleman from New Jersey has an amendment. Was your report?
Does the clerk have my amendment?
SCD-AMD-01.
All right.
An amendment to HR 4421 offered by Mr. Pallone. Page 3, line 12, strike 2028 and insert.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. It's unfortunate, again, that instead of working with Democrats to find a bipartisan path forward to reauthorize PAPA, we're here today considering what I consider a partisan ideological bill that my staff and I saw for the first time on Tuesday evening. HR 4421 leaves out numerous core PAPA reauthorizations, includes several new policy proposals that I can't support, and fails to increase any authorizations for existing programs beyond the most recently enacted appropriated levels. At best, this bill is misguided, and at worst, it's playing games with our public health preparedness. And for this reason, I feel forced to file or to move this amendment that would instead reauthorize these critical programs for just 2 years. And the reason for 2 is to ensure that we do not let these important provisions lapse, but also allows us to bring us back to the table sooner than 5 years from now, so we can have a more comprehensive and reflective policy discussion about how best to move forward with public health preparedness and response following the worst pandemic in this country's history. So in my opinion, this bill is a missed opportunity to take the lessons learned from COVID-19 and work together to be better prepared for the future. And I am disappointed that Republicans have chosen to flat fund essential preparedness and response capabilities like the Strategic National Stockpile and the Hospital Preparedness Program, both of which were critical in responding to COVID-19. For this reason, my amendment increases funding for the SNS to the amount outlined in the Public Health Emergency Medical Countermeasures Enterprise multi-year budget, which notes that the SNS needs double the resources it currently has in order to sufficiently maintain current capabilities and absorb additional products successfully developed through BARDA. And this should not be partisan. We all support a robust and strong stockpile of medical countermeasures and supplies, and we've seen in real time how critical the SNS can be as Republicans sought resources from the SNS throughout the pandemic for their districts, just like Democratic members did. Additionally, the Hospital Preparedness Program has been vital to ensuring there's healthcare system resilience in the wake of public health emergencies, while also ensuring there is adequate coordination between state and local health departments, healthcare facilities, and other partners. In response to the request for information on the reauthorization of PAPA, one stakeholder highlighted that HPP was funded at $500 million 20 years ago, and so there's no reason why that shouldn't be the authorization level now as well. Finally, my amendment also strikes a number of policy provisions that I can't support, including the creation of FEMC Advisory Committee that will provide self-interested industry stakeholders with a seat at the table to aid in the decision-making of the PHE of FEMC and create the possibility that committee members may seek to influence the FEMC by putting their industry's own self-interest in procurement decisions above what is best for public health. Technical assistance feedback on this policy also noted that much of the discussion of FEMC are classified and could have national security implications if they were released publicly. Similarly, I can't support policies that would tie the hands of the SNS or BARDA in terms of contract duration or lock in the placement of the SNS by codifying the agency in which it sits in the statute. So these are immense decisions that require thoughtful consideration, data, robust discussion, and clear rationale, and unfortunately, the proposals do not have that. So for all these reasons, I urge my colleagues to support my amendment. While this is not the bill that I was hopeful would move to the Energy and Commerce Committee to reauthorize PAPA, I feel this is the only solution to bridge the gap between the majority's incomplete and detrimental bill and finding a path forward to a longer-term compromise in the future. That's why I'm offering this amendment, Mr. Chair. And with that, I yield back.
The gentleman yields back. Is anyone wishing to speak on the amendment? What purpose does the gentleman from North Carolina seek recognition?
To strike the last word in opposition.
Gentleman is recognized.
Thank you, Mr. Chairman. You know, I've been working in good faith in a bipartisan way to ensure we have a 5-year reauthorization of PAPA. We've offered multiple times commitments of working together on this drug shortage issue separately. The chairman's even announced the plans for a discussion draft laying out a concrete plan. But this straight extension for 2 years of PAPA is short-sighted, and frankly, it's dangerous to just hope that another emergency isn't going to happen in the next 2 years. We would also lose the opportunity to implement lessons learned from the last pandemic. Innovators need certainty in order to invest in their products. This will discourage and disincentivize that innovation. Not to mention this violates Cutco rules with the increased authorization without cutting elsewhere. It violates leader protocol and jeopardizes floor consideration. This also violates Cutco rules by increasing authorization of funds Well, that's the speaker protocol. Listen, a straight extension is a move of last resort. If we can't get our work done, and certainly if we can't find a way to make this a bipartisan process and get this work done, we may end up in a position where we have to do an extension for a year. But at this point, and certainly not a 2-year extension, I don't see how we can move forward without jeopardizing even having a floor vote on this in the first place. And so I urge my colleagues to oppose this amendment, and I yield back.
The gentleman yields back. Anyone else seeking to discuss on the amendment? Okay, so if there's no further discussion, a vote occurs on the amendment. All those in favor shall signify by saying aye. Aye. All opposed say nay. Nay. A roll call has been requested. A roll call vote has been requested. You want a roll call vote? A roll call vote has been requested. The clerk will call the roll.
Chair Guthrie.
Aye. No, nay, I'm sorry. I'll change my vote.
Chair Guthrie votes no. Burgess.
I know.
Burgess votes no. Latta. Latta votes no. Griffith. Griffith votes no.
As I
Bilirakis.
said, I knew it was wrong.
Bilirakis votes no. Johnson. Johnson votes no. Bouchon. Hudson.
No.
Hudson votes no. Carter. Carter votes no. Dunn. Pence. Pence votes no. Crenshaw. Crenshaw votes no. Joyce. Joyce votes no. Harshbarger. Harshbarger votes no. Miller Meeks. Miller Meeks votes no. Obernolte. Obernolte votes no. Eshoo. Eshoo votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Dingell. Dingell votes aye. Custer. Kelly. Kelly votes aye. Badagan. Miss Badagan. Badagan votes aye. Blunt Rochester. Craig. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes no. Mr. Ruiz is not recorded. Ruiz votes aye. Mr. Bouchon is not recorded. Bouchon votes no. Mr. Dunn is not recorded. Dunn votes no.
Has Ms. Craig recorded?
Craig is not recorded. Craig votes aye.
Anyone else seeking recognition to vote? Seeing none on the Democrat, any on the Republican side to vote? Seeing none, the clerk will report. Oh, that looks good.
Chair Guthrie, on that vote, there were 11 yeas and 17 noes.
With 11 yeas and 17 noes, the amendment is not agreed to. Are there any further amendments? Seeing none. So no. None. I mean, even ours. The question now occurs on forwarding. You want to roll call on this? Okay. The question now occurs on forwarding HR 4421 to the full committee, and the roll call has been requested. All of those in favor will vote aye. All the opposed will vote no. The clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon.
Aye.
Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo. No. Eshoo votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Kelly. Kelly votes no. Barragan. Barragan votes no. Blunt Rochester. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers. Chair Rogers votes aye.
I think people just get so. Anyone wishing to be recognized for purpose of vote? Anyone on the Republican side? On the Democrat side, anybody remaining? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 17 ayes and 11 noes.
With 17 ayes and 11 noes, the ayes have it, and the bill is agreed to. The chair calls up H.R. 4420 and asks the clerk to report.
H.R. 4420, a bill to reauthorize certain programs under the Public Health Service Act with respect to public health security and all hazards preparedness and response related to the Centers for Disease Control and Protection and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek recognition on the bill? For what purpose, the gentleman from North Carolina seek recognition?
Strike the last word.
Gentleman is recognized.
Thank you, Mr. Chairman. As I previously mentioned, we've been working on this legislation for a long time now. I don't need to beat a dead horse to explain the importance of this reauthorization and the importance of preparedness efforts. CDC needs a lot of work, and not just a reorganization. Real reform looks like Senate confirmation of a CD director immediately, good guidance practices to exclude mandates, require public participation and training and guidance for employees, and further oversight of the agency. There are many opportunities for bipartisanship, oversight, accountability, and reform at CDC as it relates to response efforts, and I welcome that work with my colleagues. We're keeping our hand extended with this legislation in hopes that we can put together a comprehensive reauthorization. I look forward to moving this bill to the next level, hopefully working with my friend Representative Eshoo. And with that, I yield back.
The gentleman yields back. Anyone seeking recognition to speak on the bill? No one is seeking recognition to speak on the bill. Are there bipartisan amendments on the bill? I'm sorry, the chair, what purpose does the gentlelady from California seek recognition?
I seek recognition, Mr. Chairman, to strike the last word and speak on H.R. 4420.
The gentlelady is, the vote has just been called on the floor, so the gentlelady is recognized.
Thank you. As I said, colleagues, on the ASPR bill, this fragment of PAPA, once again, in my view, chooses unpreparedness. Our country has a shortage of some 80,000 public health workers. We're collecting public health data in the second decade of the 21st century via fax machines and scraps of paper. These antiquated methods are embarrassing for a nation that once had a globally respected public health system, and our disarrayed data collection has broader consequences for many Americans. It's allowed health disparities to flourish without intervention. There's a common maxim, and it goes like this: you can't manage what you can't measure. Instead of enacting common sense changes to rebuild our public health workforce and allow the CDC to have a clearer picture of the health status of our nation, this bill chooses to ignore our hollowed out public health system by underfunding key CDC programs for 5 years. I agree with Mr. Hudson's comment that the CDC really needs an overhaul. There are many shortcomings there, but this one, in terms of how information, public health data about outbreaks is being collected, is really shameful. It really is shameful. And we have, in my view, the responsibility to direct the redirection on that and reshape it and address it. What I'd like to do at this point is just have a colloquy with the chair and ask Do you plan to combine the ASPR and the CDC bills with the underlying PAPA bill before they come to the floor? Or going to the floor, have them combined?
We'll work with you on this.
Well, it's not my proposal. You're the ones that have chopped them up. That's why I'm asking, do you think that you're going to, do you have any intention to rejoin them?
Not at this point. We are working on these bills in subcommittee today. I believe that it is important that we move forward on PAPA. We all know that we have a deadline coming on September 30th. We are responsible for taking action to ensure that the nation is prepared as possible. This is subcommittee, and I am committed to continuing to work with the minority on reforms that we believe are important in PAPA, and those discussions will continue, and we'll make decisions later as to how we decide to bring the bills to the floor.
Okay, thank you. I yield back, Mr. Chairman.
Gentlelady yields back. Anybody else seeking discussion on the bill? I know there's 11 minutes left in the vote. However, they are trying to stick to the 20 minutes. So I know that's not been technically so much, but I think we probably will do one amendment if we can. We're going to break when it gets 5 minutes left for the vote, so it'll give us 15 minutes to get over there. So anyone seek recognition for the purpose of amendment? Are there any bipartisan amendments? Or are there any other amendments to the bill? What purpose, the gentleman from California seek recognition?
Mr. Chairman, I have an amendment at the desk.
The clerk will report.
Amendment to H.R. 4420, offered by Mr. Ruiz. Beginning
Gentleman is recognized without objection, the reading of the amendment is dispensed with, and the gentleman from California is recognized for 5 minutes.
Thank you, Mr. Chairman. The PAPA reauthorization process is an important opportunity every 5 years to take stock of our federal government's preparedness and response capabilities and hear from public experts, stakeholders, and those on the ground about what more we can be doing to protect our nation from emerging threats and infectious diseases and be better prepared for the next public health emergency or pandemic that could be coming. We have heard loud and clear that one essential way to improve our public health preparedness and response capabilities is to ensure that CDC has the authority it needs to receive standardized real-time data from state and local health departments in order to make recommendations and guidance decisions using the most up-to-date and accurate data. As former CDC Director Walensky testified earlier this year before this committee, the current way public health data is collected and shared has resulted in fragmented and inconsistent and slow reporting to CDC. Unfortunately, this means CDC is often considering data that is outdated, not standardized from locality to locality, and may not be able to provide the best forecasting and modeling as a result, and cannot best respond to surges and outbreaks in different areas of our country in the case of pandemics. We also heard from Dr. Raynard Washington, the director of the Public Health Department in Mecklenburg County, North Carolina, who testified that during COVID-19, there were often 3 different numbers reported from local, state, and federal partners in terms of what the disease burden was day to day. He noted that local, state, and federal officials are tasked with making million, billion, and even trillion-dollar decisions, often using that fragmented, outdated data. This is unacceptable, and we must ensure our federal public health agencies, along with our state and local health officials, have access to the streamlined, standardized data to improve public health decision-making. For this reason, my amendment would insert into the bill language of the Improving Data in Public Health Act, introduced by Representative Underwood, that would promote coordination between federal agencies to share critical public health data to prepare for, identify, monitor, and respond to public health emergencies, while also creating standards to improve the exchange of electronic health information. The amendment would also establish an advisory committee to ensure that healthcare data reporting and sharing processes are carried out as effectively as possible, and will provide resources to healthcare providers, community-based organizations, and others to develop and disseminate best practices in the collection and sharing of electronic health information. This provision is supported by numerous public health and healthcare provider organizations, including the American Academy of Family Physicians, the American Public Health Association, the Association of Public Health Laboratories, the National Association of County and City Health Officials, and the Trust for America's Health, et cetera, et cetera. This is a critical opportunity to improve our nation's public health preparedness and response, and I hope my colleagues will be joining me in supporting this common sense amendment that will help our nation better respond with data. As a physician and a public health expert and a scientist, if you can't measure, you can't improve it. We need to measure so that we can have real-time, quick, rapid response based data so that we can better move resources, better make wise decisions in those resources and strategies and guidelines. And with that, I yield back.
The gentleman yields back. Anyone seeking? Chair will recognize myself to speak in opposition of the amendment. I move to strike the last word, and I'm recognized for 5 minutes. I'm speaking in opposition to the amendment. This amendment significantly expands required data that must be shared to the CDC. This amendment will require that the exchanges capture and use personal data, including race, disabilities, age, and other personal information. Matter of fact, it says other elements, I believe. It doesn't describe what other data can be brought forward in the actual text. So the questions still remain on how CDC has used Americans' data throughout COVID-19. We must continue our work to conduct oversight on how the agency operated throughout COVID-19 public health emergency before we consider giving them any additional authorities. This is an example of government overreach at its finest, requiring that your local healthcare provider report your sensitive personal information to the federal government. I urge my colleagues to oppose the amendment. And I also suggest that my colleagues, they would support Mr. Hudson's legislation, which includes a bipartisan proposal that I work with Mr. Peters to require GAO to study how CDC used their data collection authorities permitted under the PHE and public health emergency, and as we specifically want to know what CD uses data authorities during the declared public emergencies, including whether these authorities were redundant or overutilized, and it's a bipartisan solution. It's actually included in the underlying bill. I will yield back. I said we'll let you go in five. It's 5:06. Is anybody else wants 5 minutes left in the vote? So add another 5 for, I did the math on Obernolte, looked at me, I said 15 minutes, 10. Any further discussion? We can go to the vote on the amendments. Any vote? You want a roll call vote? You're going to want a roll call vote on the amendment? Okay, so we will adjourn and we'll come back and do the first business will be the roll call vote. Recess. The committee is recessed. committee will come to order. When we recessed, the business before the committee was a roll call vote on Dr. Reese's amendment. And so I have a roll call being requested. The clerk will call the roll.
Chair Guthrie.
No.
Guthrie votes no. Burgess. Latta. Latta votes no. Griffith. Griffith votes no. Bilirakis. Bilirakis votes no. Johnson. Bouchon. Hudson.
No.
Hudson votes no. Carter. Carter votes no. Dunn. Dunn votes no. Pence. Pence votes no. Crenshaw. Joyce. Joyce votes no. Harshbarger. Miller Meeks. Obernolte. Obernolte votes no. Eschew. Eschew votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Ruiz. Ruiz votes aye. Dingell. Custer. Custer votes aye. Kelly. Kelly votes aye. Badagan. Badagan votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Trahan. Trahan votes aye. Pallone. Mr. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes no.
How's Dr. Bouchon recorded?
Dr. Bouchon is not recorded. Bouchon votes no.
How is Dr. Miller Meeks recorded?
Dr. Miller Meeks is not recorded. Miller Meeks votes no.
How's Mr. Cardenas recorded?
Mr. Cardenas is not recorded. Cardenas votes aye.
We got who? Is Mr. Bilirakis recorded?
Mr. Bilirakis is recorded as no.
We'll wait a couple more minutes. Do you have everybody back that needs to be back? Do we know if Dr. Burgess is? No, he's coming back. Dr. Burgess? We've got one more coming, it looks. How is Ms. Harshbarger recorded?
Ms. Harshbarger is not recorded.
Yes, who's not recorded? Can you ask? the
Harshbarger
clerk who
votes
is
no.
not recorded?
Will the clerk report who has not been recorded?
Mrs. Dingell is not recorded. Ms. Blunt Rochester is not recorded. Ms. Schreier is not recorded. Dr. Burgess, Chair Johnson, and Mr. Crenshaw are not recorded.
How is Dr. Shire recorded?
Schreier is not recorded. Yes. Schreier votes aye.
Nobody's walking up? Give about another 30 seconds and we'll. Staff's not here stopping us. The clerk will report.
Chair, on that vote, there were 11 yeas and 14 noes.
With 11 yeas and 14 nays, the amendment is not agreed to. Are there further amendments to the bill? What is the purpose of Mr. Pallone seek recognition?
I have an amendment at the desk, Madam Clerk.
His staff's. The clerk will report.
An amendment to H.R. 4420 offered by Mr. Pallone.
Without objection, the reading of the amendment is dispensed with, and the gentleman from New Jersey is recognized for 5 minutes for the support of the amendment.
Thank you, Mr. Chairman. It's very disappointing to me that we're considering an 8-page bill to reauthorize only a handful of critical PAPA provisions because Republicans don't want to find a bipartisan solution to reauthorize our public health preparedness and response capabilities. Republicans have put forward a partisan vehicle designed to shield amendments and debate from taking place during this markup. And that's why I'm forced to offer this amendment that would ensure these programs are reauthorized on time, but would also bring us back to the table sooner than 5 years from now so that we can finally have a discussion on how to adequately fund and enhance our public health preparedness and response capabilities. My amendment would also increase funding for the Public Health Emergency Preparedness, or FEPA grants. These grants serve as our core federal resources for state and local public health preparedness and response, and it's critical we provide adequate resources on the ground so we aren't caught flat-footed in the future like we were during the early days of COVID-19. And then I'm also disappointed that my Republican colleagues have been unwilling to consider enhancing public health data authorities for CDC, as was proposed by Congressman Ruiz in his last amendment and his bill. We don't need to study whether providing streamlined, up-to-date, standardized data to our federal public health agencies is needed. We don't need the GEO study because we know this data is needed. Section 107 is highly duplicative of other requirements already enacted under the end-of-the-year omnibus and only kicks the can down the road instead of finding real solutions to ensure our public health agencies can provide guidance in real time that reflects accurate data from localities and states. And that's how we improve our public health preparedness and response. And it's unfortunate that Republicans refuse to support this. So for these reasons, I urge my colleagues to support my amendment to ensure that we can reauthorize these programs on time, but also make clear that there's a lot more work to be done. And I hope that the Republicans, if not today, at some point would join me in this effort. And with that, I yield back, Mr. Chairman.
The gentleman yields back. Anyone else seeking recognition on discussion of the amendment? What's the purpose of the gentleman from North Carolina seek recognition?
Strike the last word in opposition to the amendment.
Gentleman's recognized for 5 minutes.
Thank you, Mr. Chairman. This amendment is another amendment to delay reauthorization for 2 years. An extension is a last resort that hopes we won't face a public health emergency in those 2 years. This is another short-sighted and dangerous amendment. It's further discouragement for innovators, and this is another violation of Speaker protocol and Cutco rules. I urge my colleagues to oppose this amendment, and I yield back.
Gentleman yields back. Any further discussion on the amendment? You want a roll call? Seeing no further discussion on the amendment, a roll call being requested. The clerk will call the roll.
Chair Guthrie.
No.
Chair Guthrie votes no. Burgess. Burgess votes no. Latta. Latta votes no. Griffith. Griffith votes no. Bilirakis. Bilirakis votes no. Johnson.
No.
Johnson votes no. Bouchon.
No.
Bouchon votes no. Hudson.
No.
Hudson votes no. Carter. Carter votes no. Dunn. Dunn votes no. Pence. Pence votes no. Crenshaw. Joyce. Joyce votes no. Harshbarger. Harshbarger votes no. Miller Meeks. Miller Meeks votes no. Obernolte. Eschew. Eschew votes aye. Sarbanes.
Got you right in the middle of a bite.
Sarbanes votes aye. Cardenas. Ruiz. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Badagan. Badagan votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes no.
How's Mr. Crenshaw recorded?
Mr. Crenshaw is not recorded. Crenshaw votes no.
How's Dr. Ruiz recorded?
Dr. Ruiz is not recorded. Dr. Ruiz votes aye.
Here she is. How's Dr. Schreier recorded?
Dr. Schreier is not recorded. Schreier votes aye.
That should be. He wasn't here last vote. Anyone else seeking recognition for voting? Seeing none, the clerk will report. How is Mr. Cardenas recorded?
Mr. Cardenas is not recorded. Cardenas votes aye.
Good job. Anyone else? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 12 yeas and 16 noes.
The amendment, with 12 yeas and 16 noes, the amendment is not agreed to. Are there any further amendments? Seeing none, the question now occurs on forwarding H.R. 4420, not amended, to the full committee, 4420 to the full committee. All those in favor will say aye. Aye. All opposed will say no. Independent of the chair, the ayes have it. I'm not asking for one, or you want to? You, okay. So the gentleman from New Jersey asked for a roll call vote, so roll call being requested, the clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson.
Aye.
Hudson votes aye. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Mr. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Eschew.
No.
Eschew votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Kelly votes no. Badagan. Badagan votes no. Blunt Rochester. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers. Chair Rogers votes aye.
Anyone seeking recognition? Dr. Ruiz?
Ruiz is recorded as no.
Anyone else seeking recognition for a vote? Seeing none, the clerk will report.
Chair Guthrie, on that vote, there were 16 ayes and 12 noes.
With 16 ayes and 12 noes, the bill is agreed to. The chair calls up H.R. 4529 and asks the clerk to report.
H.R. 4529, a bill to amend the Public Health Service Act regarding guidance documents of the Centers for Disease Control and Prevention and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek to be recognized for the bill? What purpose, the gentlelady from, the chair from Washington?
Strike the last word.
The gentlelady is recognized for 5 minutes.
Thank you, Mr. Chairman. I wish to speak in support of H.R. 4529, the Public Health Guidance, Transparency, and Accountability Act of 2023. Over 25 years ago, this committee worked together to make sure that guidance released by the Food and Drug Administration still had some type of process for input and was clearly noted as guidance, rather than regulation enforceable by law. FDA has been able to implement that requirement in a way that allows for stakeholder comment and allows for quick release of information in the case of an emergency. It is time CDC does the same. We saw over and over how guidance, 6 feet distancing, for example, was taken by businesses, states, localities to be undisputed, best science, and required. What if there had been a public docket opened on that guidance, where school administrators could have noted that guidance is forcing schools to stay shuttered longer, where substance use disorder treatment programs could have indicated the same, where data from around the world suggesting 6 feet didn't really have any scientific significance could have come in. Former Director Walensky finally acknowledged in March of 2021 that 6 feet of distance was a primary hurdle for wider reopening of classrooms and said CDC would review. CDC guidance wasn't changed until over a year later. CDC's insistence on recommending masking toddlers was another example where the agency was a global outlier and failed to consider not only other educational concerns like speech development, but also recommendations of other Western public health agencies. Good guidance practices would speed up that whole process, from allowing the public a clear process to flag potential consequences and quickly signal the risk of policy that outweighs the benefits. CDC may have good scientists, but they do not have the only scientists and experts. And it's not just CDC scientists who have had input on these problematic guidances. Teachers' unions influence CDC's guidance on reopening schools based on politics and self-interest, not science. This bill will open up CDC's insular culture and decision-making process to more outside voices, not just the administration's political allies, and bring much-needed transparency to the process, leading to better results based on evidence and science. Each of us represents a district with brilliant constituents who bring expertise and perspectives that could improve the quality of guidance CDC is releasing. A transparent and accountable guidance development process, one that is visible to outside experts and the public and open for public comment, can help rebuild trust in the agency. We received technical feedback from CDC yesterday, and I plan to look at and update the bill if necessary ahead of full committee. I yield back.
The gentlelady yields back. Any further discussion on the bill? Gentleman from Maryland, what purpose do you seek recognition?
Move to strike the last word, Mr.
Gentleman's recognized.
I'm speaking in opposition to the bill. Over the past 3 years, we've certainly learned the important role that our public health agencies play in keeping our communities safe and just how critical it is that we have timely, adequate information sharing between federal, state, and local partners when we are responding to these health crises. That's why I'm disappointed in this bill that we're considering now, which will tie the hands of the CDC in a way that will slow down its ability to share vital health guidance, hinder its dissemination of updated information, and frankly, impede our public health response efforts at every level. That's going to be the practical impact of legislation like this. At the beginning of the pandemic, we saw just how quickly emergency situations can change and how quickly our public health responses need to change alongside data received and facts on the ground in order to keep up. We should be working to enhance the nimbleness of CDC and other public health agencies and bolster our data collection, tracking, and sharing capabilities. But the bill before us does the opposite. According to technical assistance feedback the committee received, the bill could even be interpreted to limit the CDC's ability to provide infection prevention and control guidance that is designed to improve the safety of patients, nursing home residents, and healthcare workers. Such a limitation would endanger patients and providers alike and result in increased confusion and public health risks. This is not the time to try to undermine our public health institutions. It's time to build them up, make them stronger so that we can better respond to the health challenges we face today and be ready for the next public health crisis. I urge the committee to consider different legislation that would meaningfully improve the ability of the CDC to collect, analyze, share data, and provide guidance on the proper public health response to such data to our state and local partners and the public. And I urge my colleagues to join me in opposing this legislation. Let's look at an alternative approach that can really strengthen the CDC's capacity. With that, Mr. Chairman, I yield back.
The gentleman yields back. Anyone else seeking recognition to speak on the bill? Seeing none, we'll move to amendments. Are there bipartisan amendments to the bill? Are there any amendments to the bill? Seeing none, the question will be on reporting HR 4529 to the full committee. All those in roll call vote. I will request a roll call vote. So a roll call vote is requested. All those in favor vote aye. Those vote no. The clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Griffith. Mr. Griffith. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Hudson. Carter. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Eschew.
No.
Eschew votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Barragan. Barragan votes no. Blunt Rochester. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers. Chair Rogers votes aye. Dr.
Dr.
Ruiz is not
Ruiz?
recorded. Ruiz votes no.
Dr. Bouchon, have you recorded?
Dr. Bouchon is not recorded. Aye. Bouchon votes aye.
Mr. Griffith?
Votes aye.
Griffith votes aye.
Anybody in your?
Mr. Carter is not recorded. Carter votes aye.
Anyone? Seeing no one else for the roll call, the clerk will report.
Chair Guthrie, on that vote, there were 14 yeas and 11 noes.
With 14 yeas and 11 noes, the ayes have it, and the bill is agreed to. The chair calls up H.R. 4381 and asks the clerk to report.
H.R. 4381, a bill to amend the Public Health Service Act with respect to the determination, termination, and renewal of public health emergencies and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. And I seek recognition, and the chair recognizes himself for 5 minutes to speak on the bill. I'm proud to co-lead this bill with Dr. Murphy, which would give Congress the ability to vote on extending or terminating a public health emergency after a PHE, after it has been renewed twice, or 6 months after its original declaration. I support the flexibility the PHE statute provides the executive branch to respond to emerging public health threats. It is imperative to keep our communities safe during uncertain times. But I believe Congress also has a role in ensuring our resources are being appropriately deployed during such outbreaks. I believe this legislation strikes that balance. In fact, we mirrored this legislation to the National Emergencies Act, which provides the same level of flexibility to the executive branch while giving Congress the appropriate oversight role. Unlike the National Emergencies Act, Section 319 of the Public Health Service Act gives full discretion of overseeing the public health emergency declaration process to the executive branch and does not explicitly give Congress a role in overseeing this process. We had a 100-year pandemic, and we didn't have a role directly in overseeing the processes moving forward. Congress must have oversight given the magnitude of PHE has. The COVID-19 public health emergency was extended 12 times over the course of 3 years. We've seen how much of a drastic socioeconomic impact the COVID-19 PHE had on our kids and others in the community struggling from a loss of a job or because they lacked access to critical behavioral health care services during the PHE. We must pass this bill to restore Article I authority in order to ensure Congress is a part of the equation when determining when a public health emergency ends, restore confidence in our public health institutions, and appropriately respond to emerging threats. I yield back. Is there any discussion on the bill? Mr. Cardenas, or purpose you seek recognition?
Move to strike the last word.
Gentleman is recognized for 5 minutes.
Thank you, Mr. Chairman. I'm concerned that we're determined to repeat the mistakes of our recent past. We saw time and time again in our response to COVID-19 pandemic that when members of Congress insisted on putting politics ahead of public health, the results were catastrophic. We even witnessed then President Trump encourage people to try putting bleach in their body to fight COVID-19. Dios mío, my God. This bill is merely an attempt to ensure politics, not science, gets the final say on every public health emergency going forward. Specifically, this bill requires a vote or multiple votes of politicians in order to maintain emergency authorities for our public health specialists. But think about the consequences of a proposal like this. We all remember when members of the Republican conference insisted that COVID-19 was, quote, a mild flu, or, quote, no big deal, even as thousands died every day from this deadly disease. If this is their record on making public health determinations, I would much prefer we leave it to the experts. We must keep politics out of this. Thank goodness our public health leaders, doctors, nurses, were on the front line and were able to use tools such as vaccines authorized for emergency use and were able to quickly communicate with the American people about new variants and risks. I can only imagine how much worse it could have been. Our public health experts deserve our scrutiny and our attention. But just like patients go through their doctor for their health advice rather than politicians, we must rely on our public health officials to tell us that a public health emergency is upon us. If this bill were to become law, we risk a political decision about when emergency authorities expire rather than one based on science and reality on the ground. In fact, we received technical assistance that confirmed that, and I quote, the authority to issue and renew a public health emergency declaration should remain with the Secretary of the Department of Health and Human Services, given the expertise and clinical, scientific, and public health personnel health within its operating divisions, and the staff who can support the information gathering and analysis needed in making these determinations, end quote. Unfortunately, this is just one more area where Republicans have shown that they failed to learn from the COVID-19 pandemic. We should be working together on real policies to improve our public health preparedness and ability to respond, not playing partisan games while the next threat is lurking. I urge my colleagues to vote no on this bill, and I yield back.
The gentleman yields back. Anyone else seeking recognition on the bill? The gentleman from, what purpose is the gentleman from Indiana seek recognition?
I move to strike the last word.
The gentleman is recognized for 5 minutes.
I just need to push back a little bit on the comments of my colleague on this partisanship on the COVID pandemic. I mean, many of the statements are just blatantly false. And, you know, during Operation Warp Speed, that was a Republican administration. We had trouble in rural America getting people to get vaccinated because the now Vice President of the United States said that she wouldn't take a vaccine because the Trump administration developed it and it might be dangerous. So I just think, you know, there's culpability to go all around when you're in the middle of a 100-year pandemic. But, you know, you want to talk about partisanship, almost the entire statement of my colleague was partisan and false. So if we really want to work together, we need to stop talking like that. I yield back.
Gentlemen, yield.
I will yield.
So I've sat through a lot of this today, and it's been hard to listen to. But look, I remember as that pandemic started, the administration made multiple, not classified briefings, but member-only briefings available to each and every one of us. We went over to the big auditorium over in the Capitol Visitor Center. All the people from Public Health came and shared with us what they knew, but it wasn't that anyone was hiding anything from anyone, and all of us had the same information. We had the same information that the President of the United States had. Now look, I was extremely aggravated during the month of February 2020. Our Oversight and Investigations Subcommittee, our Health Subcommittee did not have the proper, I thought, attention to this problem that was boiling up half a world away. We had hearings on ticket stubs. We had hearings on horse races. But we didn't have hearings on what was our pandemic preparedness. And then here's the sad part. This committee had just passed the Pandemic All Hazard Preparedness Act, the previous reauthorization, signed into law in June of 2019. We didn't even take the shrink wrap off the law and look at, was this working as we thought it would? And you know what? It wasn't, because we were preparing for pandemic flu, and this was something entirely different. No one knew ahead of time that this was going to be an illness that, yes, it's transmissible, but it can be silent for 14 days. You're exposed, and it's 14 days later before you get symptoms. So the universe of people that you came in contact with, it made it virtually impossible to do contact tracing. Now, we finally had a hearing right at the end of February. It was a budgetary hearing. Dr. Fauci and Dr. Azar, Alex Azar, Secretary Azar, came and sat at the table. And we asked them, was this going to be different from the SARS epidemic of 2003? And they assured us, no. Normal public health measures in the SARS epidemic in 2003, contact tracing, quarantine, normal public health measures were enough to succeed in that environment, and it would be enough this time, but it wasn't. That 14-day interval is what blew that all up. So I agree with my friend from Indiana. Let's stop the revisionist history. This was a tough problem. Many people did the best job they could, but the big beef that a lot of American people have with the so-called experts is the hubris. They would never have the humility to say, we weren't sure, and now we've reevaluated. You'd never heard those words come out of the mouth of Dr. Fauci, Dr. Walensky. It was always just do as we say. There were a lot of missteps that were made. I think we can learn from that experience. I hope we have tasked the FDA with providing us the after-action report. I hope we have tasked the CDC with providing us their after-action report. Yes, let's learn from that. Let's build on that. But let's not involve in revisionist history. It just makes people mad, and it is not successful. I'll yield back to the gentleman from
Yeah,
Indiana.
reclaiming my time, I just want to say, I think everybody in the committee knows that my preference is always to work in a bipartisan way. Essentially, also, particularly on health issues, and I work with many of my colleagues on both sides of the aisle, but you know, revisionist history in these type of hearings and making inflammatory political statements is not helpful. You know, I mean, I could argue that Democrat politicians pushed career bureaucrats at the FDA to delay the vaccine through the election for political purposes. I believe that happened. Is it true? I don't know. But that's what happened. And in the meantime, thousands, if not hundreds of thousands of people couldn't get vaccines. So, look, we can both talk politics. Mistakes were made on both sides. It was a once-in-a-100-year pandemic, and we need to talk about the future, not the past. I yield back.
Gentleman yields back. Anyone else seeking recognition to speak on the bill? Seeing none, are there any amendments to the bill? Any bipartisan amendments? I don't believe it. Any other amendments to the bill? Seeing none, the question now occurs on forwarding H.R. 4381 to the full committee. Roll call. A roll call vote has been requested. The clerk will call the roll.
Chair Guthrie.
Aye.
Chair Guthrie votes aye. Burgess. Burgess votes aye. Latta. Griffith. Griffith votes aye. Bilirakis. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Eshue. Eshue votes no. Sarbanes. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Kelly votes no. Badagan. Badagan votes no. Blunt Rochester. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone.
No.
Pallone votes no. Chair Rogers.
Chair Rogers?
Chair Rogers votes aye.
Is Sarbanes recorded?
Mr. Sarbanes is not recorded.
Votes no.
Sarbanes votes no.
Mr. Latta?
Mr. Latta is not recorded. Latta votes aye.
Anyone else seeking recognition for a vote? Anyone on your side? Seeing none, the clerk will report.
Chair Guthrie, on that vote, we have 13 ayes and 12 nays.
I haven't announced the vote yet, so
Carter votes aye.
so I hadn't announced the vote yet.
Chair Guthrie, on that
Carter.
vote, we have 14 ayes and 12 nays.
So I will now announce the vote. With 14 ayes and 12 noes, the bill is agreed to. The chair calls up HR 3813 and asks the clerk to report.
HR 3813, a bill to accelerate the applicability of the requirement that the Director of the Centers for Disease Control and Prevention be appointed by the President by and with the consent of the Senate.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. I will recognize myself to strike the last word. The American people deserve strong leadership within our public health agencies. Through one-size-fits-all mask and vaccine mandates to politicized COVID-19 guidance to wide-scale economic shutdowns and school failures, it is clear our public health institutions could benefit from greater congressional oversight. In December, Congress took some steps aimed at holding these agencies more accountable to the American people. Notably, federal law now requires Senate confirmation of the CDC director starting in 2025. We simply cannot operate on a business as usual and must continue to hold our nation's public health officials to the highest possible standards, including ensuring these individuals will be guided by science and operate transparently with the American people. My legislation would simply move up the timeline for CD director confirmation to 6 months after enactment. Further, as CDC continues its internal restructure, Congress must ensure CDC is effectively prepared for future infectious disease outbreaks. Urge my colleagues to support this legislation, and I will yield back. Anyone seeking discussion? The gentleman from New Jersey, what purpose do you seek recognition?
To strike the last word in opposition.
Gentleman is recognized.
Mr. Chairman, right now in the Senate, and you know I'm usually critical of them, hundreds of members of our military are being blocked from moving up in rank, and for the first time since 1859, the Marine Corps is without a confirmed leader due to a hold from just one senator. Another senator has pledged to block all nominees of the Department of Justice, while another has pledged to block the new director of NIH, and this is not unusual. Individual senators often use their power over personnel to block appointments, not necessarily because senators have any concerns about the nominee's qualifications, but rather because of politics unrelated to the nominee or even the department where they would serve. So this legislation would immediately put the director of the Centers for Disease Control and Prevention in the middle of this political morass of the United States Senate. Earlier this week, Dr. Mandy Cohen was sworn in as our new CDC director. If this legislation were to go into effect, she would immediately be removed from that position and placed in acting status while the Senate stalled on her nomination. This would leave our lead public health agency without a permanent leader to focus on the agency transformation that was started by her predecessor or carry out the tasks that we're asking her to do in the PAPA reauthorization bills the majority has offered today. It would also invite unnecessary political interference into public health, preparedness, and response. I believe we need a director of the CDC to hit the ground running to address the public health threats that are out there, whether that's an outbreak of measles or the next novel pandemic. The Senate has frankly proven to be incapable of doing anything quickly. You've heard me say that a million times. And it would be a mistake to leave the CDC without a permanent leader at this time. Once again, politics are driving the GOP agenda on public health, and once again, we should reject this attempt because I do think it undermines the CDC. So I urge my colleagues to oppose this legislation, and I yield back.
The gentleman yields back. Anyone else seeking? What purpose is the gentleman from Indiana?
I move to strike the last word.
Gentleman's recognized.
I want to speak in favor of the legislation. One of the biggest problems we currently have at the CDC is political interference. I had conversations with Dr. Redfield and Dr. Walensky about this, and we need to do all we can to try to minimize political interference. And to do that, maybe having to be Senate confirmed will encourage presidents to appoint less partisan people. Because I can tell you, I'm a physician, but that doesn't mean physicians out there in practice don't have political viewpoints, because they all do. And I think it would be important for congressional oversight for the U.S. Senate to have one in front of their committee where they can do a deep dive into their, not only their scientific background, but where they are as it relates to minimizing political interference in their career. Because honestly, most people that get appointed to CDC are going to be academicians, people at academic medical centers, and people who have a long history of being engaged in the political process. So I want to speak in favor of this because I think our current CDC directors are put under a tremendous amount of political influence, and that is a shame. And maybe the fact that having to be Senate confirmed would help to minimize that situation. So I'm in support of this legislation.
Gentlemen, yield.
I will yield.
Yeah, I just want to say that there's some truth, I mean, accurate what you said, except if this bill was enacted today, if the president signed it today, then the new CDC director would not be acting. She would actually be director for 6 months, and then she would have to go to have 6 months for the Senate to confirm. And I think some of the examples that you have cited get frustrated. It frustrates me as well for some of the people that are lingering in the Senate that need to be confirmed. I mean, we have ambassadors when a new president comes in, it takes they get appointed in January, they don't get put into until August. But I don't think that we want to undo, and I know we can't do it legislatively, but we don't want to undo the advise and consent responsibility of the Senate. And so I think that high-level officials, particularly as we've seen in the CDC, it's important that they are Senate confirmed. It gives the legislative branch, not us, unfortunately, but the legislative branch the ability to at least question and ensure these and give advice and consent. And so I think, but there's been a proposal to take the CDC, because right now it's 2025 when it takes effect. There's been a proposal to just take the CDC director out from being confirmed at all. And I just think that's, even though frustrated with the Senate, we all can be, that's just not proper for us, in my opinion. But I will yield back to my friend from Indiana.
Reclaiming my time, I want to agree with what the chairman just said. I think the Senate has been frustrating under administrations on the Republican and Democrat side about timeliness of confirmation, but that's not a reason, in my view, dysfunction in the Senate to not have someone Senate confirmed. I mean, we could make that argument for the Secretary of State, for the Secretary of Defense, and as the ranking member pointed out, there are high-level military people right now being held up by essentially one senator, which is something that's frustrating. But that doesn't mean that we shouldn't try to do as much as we can to depoliticize the CDC and regain the confidence of the American people in the CDC. That's another one. If you have a chance to publicly vet and publicly discuss with the proposed or nominee for the CDC director, it can be in a public forum and help regain the confidence of the American people in the future of the agency, which right now is lacking. And so I support the legislation. I yield back.
The gentleman yields back. Any further discussion on the bill? Seeing none, are there any bipartisan amendments to the bill? Are there any amendments to the bill? Seeing none, roll call vote being requested. Get to the question now occurs on forwarding HR 3813 to the full committee. The roll call has been requested. The clerk will call the roll.
Chair Guthrie.
Aye.
Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Eschew. Eschew votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Kelly votes no. Badagan. Badagan votes no. Blunt Rochester. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers.
Is there anyone who have not answered the roll call? Is chair coming? Okay. Anyone on side? See no one? The clerk will report. Clerk will report.
Chair Guthrie, on that vote, we had 14 yeas and 12 noes.
The chair will announce the vote. 14 ayes and 12 nays. The bill is agreed to. The chair calls up H.R. 3836 and asks the clerk to report.
H.R. 3836, a bill to facilitate direct primary care arrangements under Medicaid.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. Does anybody seek recognition on the bill? What is gentleman for Texas seek recognition?
Move to strike the last word.
The gentleman is recognized.
Chairman, thank you for bringing this to the committee. You know, when we talk about the critical issue of healthcare access, I think we have to consider two very important factors: empowering patients and establishing a viable entry point. And one solution that cuts through all the bureaucratic red tape is direct primary care. And I want to break that down for you. Direct primary care offers unlimited access to a primary care physician for a recurring monthly payment. And it hinges on the most crucial relationship in healthcare, that bond between the patient and the doctor. Direct primary care holds tremendous potential in tackling the skyrocketing costs of emergency room visits within the Medicaid population because it fosters a more direct and personal patient-physician relationship. It also opens up a whole new avenue of care for Medicaid patients, grants them access to a fresh pool of highly skilled physicians. Now, in the current system, many primary care doctors simply cannot sustain their practice due to the woefully inadequate Medicaid reimbursement rates. So this adversely affects Medicaid recipients because they require primary care just like the rest of us. And just like the rest of us, primary care is the entry point into healthcare. So they deserve the same standard as everyone else. So I've joined forces with my friend Representative Schreier to introduce this bipartisan bill. Our legislation is very straightforward, very simple, small step. It offers opportunities to expand primary care access for Medicaid recipients. How? By clearly stating that current law does not prohibit direct primary care arrangements within the Medicaid program, while also providing guidance for states that wish to incorporate direct primary care into their unique Medicaid system. It is a small step, but it's significant, and it's in the right direction. It paves the way for delivering an innovative care model to a population that is genuinely in need, and I hope we can move forward with this in a truly bipartisan manner. Thank you, and I yield back.
The gentleman yields back. Is anyone seeking for discussion on the bill? Seeing none, are there bipartisan amendments to the bill? Are there other amendments to the bill? Gentleman from Texas? Do you have an amendment to the bill, nature of a substitute? Clerk will report.
Yes.
Clerk will report the amendment.
Sorry, Chairman, I do have an amendment at the desk.
No problem.
An amendment in the nature of the substitute to H.R. 3836, offered by Mr. Crenshaw of Texas.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized in support of his amendment.
I think I was out of order there, so I think you heard me.
Any
Thank you,
discussion?
Chairman. I yield back.
Any discussion on the amendment? Seeing none, Are there any amendments to the amendment in nature of a substitute? Seeing none, so. I got it here. If there's no further discussion on the amendment, the vote occurs on the amendment in the nature of a substitute. We'll do this by voice. I believe that all those in favor shall signify by saying aye. Aye. All those opposed, no. The ayes have it, and the amendment is agreed to. The question now occurs on forward in H.R. 3836 as amended to the full committee. A roll call has been requested, and the clerk will call the roll.
Chair Guthrie.
Aye.
Guthrie votes aye. Burgess. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Hudson. Carter. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo.
Aye.
Eshoo votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Badagon. Badagon votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes aye.
How is Dr. Burgess recorded?
Dr. Burgess is not recorded. Burgess votes aye.
How is Mr. Griffith recorded? Oh, is it Griffith or Carter? Carter, how's Mr. Carter recorded?
Mr. Carter is not recorded. Carter votes aye.
Dr. Bouchon?
Dr. Bouchon is not recorded. Bouchon votes aye.
You on your side? Is that everyone? The clerk will report.
Chair Guthrie, on that vote, we had 28 ayes and 0 nays.
With 28 ayes and 0 nays, the bill is agreed to. The chair calls up HR 4531 and asks the clerk to report.
H.R. 4531, a bill to reauthorize certain programs that provide for opioid use disorder prevention, recovery, and treatment, and for other purposes.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point so ordered. The chair will recognize myself for 5 minutes to speak on the bill. We all know why this legislation is important. Year over year, drug overdose deaths have reached record highs, exceeding nearly 110,000 deaths in 2022 alone. This surge comes alongside a fentanyl-driven rise in overdoses. In my home state of Kentucky, 70% of those overdose deaths are due to fentanyl. Each of these 110,000 people have families and loved ones that are impacted across America. We work to schedule fentanyl in the Halt Fentanyl Act, and we need to schedule another dangerous drug, xylazine. But this bill does that to level 3, but it also reauthorizes critical federal programs first offered by this committee 5 years ago that provide critical resources to those seeking to overcome their substance use disorder. Among these reauthorizations is the Comprehensive Opioid Recovery Center, the CORCS, which I led in the last session, or the last bill. The CORCS program is responsible for providing wraparound treatment and recovery support services, including workforce training to individuals living in communities with disproportionately drug overdose rates. I have fellow colleagues from Kentucky. Representative Barr has a bill that will reauthorize targeted workforce training grants for individuals in recovery, and Representative Rogers will ensure that we have enough providers providing loan repayment transfers. This bill also includes significant resources dedicated to preventing overdose deaths to reduce opioid dependency, providing for enhanced funding for state-level prescription drug monitoring by allowing federal funding to use for fentanyl and xylazine testing strips, and by states where they're illegal, and by helping to ensure Medicaid provides access to all FDA-approved overdose reversal medications. However, I note that the underlying legislation does not include provisions lifting the IMD exclusion, which I believe is needed. I look forward to working with my committee colleagues to find ways to offset and pay for lifting this arbitrary and antiquated policy. In closing, I remain optimistic that our continued bipartisan efforts will help us turn the tide and change lives. I thank my colleagues for joining me, and I look forward to advancing this legislation to the full committee today. I will yield back, and anyone seeking the chair, what purpose is the gentleman from New Jersey seek recognition?
Move to strike the last word in support
Gentleman
of
is
the bill.
recognized.
Thank you, Mr. Chairman. Despite there being a lot of partisan bills being considered today, I'm pleased that the Support Act package before us is a bipartisan effort. 5 years ago, we all worked together on a bipartisan basis to create a number of new programs to address the ongoing opioid epidemic. Over the last 5 years, this law has expanded treatment options in Medicare and Medicaid, allowed more providers to prescribe medication-assisted treatment, and made important investments in public health. So today, we're building on that important work. The package before us will reauthorize critical programs included in the Support Act. These include a number of programs for particularly vulnerable populations. I'm very glad that we are reauthorizing the program to expand residential treatment for pregnant and postpartum women. I'm also glad that we are reauthorizing programs to train first responders, support recovery centers, and bolster the behavioral health workforce. In addition to reauthorizing existing programs, this bill includes some important new provisions, such as expanding access to life-saving resources like fentanyl and xylazine test strips. However, as I said in my opening statement, I'm disappointed that the markup does not include policies that will help justice-involved populations access Medicaid, and particularly the Bipartisan Medicaid Reentry Act and the Due Process Continuity of Care Act would ensure that these vulnerable populations are able to access the care they need when they reenter society or await trial. We know that individuals reentering society after incarceration are at higher risk of an overdose than others. Connecting them to coverage and treatment prior to their release can mitigate these harms. I also think it's bad that we take away individuals' Medicaid coverage while they're in pretrial detention. These are people who have not been convicted of a crime. Many may only be incarcerated because they lack the resources to afford bail. And both of these bills enjoy broad bipartisan support and support from law enforcement, so I'm disappointed that they were not part of this package, but I'm hopeful that the chairwoman will continue to work with me so that we can include these important policies when we consider this bill at the full committee level. In that same spirit, I look forward to continuing to work on xylazine and what a public health response to its emergence looks like. I thank my colleagues for working with me on this issue. I want to make clear that while I'm glad we have found a path forward today and that I can support, I want to note for the record that I continue to be strongly opposed to H.R. 1839 as it was originally drafted. That approach would have applied criminal penalties to an FDA-approved drug without formally making it a controlled substance. I think that's a dangerous precedent that could be used by Congress to criminalize drugs with legitimate medical uses for political reasons. So there's no reason to go outside of the usual structure for how we deal with controlled substances. But thank you, Mr. Chairman. I do support the bill and thank all of us for working on a bipartisan basis to get this here today, and I yield back.
Thank you. The gentleman yields back, and the chair recognizes Mr. Latta. What purpose does Mr. Latta seek recognition?
Thank you, Mr. Chairman. Move to strike the last word.
Gentleman's recognized.
Thank you, Mr. Chairman. Today is a somber reminder we're continuing to fight the uphill battle against an enemy, ruining families, destroying communities, and most tragically, stealing lives. I can't emphasize enough how critical the original authorization of the Support Act was and how important it was that we came together, not as Republicans or Democrats, but as Americans to finally fight back against substance use disorder. Addiction can happen to anyone. Addiction knows no boundaries. Addiction is ravaging our youth, and addiction is killing our loved ones. The authorization of the Support Act cannot come at a more critical time. Tragically, for a second year in a row, there were over 109,000 drug overdose deaths in the United States. Much of this can be directly contributed to over 73,000 poisoning deaths due to fentanyl and fentanyl-related substances. Prior to the COVID-19 public health emergency, it appeared we were finally taking a step in the right direction to curb substance abuse. However, with lockdowns, tremendous fear of the virus, and limited human interaction that all resulted from the pandemic, a perfect storm developed for individuals to experiment and develop a dependence on substances. In addition, new illicit substances like xylazine and fentanyl analogs have made it much harder for law enforcement to hold criminals accountable. I'm proud the House passed the Fentanyl Act earlier this year, but this is just the tip of the iceberg. Treatment before tragedy is real, and we can fix this. With improvements and extensions such as the Trauma-Informed Care Task Force Reauthorization Act, legislation I'm co-leading with the gentleman from California's 25th District, I'm optimistic the SUPPORT Act will allow us to be better positioned to provide resources to those suffering, expand access to care, and most importantly, stop these poisonings. I'm looking forward to the day this committee won't need to address these entirely unnecessary poisonings, and pray that the reauthorization of the SUPPORT Act will be one step closer to a world without addiction. Mr. Chairman, I thank you for your leadership on this reauthorization, and I yield back the remainder of my time.
Gentleman yields back. Anyone? We're going to go down the order here. So, Mr. Cardenas, what purpose do you seek recognition?
To strike the last word, Mr.
Gentleman's recognized for 5 minutes.
Thank you. I want to thank my colleagues for including some critical provisions in the SUPPORT Act, including a bill I'm co-leading with Representative James, which would fund a center that provides technical assistance and other support to recovery community organizations and peer support networks. There's a lot of good in this bill. However, I do have some concerns, especially as it relates to our approach to combating the rise in xylazine use. First, let me say I'm disturbed by reports about the increased use of fentanyl laced with xylazine. This mixture can have absolutely devastating impacts on those who use it, and its resistance to interventions like Narcan make overdoses even more difficult to prevent. While I understand the rush to react, I urge my colleagues not to look at imposing harsh criminal penalties as the answer. The rise in xylazine use is a consequence of the fact we have an addiction crisis in our country. Individuals who are suffering from substance use disorder need compassionate care, access to services, and the ability to benefit from harm reduction measures. Criminal penalties often impact the individuals who are suffering the most from addiction. We should not be throwing people in jail for having a substance use disorder. I would caution against this approach, and I hope my colleagues and I can work together to agree on an effective, responsible public health response to the increase in xylazine use. And I yield the balance of my time to my colleague from California.
Thank you, Representative Cardenas. As I mentioned in our hearing on this issue in June, it's stunning how long we have been working to tackle the ever-evolving opioid crisis. And while I know we have made great strides and adopted policies to tackle many of these issues, fentanyl remains the leading cause of death for U.S. adults ages 18 to 45. That's why it is critical to examine these programs and extend the ones that are working. Substance use disorders don't just affect the person with a disorder. Entire families feel the ripple effects of substance use disorder, often suffering trauma as a result of their experiences. That's why in the SUPPORT Act, we created the Interagency Task Force on Trauma-Informed Care. We need to make sure that we are taking a holistic approach and treating the entire family appropriately in order to properly address the effects of this disease. The purpose of this task force is to solicit input from on-the-ground experts and then provide recommendations, including evidence-based best practices and a national strategy to address children and youth who have experienced or are at risk of experiencing trauma impacted by substance use disorder. Experts are the ones who are implementing these policies every day on the ground with real-life experiences informing their decisions, such as frontline service providers, educators, mental health professionals, and experts in infant, child, and youth trauma. That is why this task force is so important, because it includes the very people that need to be at the table as these decisions are being made. It is important to extend their authority so that they can continue their critical work. And I would like to thank the committee for including my bill, the Trauma-Informed Care Task Force Reauthorization Act, in this legislation, and I urge my colleagues to support its final passage. I yield back to Representative Cardenas.
Thank you. I thank my colleague who represents California's 25th District, and I yield back the balance of my time.
I'm done. Yeah, but we're arguing over our court here. The gentleman yields back. The chair now recognizes Mr. Bilirakis for 5 minutes for
Thank you.
speaking on the amendment.
Thank you, Mr. Chairman. I move to strike the last word. I want to issue my strong support for Chairman Guthrie's legislation, and I'm proud to co-sponsor the Support for Patient and Communities Reauthorization Act. This bipartisan bill, the package pulls together significant work our committee has done to reauthorize and strengthen critical opioid prevention and substance use order treatment policies that we enacted in the original Support Act in 2018. This includes a bill I co-lead with Representative Dingell, the Federal Interventions and New Detections, or FIND Fentanyl Act, which will reauthorize the pilot program for public health laboratories to coordinate with law enforcement agencies to better detect fentanyl and other synthetic opioids and stop it at its source. Importantly, this package also includes a bill I have been proud to lead with Representative Pfluger and Representative Panetta, the Combating Illicit Xylazine Act. This legislation reflects a sad reality we're seeing on the ground with the depressant drug xylazine being laced into fentanyl to create a sustained high feeling. It has absolutely horrific side effects on humans, such as severe skin ulcerations, blacked out sedation in a state of comatose, a heart rate stoppage leading to death. This is a growing public health crisis that has been recognized by ONDCP, DEA, FDA, and others across the country. And we must use every tool in the toolbox to address the substance abuse epidemic we have continued to face and that has evolved since we passed the original Support Act. However, we've also recognized that xylazine has been a legitimate and very safe and effective drug in animal use. I'll say it again, in animal use for decades. And we want to continue to allow the veterinarians, the cattlemen, and ranchers in farming communities to maintain access for legitimate purposes. I want to thank the committee leadership on both sides of the aisle for recognizing this crisis and the balance needed with xylazine, and for coming together and negotiating in good faith to include our legislation in the support package, which will place xylazine in a Schedule 3 of the Controlled Substances Act. Scheduling illicit xylazine in this faction will give law enforcement the tools they need to address the polysubstance crisis while still excluding from the schedule the legal use by veterinarians who rely on it to care for cattle and large animals. In short, this bipartisan package will strengthen the bipartisan work and start to address the shifting dynamics we faced in the overdose epidemic. I also remain hopeful that we can address the need to update our methods for tracking trends related to controlled substances and opioids, such as fentanyl. Addressing this crisis requires studying and understanding utilization of these illicit substances, better targeting our resources for care in real time. We have seen great strides in the utilization of the wastewater surveillance by the CDC through the COVID-19 pandemic. This type of testing tracks data accurately and can provide unique insights into public health response, all while maintaining individual privacy. I welcome the opportunity to work on this policy further, and hopefully we can include it in the next full committee level. I want to thank again my Democratic colleagues on the other side of the aisle for their interest to work with me on this particular issue, and I also want to thank again the Republicans on this side of the aisle. I think there's a lot of promise there. I look forward to working with all of you to see this through, and I thank you, Mr. Chairman. I yield back the balance of my time.
The gentleman yields back, and the chair recognizes the gentlelady from Michigan. What purpose does the lady seek recognition?
Mr. Chairman, I move to strike the last word.
Gentlelady is recognized.
Thank you, Mr. Chairman. Stories of loved ones, friends, and constituents losing their lives to addiction and overdose are just far too common, and they've become everyday stories. They are unnecessary tragedies. In 2018, this committee worked together to enact the Support Act to address the opioid crisis, and it did make progress. The number of opioid deaths began to fall after its enactment. But in the wake of a new and growing fentanyl and synthetic opioid crisis, deaths are again on the rise, and it's time to reassess our approach. As we work to respond to the evolving crisis, it is critical to reauthorize key Support Act provisions set to expire at the end of the year. For example, the Support Act authorized a pilot program to improve coordination between public health laboratories and those operated by law enforcement. Public health labs, which detect and monitor public health threats, and labs run by law enforcement, which often assist with crime investigations involving suspected controlled substances, can offer a unique insight into emerging opioid trends. Taken together, collaboration between the two can play a critical role in our nation's response to the synthetic opioid epidemic and help us track evolving threats. That's why I'm grateful the Fine Fentanyl Act, legislation which I led with my dear friend and colleague, Rep. Bilirakis, is included as part of H.R. 4531. The Fine Fentanyl Act will reauthorize the Support Act's lab pilot program through fiscal year 28, ensuring we can expand upon the progress and discoveries the program has already made. Thank you, Rep. Bilirakis, for joining me on this effort, and I want to express my thanks to Representatives Guthrie and Custer for their leadership on these issues. I know it's something we all care deeply about, and unfortunately, too many of us in this room have been personally impacted. I urge my colleagues to support this legislation, and I look forward to its advancing to the full committee, and I yield back.
The gentlelady yields back, and the chair recognizes the gentlelady from Washington, the chair of the full committee. What purpose you see recognition?
I would like to strike the last word.
Gentlelady's recognized.
Thank you, Mr. Chairman. The Support for Patients and Communities Reauthorization Act, Support Act, is a critical step to helping address the overdose and drug poisoning crisis. This bill reauthorizes key public health programs aimed at helping to support prevention, treatment, and recovery services for individuals with substance use disorder. It also includes a provision that places tranks in Schedule 3 of the Controlled Substances Act, which will allow veterinarians and ranchers to maintain access for animal use. Tranks has been detected in almost every state in our country, and the monthly percentage of deaths that involved illicit fentanyl and xylazine has increased by 276% over the last 3 years. That's according to the CDC. This will allow law enforcement to crack down on criminals who illegally traffic this harmful drug. I'm pleased by the progress we're making today on this important piece of legislation. Legislating is never easy, and it requires compromise on both sides to get things done. There are key policies that are missing from this package, and I hope to see included in the final markup, namely policies to lift the IMD exclusion. Additionally, I know members have expressed an interest in seeing policies to support people in the criminal justice system in getting the care after they leave incarceration. Two bills in question, the Reentry Act and the Due Process Continuity of Care Act, were included in our legislative hearing on the topic. However, CBO has informed us that these two policies together cost over $20 billion. As such, we're continuing to work to identify bipartisan ways to hold down these costs and pay for the overall package. A famous man once said, "You can't always get what you want, but if you try sometime, you might find what you want, you need. You get what you need." This committee has an incredible history of putting partisan, did I say that wrong? A famous man once said, "You can always get what you want, but if you try sometime, you might find you get what you need." Oh, you want me to sing it? Woo, that you don't really. Okay, this committee has an incredible history of putting aside of the partnership. I am very hopeful. I appreciate the work that's been done. I know there's important provisions that we're still going to work on this legislation, but just thank you everyone that's been a part of getting it to this point, and we'll keep working on it. I yield back.
The chairwoman yields back, and the chair recognizes my colleague on this bill, Ms. Custer What purpose you seek recognition?
I move to strike the last word.
The gentlelady from New Hampshire is recognized.
Mr. Guthrie and fellow members of this committee, I'm so proud to co-lead the comprehensive support for patients and communities reauthorization with our chair. This is a vital bipartisan package to empower communities across this country to respond to the tragic mental health and substance use disorder crisis gripping our nation. As my colleagues in this room know, we have no time to waste. In my home state of New Hampshire, recent data found that drug overdose deaths just within the last year rose faster than the rest of the country, nearing a decade high. Behind these horrifying statistics are families who are devastated by the loss of a loved one, first responders desperate for more resources to help save lives, and communities reaching their breaking point. So we must come together in support of this bill to deliver for our constituents, and that's where the Support Act comes in. This comprehensive package is an opportunity for Congress to respond to the complicated challenges of mental health and substance use disorder, and to update our approach to match how these issues have changed since we passed the original Support Act in 2018. From tackling growing workforce shortages to addressing the increased prevalence of co-occurring disorders and the introduction of new harmful adulterants, this bill addresses the most pressing issues facing our communities. When I first began my work establishing and co-chairing the bipartisan Mental Health and Substance Use Disorder Task Force back in 2015, I spoke to my colleagues from districts across the country about the issues facing my constituents: heroin, opioid misuse, and many members told me at that time they didn't have these problems in their communities, and it just wasn't a priority for them. The unfortunate reality now for all of us here today is that this is a problem in every single district across our country. And many of us share a personal connection, including myself, with someone who is impacted by substance use disorder and mental health challenges. The Support for Patients and Communities Reauthorization Act will help provide tools to address these issues, to save lives, and to invest in the future of our country and our communities. I'm glad that my colleagues on both sides of the aisle have raised the issue of justice-involved individuals. I think it's a tragedy in our country that we don't provide Medicaid coverage for mental health and substance use treatment while a person is incarcerated. And look forward to working with the chair and vice chair and members of this committee to address that issue. I want to thank Chairman Guthrie for his partnership, and I want to encourage all of my colleagues to support this bipartisan bill. And I yield back.
The gentlelady yields back. Anyone seeking recognition for discussion? Mr. Carter, what purpose you seek recognition?
Mr. Chairman, I move to strike the last
The
word.
gentleman is recognized for 5 minutes to strike the last word.
Mr. Chairman, I'm pleased to see my bill, H.R. 4096, the Responsible Mental Health Medications Prescribing Act, is included in this package. This legislation standardizes the oversight and reporting of antipsychotic medications prescribed to Medicaid recipients. I was alarmed by a recent GAO report finding extraordinarily high rates of schizophrenia diagnoses and other psychotic disorders among Georgia Medicaid recipients with intellectual or developmental disabilities in home and community-based services programs. It's disturbing to note that GAO also found a high antipsychotic use in Georgia. Over 90% of beneficiaries with intellectual or developmental disabilities in Georgia with schizophrenia had used antipsychotic medications. This suggests that there may be an overprescribing problem, especially in Georgia. As a pharmacist myself, I recognize the dangers of overprescribing. If patients are being given antipsychotic medications unnecessarily, their risk of serious and even life-threatening side effects increases. This is why I'm proud to support this bill, and I urge my colleagues to do the same. Thank you, Mr. Chairman, and I yield back.
Would the gentleman yield?
And I'll yield to the gentleman from Pennsylvania.
I thank the gentleman from Georgia for yielding. And thank you, Mr. Chairman and Ranking Member, for having this hearing today in this markup.
I wish to add my support for the important legislation before this subcommittee. The Support for Patients and Communities Act is a comprehensive, bipartisan legislation that reauthorizes key provisions of the Support Act and builds on its success. This legislation also includes H.R. 4097, the Mental Health Improvement Act, which I co-introduced with Rep. Sykes, which reauthorizes Section 756F of the Public Health Service Act, which provides important grant funding for our behavioral health workforce. Investments like these in workforce development are crucial as communities across the country work to tackle the scourge of addiction and the devastation that it leaves in its wake. This bill is a product of the comprehensive legislative process that took this subcommittee to Gettysburg, Pennsylvania, where we heard powerful and important testimony from my constituents. And I would again like to thank Mike Straley, Chief Bill Saravola, and Dr. Mitch Crawford again for their input in sharing their firsthand experience with the opioid and addiction crisis that we are currently facing. I urge support, and I yield back to the gentleman from Georgia.
Anyone else need time? I'll yield back, Mr. Chairman.
The gentleman from Georgia yields back. The chair now recognizes, what purpose does Ms. Kelly seek recognition?
I'd like to strike the last word.
The gentlelady is recognized.
Trends in modern healthcare and opioid prescriptions have resulted in new risks for patients taking opioids at home. Surgery is among the most common indication for opioid initiation, as opioids are routinely prescribed for postoperative pain management to treat short-term pain. Same-day discharges have resulted in home caregivers becoming responsible for recognizing the signs of respiratory depression. This is why I was happy to work with my partner, Rep. Balderson, to introduce H.R. 4093, the Remote Opioid Monitoring Act of 2023, which requires a GAO study on the use of remote monitoring for patients who are prescribed opioid to better understand the efficacy, individual outcomes, and potential cost savings from using this tool. I'm glad to see this bill included in the larger bill. With so many individuals having access to opioids, we must better understand how to ensure patients are safely monitored when they are discharged home and what additional support resources they need to be provided. I encourage my colleagues to support this bill. Thank you, and I yield back.
Will the gentlewoman yield
Yes, I will.
for the time?
Yes, I will.
Thank you. Mr. Chairman, I was going to strike the last word, but since there's time, in the last 5 years since this committee passed the Support Act, the substance use disorder crisis has evolved but continues to exacerbate our nation's homelessness crisis. In 2018, the Support Act included various policies to expand treatment options and made critical investments in public health. Importantly, it included language to support states who wanted to provide housing-related services under Medicaid. As co-chair of the Congressional Caucus on Homelessness, it would be negligent to ignore that today's markup fails to include language to improve access to housing services for Medicaid beneficiaries. In the United States, there are more than 580,000 people who experience homelessness on any given night. Many of these individuals are insured under Medicaid and seek treatment for their substance use disorder, but only to find themselves back on the streets. As members of this committee, we have an opportunity with this bill to address two of our nation's crises. That's why I'm disappointed we've chosen to not include a single policy that would help people affected by substance use disorder get connected to housing-related services. I intend to continue working on this issue ahead of our full committee markup and hope that we will have the support of members of the majority. We are happy to work with anybody on either side of the aisle on advancing this policy, and I want to make clear that I support this legislation. I'm just disappointed that there is nothing in here to address this, and in the past it has. And with that, I will yield back the remainder of the time to the gentlelady from Illinois.
And I yield back.
Gentlelady yields back. Anyone seeking recognition to speak on the bill? Seeing anyone on the other side seeking, Democrat side? Seeing none, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill? Seeing none, understand that there's work to be done as we are trying to get to some of the things that people have mentioned today that need to be addressed. We all know that we're working together and moving forward, and I'm not trying to take time other than to say that. I know that we are asking to, we're on our side, we like to do a voice vote, so we know we're going to work forward. Are y'all looking for a voice, not a roll call vote or a voice? You're good with voice? Okay, so this will be a voice vote, so just so everybody know when I call the vote. All right, the question now occurs on forward in HR 4531 to the full committee. All those in favor shall say aye. Aye. All those opposed, no. The ayes have it, and the bill is agreed to. Thank you. The chair calls up HR 4056 and asks the clerk to report.
H.R. 4056, a bill to amend Title 19 of the Social Security Act to ensure that medical assistance is available to children in foster care who are placed in a qualified residential treatment program under the Medicaid program.
Without objection, the first reading of the bill is dispensed with, and the bill will be open for amendment at any point. So ordered. Does anyone seek to be recognized on the bill? For our purposes, the gentleman from Florida seek recognition.
I move to strike the last word.
Gentleman is recognized.
Mr. Chairman, I was originally going to offer an Ains that makes technical changes to the bill to ensure proper implementation that matches with our original intent of the bill, but I know there are concerns on the other side of the aisle with some of the language. So in showing good faith, I'm going to offer it next time in full committee. That way we have a chance to work out any disagreements with regard to the Ains and the bill, as a matter of fact. I asked my colleagues across the aisle to come to the table and commit to working with me on this. I want to commend Representative Kathy Castor. I know she cares about this issue deeply, and she's really working on this. She's been a great partner, and I support, again, she supports this particular bill, and again, she wants to work with me, with my colleagues, but also on the other side of the aisle to get unanimous support. There is a great need in the community for this, Mr. Chairman. The bipartisan legislation, the Ensuring Medicaid Continuity for Children in Foster Care Act, which is H.R. 4056, fixes an unintended problem that has kept qualified residential treatment programs from accessing Medicaid for critical mental health services. QRTPs are one of the few residential settings that have strong oversight and accountability due to federal qualification and accreditation requirements. These programs were newly created by the Family First Prevention Service Act, which we passed in 2018, and had just started to be implemented when inadvertently CMS sent letters to states saying they interpreted QRTPs to, they said that they likely may be considered institutions for mental health disease, which disqualifies them to receive Medicaid for their services. This was never the intent of the original bill, and we want to make sure that foster children receive critical mental health care services covered by Medicaid. The Family First bill specifically exempted QRTPs from limiting federal financial participation. The original bill did, and it's clear that QRTPs were never supposed to fall under the IMD exclusion. They're not mental health institutions. The Family First law specifically authorized and required a trauma-informed treatment model in the first place, with clinical services provided when appropriate. Ironically, because of Medicaid's IMD exclusion, children are now being forced into potentially worse or unsafe settings. And we know this is happening, Mr. Chairman, all along. I strongly support children getting care in the right setting, and if that means outpatient, then that's great. But the reality is we have a shortage of options available for children in care. And we know that. We see that all over the country. Where are we going to put these kids? These are safe havens, and they also perform great mental health services for our foster kids. News reports have highlighted this problem with some state foster care systems having to place kids in hotels for the night and juvenile detention centers. We don't want that, or boarded up in the emergency room for long periods of time, and you know that happens. Most states have specifically cited the IMD exclusion as a barrier for additional support. We need to do more to fill the gaps across the continuum of care, and QRTPs can help fill this need by providing qualified care that is accredited, provided by professional medical staff, trauma-informed treatment models, and on a non-permanent basis with aftercare family safeguards. There's a lot of oversight here. These are built-in guardrails that protect against unnecessary or prolonged care. My bill specifically ensures that treatment programs must follow the accountability and oversight requirements outlined in the law, and there are no loopholes. QRTPs must maintain the federal accreditation and safeguard requirements in order to receive Medicaid funding. This will also be a state option, so it's optional. So we're not forcing states to do this, but we do want to remove the clear barriers by Medicaid that have undermined the intent and goals of the Family First Law to reform and provide additional supports for foster youth across the country. The Congressional Budget Office has agreed that this bill is a narrowly tailored fix, and the estimated cost is $90 million. Only in Washington is that.
Gentlemen,
I want to insert, I know I don't have a lot of time, huh? Okay, well, anyway, it's a great bill, and these kids need a place, and this is a perfect place for them. But hopefully they can stay with their families. There aren't enough foster parents in this country. They do it for the right reasons, and we need help. Our children need help, Mr. Chairman. I yield back.
thank you. The gentleman yields back. Is there any discussion? The gentlelady from Washington, gentleman, what purpose gentleman from New Jersey seek recognition?
Thank you, Mr. Chairman. I move to strike the last
Gentleman's
word.
recognized.
I want to speak in opposition to the bill. I appreciate Mr. Bilirakis' withdrawal of the Ains, because I do think that would have even aggravated my concerns. But I'm still concerned about the underlying bill. I understand that we have to ensure that children in foster care have access to the care that they need, but I'm still concerned by this bill's approach because it really just exempts these institutions from critical protections for children and Medicaid. And I don't see these protections as barriers. I see them as protections. So I think hopefully between now and full committee, if this passes today, that we can, look at some alternatives to addressing the concerns that Mr. Bilirakis has. But just exempting these institutions from Medicaid protections, I don't think is the way to go. HR 4056 would allow group homes, also known as QRTPs, to receive Medicaid dollars without following important Medicaid requirements. These requirements include ensuring that the facility has a provider overseeing the care of the children, that the facility meets Medicaid restrictions on solitary confinement and restraints, such as physical restraints or drugs. The American Academy of Pediatrics shares concerns that I have with this bill. In their letter opposing it, they said that HR 4056, and I quote, would create an incentive to place more children in large-scale institutions. Rather than putting financial resources towards institutions, the AAP encourages Congress to instead invest in community-based services for young people. This last point is especially relevant for kids in foster care institutions who receive psychotropic medications at a significantly higher rate than other foster kids. The Government Accountability Office has previously reported that foster children living in larger institutions were substantially more likely than their peers to receive psychotropic medications. GAO found that nearly half of the foster kids in these places were taking psychotropic medications, and that 13% of them were taking 3 or more psychotropic medications at a time. I'm not suggesting that these types of drugs are always inappropriate, but I do think that it's just another reason that we should ensure that Medicaid's regulations against the inappropriate use of these drugs continue to apply to foster care facilities that want to receive Medicaid dollars. Now, Medicaid already allows for children under 21 to receive care in an institution as long as it meets these certain federal requirements. If certain facilities want to access these federal dollars, they should be in compliance with these requirements, or else we are creating a loophole for potentially bad actors to harm vulnerable children. If a QRTP wants to be eligible for Medicaid, it needs to meet the requirements that exist for other Medicaid providers that treat children in institutional settings. Now, I know this is a high bar. I'm not suggesting that that's easily done, but I think it should be a high bar. These are foster children with significant behavioral health care needs. You're not going to find foster homes for them in most cases, and Mr. Bilirakis is right about that. But these are kids that are often very young. You know, we're talking like 6-year-olds in many cases, and they're extremely vulnerable. And I think that we have to ensure that any facility that receives Medicare dollars for their care meets the high standards, including the standards that restrict the use of seclusion and restraint. And I appreciate that the bill sponsors want to ensure children are able to access the services they need, but I just think that this is the wrong approach. There's got to be a better way. We should not provide financial incentives to institutionalize children. We should not weaken Medicaid standards for these kids. Maybe there's a way to address the sponsors' goals while addressing my concerns, but I don't think the bill in its current form does that, and that's why I can't support it, and urge my colleagues to join me in voting no, and I yield back, Mr. Chairman.
The gentleman yields back.
Mr. Chairman.
Anyone Mr. Griffith, what purpose do you seek recognition?
Speaking to the
Gentleman is recognized.
Thank you very much. I appreciate the time to speak on the bill, and I think we're moving in the right direction. Mr. Bilirakis has indicated he's willing to work on an AINS with our colleagues on the other side who have concerns. And with that, Mr. Chairman, I'd like to yield some time to my good friend, Mr. Bilirakis of Florida.
Thank you. Thank you. I appreciate it. Mr. Chairman, I just want to insert into the record a letter from 350 organizations strongly supporting the policy outlined in H.R. 4056 and urging passage. This includes stakeholders like the National Alliance on Mental Health, the National Association of Counties, the Child Welfare League, and the National Council for Mental Well-Being, just to name a few. And again, work with us on this. I know that Representative Castor is really in favor of this, and she cares deeply, and I believe this is part of the solution. So anyway, with that, I'll yield back, Mr. Chairman. Thank you.
Will the
Griffith
gentleman
back?
yield?
Does Mr. Griffith, it's Mr. Griffith's time, so.
Will Mr. Griffin yield to Berrigan?
Yes, I'm happy to yield.
Thank you. I just need a minute. First, I am going to support this, and I'm going to support it in its current form. Per Los Angeles County, this bill is needed to support state QRTP's implementation efforts and to ensure that youth in foster care with assessed behavioral and mental health needs can access support and services from qualified professionals in QRTPs without risking the loss of their federal Medicaid coverage. So I am going to support this. I will say that I don't know what the AINS is going to look like, so I can't guarantee you I'm going to support it in the full committee if this is further expanded or there's more changes in the other direction. And so with that, I will yield back to the gentleman the time.
And I now yield back to the chair.
The gentleman yields back. The chair, Ms. SSU first? Okay. The chair, what purpose does the gentlelady from California seek
I
recognition?
move to strike the last word and
Gentlelady is
speak to
recognized.
HR 4056. Thank you, Mr. Chairman. While I don't plan to vote for HR 4056 today, I hope we can find a suitable solution that protects foster children while also ensuring that they can receive health care services they need through Medicaid. And I think that's where the rub comes in. I'm a former foster parent, so I believe that I know what the system looks like. It's a system that has really been left wanting for decades, and I can say that in California, and my sensibilities are, I see other members nodding their heads. So, and these are children. These are children. And the vast majority of children in foster care, they actually qualify for Medicaid. But CMS recently clarified that a specific foster care setting called the Qualified Residential Treatment Program, the QRTP, is considered an IMD if it's larger than 16 beds. So that means that the children who are temporarily in these QRTPs can't have Medicaid pay for their health care, even if the care is provided outside of the QRTP. I mean, go figure, you know? I mean, this is agency and whatever, in many ways, rope-a-dope. I mean, it's so hard to even come up with a sentence that is simple to explain the fractured system that these children are in. So it seems to me that that we can find a path forward to make sure that these children can receive health care, while obviously no one here wants to encourage inappropriate or unsafe placement. So I would say between now and the full committee, let's keep working and get this done, because the children really deserve this. They're so vulnerable to begin with in a system that's filled with vulnerabilities. We want to make sure that we don't add to that. So thank you, Mr. Chairman, and I yield back.
Would
The
the
gentlelady
lady yield? Would the lady yield?
Pardon me?
Would you yield to me?
Oh, I'd be glad to.
Yes, look, you know, this is a bill that I know has good motivation and good intention. As an emergency medicine physician, one of the worst scenarios is taking care of kids who have been abused violently, sexually, or any other kind of way, verbally, emotionally, and the separation that needs to happen either with their foster parent or whether their biological parent or their step parent. And the children who are in the foster system, especially those that have mental health disorders or illnesses, are amongst one of our most vulnerable populations. And if we remove some of the standards that will ensure oversight in the handling of or how they restrain or how they care for the children, then that leaves us at risk of more abuse that will go undetected. And so I highly encourage my good friend on the other side to really ensure that we increase access to healthcare without risking the child's safety while in foster care. And with that, I yield back my time.
You yield back in.
I do.
Gentlelady yields back. Where are we? Anyone else seek recognition on the bill? Hi, Dr. Schreier, recognized for 5 minutes.
Thank you, Doctor. And thank you, Mr. Bilirakis, for raising this issue, because it's a really important issue. And I'm going to speak in opposition, but I would call it very gentle opposition, because I really hope we can keep working on this. I think we have to be pragmatic, and I want to take care of these kids. I am a pediatrician and know that there aren't enough foster parents out there, and there aren't enough wraparound services out there. And so we need some way to help. And I really appreciate that you are looking to help solve this particular problem. I'm also, though, based on the sincere and strong objections of the American Academy of Pediatrics, I'm going to be voting no on this, because their concern is that by relaxing requirements and opening up more possibilities for essentially institutionalizing these kids, many more will end up
in group homes or institutions who would be far better served with a foster family and community wraparound services. And there is a history of that being the case. And so I hope that we can work together to come up with some plan that will work to ensure that kids get the best care possible so that they have the best and safest futures possible. It's just not this bill today, but I look forward to working together and perhaps the next version of it in committee we can work on together. Thank you, and I yield back.
Would the gentlewoman yield?
I will yield.
Thank you. I just want to reaffirm the comments my colleague made, and I want to remind people about the importance of allowing individuals to receive care within their own community. Most of you know that preserving and increasing access to home and community-based services is one of my top priorities. I know that the intent of this is good, and I want to work with all of my colleagues. But when given the choice, we know the vast majority of Americans want to remain in their homes, in the communities, while they receive treatment rather than being sent off to an institution. And youth and qualified residential treatment programs are no exception. And as the doctor just said, proposals that weaken the institutions for mental disease or IMD inclusion means that it could create a troublesome incentive to institutionalize children when it's unnecessary. And the studies show that inappropriate institutionalization can result in lifelong harm for foster youth. So I think it's very important that we get it right. I thank my colleague, the pediatrician, for making this point, and hope we can all work together, because when we can, we should be avoiding institutions, period. We should be trying to find foster parents for these kids. And I thank you for yielding to me. I yield back.
And I yield back.
Generally yields back. Anyone else seeking recognition? Seeing no one, are there any bipartisan amendments to the bill? Seeing none, any other amendments to the bill? You want a roll call? If there's no further discussion, the vote occurs on the amendment, and the roll call vote has been requested. No. No amendments. There's no amendments, no. Yeah. So the question now occurs on forwarding H.R. 4056 to the full committee. The clerk will call the roll.
Chair Guthrie. Guthrie votes aye. Burgess. Burgess votes aye. Latta. Latta votes aye. Griffith. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon. Bouchon votes aye. Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshoo. Eshoo votes no. Sarbanes. Sarbanes votes no. Cardenas. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Kelly votes no. Barragan. Barragan votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers. Chair Rogers votes aye.
Anyone else seeking recognition? Are we good? Clerk will report.
Chair, on that vote, there were 17 ayes and 9 noes.
The ayes have it, and the bill is agreed to and forwarded to the full committee. The chair now calls up H.R. 3887 and asks the clerk to report.
H.R. 3887, a bill to amend Title III of the Public Health Service Act to
Without objection, the first reading of the bill is dispensed with, and the bill will be open to amendment at any point. So ordered. Does anyone seek recognition to speak on the bill? For what purpose does the gentleman from Texas seek recognition?
Mr. Chairman, I have an amendment at the desk.
Gentleman's recognized. Hold on, does anyone want to speak on the, on the bill, or just go right to the Ains?
I just can't get this right.
Seeing no one speaking on the bill, are there any bipartisan amendments to the bill? Seeing none, are there any other amendments to the bill?
I'm so confused.
Gentleman, now Mr. Crenshaw is recognized for an amendment in the nature of a substitute.
Mr. Chairman, I have an amendment at the desk.
Clerk will report.
an amendment in the nature of a substitute to H.R. 3887, offered by Mr. Crenshaw of Texas.
Without objection, the reading of the amendment is dispensed with, and the gentleman is recognized for 5 minutes in support of the amendment.
Thank you, Mr. Chairman. I will continue to say I don't think that this bill, this amendment, should be controversial. The legislation is as straightforward as it gets. It simply states that if you're providing evidence-based medicine to children under your care, then the federal government will fund your residency training program. But if you choose instead to encourage and facilitate dangerous and permanent changes to a child's physiology, taxpayers should not be forced to fund that program. That's not controversial. It's common sense. Now let's delve into the issue at hand. I'm talking about so-called gender-affirming care for children, which in reality is nothing but pseudoscience parading around as legitimate care. It's a facade, plain and simple. True evidence-based medicine relies on systematic reviews. That's the gold standard for assessing a substantial body of evidence. And here's the kicker. All 5 of the genuine systematic reviews conducted on child sex change procedures arrived at the same conclusion. The evidence has alarmingly low quality, specifically the evidence that it has any benefit for them. So here's the problem. Radical ideologies have infiltrated our medical societies and children's hospitals, driving them into a state of madness. It seems the United States is alone now in presuming that every child with any level of gender discomfort automatically has diagnosable gender dysphoria, and that therefore that child needs chemicals pumped into their body or surgery done on them to permanently disfigure them, rendering them unable to produce children in the future. That is the opposite of the do no harm principle. We need to acknowledge a truth here, one that might make my colleagues somewhat uncomfortable. We're irreversibly disfiguring children based on a temporary ideation. We're causing permanent damage that stunts their development, harms their skeletal structure, and robs them of the ability to start a family. All of this in pursuit of some idea of compassion. Dr. Hilary Cass, a highly respected pediatrician and former head of the Royal College of Pediatricians and Child Health to the UK, highlighted in her 2022 report that the unsafe conditions in British pediatric gender clinics stemmed from the adoption of the affirmative model that originated here in the US. Our peer countries are practically shouting at us to put a stop to this madness. They find it utterly baffling that we just assume that an 11-year-old possesses the maturity to fully comprehend a decision that will make irreversible, drastic changes to their bodies. We need informed consent in medicine. We need physicians who are thoroughly informed. We need parents who are equally well informed. The United States should be leading on this issue, but it's leading in the wrong direction. That's why we're hitting the stop button. We're saying we should not be pouring taxpayer dollars into institutions that are carrying out procedures devoid of any solid scientific foundation. That's not a crazy thought, considering when you poll the American public, 70% are opposed to this. All this bill does is say taxpayer dollars that everybody contributes to should not be used for something that 70% at least of the population of America opposes. So let's bring back sound science, informed decision-making, and a responsible allocation of resources and tax dollars. It's time we protect our children, and with that, I yield back.
Gentleman yields back. Is there any discussion? I recognize Ms. Eshoo, the ranking member, for 5 minutes.
Thank you, Mr. Chairman. The Children's Hospital Graduate Medical Education Program is the most important federal investment we make as a nation in strengthening the pediatric workforce and expanding access to care for children. For nearly 25 years, the CHGME program has trained half of general pediatricians and a majority of pediatric specialists in our country. In California, the program funds are used by 7 children's hospitals to train over 906 full-time pediatric residents annually. The program trains doctors who go on to care for children across the nation, including those living in under-resourced and hard-to-reach communities. Many members represent such communities on this committee. The program is absolutely essential to maintaining the pediatric workforce in our country. So it's very, very difficult for me to comprehend why any colleagues are subjecting such an important program to a manufactured culture war that inserts politics between parents, children, and their pediatricians. Specifically, the bill prohibits 19 specific procedures and any type of hormone therapy that could be perceived as gender-affirming for trans youth. I just can't comprehend why these children are being pursued and singled out. There's a, in my view, there is a real cruelty to this. And I don't use that word very often, but that's the lens through which I see this. The bill threatens precious lives. As one pediatric endocrinologist said, every time politics and medicine commingle, people die. We're already seeing higher rates of maternal and infant death because of abortion restrictions that paralyze providers in an emergency. Now, some Republicans are attempting to ban 19 more procedures and treatments that should be a private decision between patients, their families, and their doctors. Now, well, what's the next area of medicine that we're going to get into and say, I don't know, maybe women beyond the age of 62 shouldn't have any cosmetic surgery? You know, what are they going to do? Drag their husbands in to ask them whether they think that it's a good idea or not? We're treading in territory where we don't belong. These decisions belong in a family, not at the Energy and Commerce Committee, where I don't know how many here can go through and explain all the surgery, what it means, what the doctors are saying, what families say yes, what families say no. We don't know any of that. We don't know any of that. This doesn't belong here. This does not belong here. And it's jeopardizing one of the really gold standard programs that we have in our country, to train doctors. And children's hospitals are now being subjected in this culture war with bomb threats. Children's hospitals in our country. I have one of them, a prestigious one in Palo Alto, California, the Lucille Packard Children's Hospital. This proposal also worsens mental health crisis. And we know that regardless of what the age is, the background, the geography, we have a mental health crisis going on in our country. And the committee is trying to deal with all of that. We have, in the young age groups, rising numbers of attempted suicides. It's really a sad, sad state of affairs. I think this is a harmful, disastrous bill. I don't think it should have ever been brought up. Certainly, the gentleman has the right to do so. But I don't believe that this bill belongs here. We should get back to working on the real issues rather than these inventions that are taking place, and pass this legislation to reauthorize this graduate school program that has served our country so well. And I yield back. Thank you.
Generally yields back. Now recognize the chair of the full committee, Ms. Rogers, 5 minutes.
I move to strike the last word, and I speak in support of H.R. 3887, the Children's Health GME Support Reauthorization Act of 2023. I urge my colleagues to join in making sure that we fund this program so that parents have every assurance that their children are getting the best care by the best doctors. With or without our colleagues, we are moving forward to support training programs for pediatric medical residents. It's how we make sure America continues to be home to world-class pediatricians. That is our goal today. Democrats are jeopardizing this critical funding for children's hospitals because of what is really a radical ideology. Surely we can all acknowledge legitimate concerns that children are being rushed to experimental interventions. Other countries, many in Europe, are urging caution and are being honest about that the evidence is lacking. Our children's hospitals and medical institutions should be doing the same. The risk outweigh the benefits. I think about the rapid surge of teen girls identifying as transgender and the mental health crisis we've all recognized is occurring in younger generations. We have also talked about the dangers of social media platforms that are influencing people, and especially our children, more and more as to what they see, hear, and believe to be true. It's hard for me to deny the bigger picture here and how these experimental interventions push young people to change the course of their life, development, and well-being without providing the underlying help they truly need. I've heard many here suggest that Republicans are intruding on parents and children in their doctor's office. This is not true. Let me share what is happening in my home state. Governor Inslee just signed legislation to allow the government to hide children, those over the age of 13, from parents when their parents don't support these experimental interventions. Governor Inslee and the state legislature, majority Democrats in the House and Senate put into law that the government, not parents, know what is best for our children. It puts parents in fear to speak up and ask questions. The government is sending the signal, raise your children by our agenda or else. I speak for many parents who are saying enough. We are the parents of our children. Our children are innocent, and they are extremely vulnerable. Let our children be children. Now back to H.R. 3887. Our goal today is to advance this bill so that when a parent steps through the door of a hospital, they are confident that their children is getting the best care they need from the doctor who is trained with the best medicine, data, and science. To support CHGME program, I urge a yes vote, and I yield back.
Generally yields back. Any further said? Recognize the ranking member of the full committee, Mr. Pallone.
Thank you, Mr. Chairman. I respect everyone on the other side, but I don't understand this idea that somehow social media or TV or someone, something you watch is going to make you want to be transgendered or gay. I mean, this is not the reality. I mean, it's not like you wake up one day and you watch a movie and you say, I guess I'm going to be a transgender. I mean, I think that what's happening out there is that because we're in a free society where more and more people are accepting people's decisions on gender or sexual preference, that, people who maybe years ago would not identify as transgender or want to be known as transgendered or gay decide that it's okay because we're more accepting society that doesn't put a stamp on people because of their sexual orientation or gender identification or race or whatever. I mean, that's the reality. This idea that somehow we're forcing people to become transgender, I just don't think makes any sense. I mean, identifying what's happening is, and what's being prohibited in this bill as pseudoscience or experimental is simply not true. We're just saying that this is a decision that should be made by doctors, with the parents, with the children. And we know that the doctors' organizations that are involved with this think that what the Republicans want to prohibit is actually totally acceptable and a good thing. You know, I don't know how to keep repeating the same thing, that healthcare decisions should be made between a patient and their healthcare providers, in the case of youth with their parents as well, and we should not intrude in this process. This Children's Hospital Graduate Medical Education Program has been reauthorized multiple times with broad bipartisan support, without substantive changes to the program. The Republican bill goes against decades of scientific research and evidence that it's established clear standards of care. It's not pseudoscience. Care that's effective and essential to the health and well-being of transgender youth. Every major medical association representing more than 1.3 million doctors across our country supports age-appropriate, gender-affirming care for transgender people. Instead of letting doctors do their job, Republicans are politicizing a bipartisan program and restricting access to evidence-based care for transgender youth. They're also attacking children's hospitals and their doctors by dictating what care they can and can't provide. Children's hospitals would be forced to make a choice between providing medically necessary care for their patients or foregoing federal funding dedicated to the training of their residents. And I think that Republicans should acknowledge that we're in the middle of a pediatrician shortage in this country. Access to care for children is threatened in communities across the country due to these provider shortages, and rather than support the training of new doctors, Republicans are choosing to hold this important funding mechanism hostage. It's also important to note the kind of impact that harmful legislation like this has on the mental health of transgender youth. This is a group that is already at high risk for mental health challenges. Nearly 1 in 5 transgender and non-binary youth have attempted suicide, and nearly half have had such incidents. So we know that transgender people who want gender-affirming care and receive it are less likely to attempt suicide than those who don't. This can be life-saving care. Restricting it is not just harmful, it's actually dangerous. And there are just countless stories from doctors, parents, and transgender youth themselves about how this care has changed their lives. Many transgender youth feel that the society around them does not see them for who they are. They describe how knowing that parents and doctors love them, respect them, and take them seriously makes all the difference. They've told us how gender-affirming care makes it possible to feel comfortable in their own bodies so they can refocus on school, friendships, and all the things that come with a regular adolescent life. We should be supporting it wholeheartedly and trusting the doctors and the parents and the patients to make the right decisions. You know, my friend from Texas, and I don't want to keep picking on him, but he talked about a poll that 70% of the people support this bill. Well, you know, what does that mean? If 70% of the people think that kids with disabilities should be, destroyed when they're children, does that mean that that's what we're supposed to do? I mean, in Sparta, they used to take disabled kids and throw them into the ravine. I don't want to be that. I don't want to go by what the majority thinks. I want to go by what the science is and what the doctors and the parents think. And with that, I yield back, Mr. Chairman.
Gentleman yields back. Gentleman, who's next? Yeah, recognize Ms. Miller Meeks, 5 minutes.
Thank you, Mr. Chair. I'd like to speak in support of H.R. 3887, Children's Hospital GME Support Reauthorization Act, introduced by my friend and colleague, Congressman Crenshaw. I know firsthand that a physician's training is a lengthy and expensive process, which is why renewing CHGME to ensure that there is sufficient supply of pediatricians to meet the demand is so important. In fact, I have long supported increasing the number of GME slots and funding. The timely reauthorization of this program through 2028 will continue a legacy of over 20 years of supporting our healthcare providers. However, I am also supportive of the prohibition on GME funding for hospitals that furnish puberty blockers, hormone therapies, and/or surgeries for the purpose of sex alteration care to minors. And let me just say that if anyone in this room thinks that the government is not already involved in the patient-doctor relationship, let me just remind people that during the COVID-19 pandemic, The government, the Biden administration, forced vaccine mandates on everyone despite calls of physicians such as myself and former directors of public health that be left to the doctor and patient to determine. And that is not the only example. That's just a very recent example. When this bill was introduced in our recent legislative hearing, the minority witness could only claim that standards of care as scientific justification for the safety of these surgeries and treatment. She could not cite any gold standard randomized controlled trials that showed and evidenced what she was saying or what the ranking member said, nor supportive systematic reviews. The purpose of healthcare is to treat and heal, and it is not in the interest of the American taxpayers to fund these experimental procedures at the expense of the physical and mental well-being of patients. Procedures and drugs that cause permanent and irreversible alterations. To quote our colleague from New Jersey, the ranking member, when talking just recently about providers of Medicaid services for foster children, he just stated, "It should be a high bar." Why should the bar be any lower when we are talking about care that can permanently damage and irreversible to minors? And as a physician and a director of public health, I have had advocacy groups numerous times come to talk to me about young people under age 25 not having the frontal lobe development to make accurate judgments, but yet we think that minors should be able to make decisions for permanent, irreversible, damaging physical alterations. There is a lack of scientific evidence regarding the effectiveness of these medical interventions, especially among minors. Again, we are only talking about minors, which is why countries in Europe, such as Denmark, Britain, and Sweden, have described the treatments. These countries have decided the treatments as experimental, and they have urged doctors to proceed with caution. I rise in support of this bill, and I would urge my colleagues to do the same. I yield back.
Will the gentlelady yield for a second? To the chair?
Yes, I'll yield.
I don't want to take 5 minutes, but I just want to say, look, I said this before, gender dysphoria obviously is real. However, we do have a role in protecting children. We protect children in all kinds of areas, from the local government, state government, and the federal government. And we don't have definitive data. We don't have definitive data on permanently changing people's anatomy when they're children. We just don't have, there just isn't that data. I've talked to Children's Hospital folks. Europe recognizes that. And we also don't have any data on permanently changing people using puberty blockers. So again, we're talking about children here. Does anyone think that we should take a 12 or 13-year-old anatomically male child and remove their sex organs permanently because they believe that they should, because that's where they are? I would have a hard time arguing that anyone thinks that that's right. Now, if you're 18 years old and you're an adult and you choose to make that decision, well, that's different. But we do have a role in protecting children, and from a scientific standpoint, as a medical doctor, I can't get past that. Do I think that there are people need aggressive treatment for gender dysphoria? You bet. But we're talking here about permanently changing people's anatomy and physiology. And the physiology side, much of it is not reversible. In youth, under the age of 18, and I can't reconcile that. So I will yield back to the gentlelady.
Thank you, and just to quote what was already said, after all, these are children. The children deserve this. The children deserve that we have a high bar. And in all other parts of medicine, when we ask for randomized controlled studies, when we ask for systematic reviews, the bar should be no less for our children. I yield back.
Gentlelady yields back. Now recognize Dr. Ruiz for 5 minutes. For what purpose does the gentleman
Move to strike the last.
Gentleman's recognized, 5 minutes.
Look, transgender individuals face one of the highest rates of anxiety, depression, homelessness, abuse, hate crimes, suicide, and it's caused by three different aspects. One is that there's incongruence between who they believe in their soul they are and what their body phenotype is. And that incongruence, we can't imagine what that leaves an individual to feel. Second is the hateful fear rhetoric that comes out in society, where you see those hate crimes appearing, where people aren't accepting, welcoming, appreciating these beautiful individuals. And third is, because of all of that and the fear, there is a lack of support systems. There's a lack of support systems from their home and then their communities. So we have found through studies, and I just looked up one, in fact, Psychosocial Functioning in Transgender Youth After 2 Years of Hormones, that was published in the New England Journal of Medicine this year, that shows that there is positive outcomes in gender-affirming hormonal care. For example, during puberty, that there's positive effects with life satisfaction, decreased depression, anxiety, increase in appearance congruence were associated with congruent increases in positive affect and life satisfaction, etc. So there is a growing body of evidence. The reason why we don't know what the long-term studies are yet is because there haven't been any long-term studies. And in order for us, in order for us to get there, we should allow the science and the research that is already showing these positive outcomes. But unfortunately, even with the care that we want to have, this type of rhetoric that we have heard today about gotcha, about fear-mongering, about hate, instilling this hate and this fear, all for the sake of some kind of these children being victims, is going to hurt kids. And this is another example of how the Republicans are using this bill to hurt all kids if they don't get their extreme agenda through in their cultural war, attacking some of our most vulnerable children in our communities. With that, I yield some time to Representative Trahan. And she yields back to me, because do you want the time or not? No, she needs more time.
More time.
I'll yield to Representative Sarbanes.
Yeah, I just want to get away a little bit from the fine print and say that all we're seeking here is to meet young people where they are. It's tough enough being a young person in this world these days with all the pressures that come at them from so many different places. What we want to do is meet them where they are and provide as much support as we can, and basically have society wrap our arms around them and say it's going to be okay. And we're going to be here as a society for you and support you and help guide you forward. That's all we're seeking here. And I think what worries many of us here is that there's an edge, whether it's intentional or not. I won't speak to that. But the articulation of all these arguments that lean against transgender youth and those who are seeking that comfort, it feels like it has an edge and a meanness to it that doesn't help the situation at all. So we're just seeking to provide that support, and I yield back.
And I yield back.
Gentleman yields back. Mr. Pence seeks recognition. Recognize for 5 minutes. Turn your mic on, please.
I rise in support of 3887 and yield the balance of my time to Mr. Crenshaw.
I appreciate the gentleman yielding. Okay, there's a lot to address here, a lot of things said. No facts given. A lot of things said. I've been called cruel multiple times. So let's address that first. I am not the one who is cruel. Doing a double mastectomy on a 12-year-old girl, that's cruel. Castrating a 10-year-old boy, that's cruel. Putting them on permanent hormone therapy and puberty blockers that could prevent them from ever having children, permanently changing their physiology. There's a cruelty to that for sure. We are not the crazy ones here. All right, we've been really. 5 minutes ago, none of y'all believed this. Let's be honest. Let's be honest. This has been called a manufactured culture war. So we're the ones who, if it's a manufactured culture war, then why are we even debating it? Why do you care if it's banned? So it's not manufactured. We are responding to what is inherently a social contagion. In the UK, referrals for these kind of transitions went up by a factor of 33 between 2009 and 2018. In the US in 2007, there was only one pediatric gender clinic that would do this. Now there's over 70. This is increased by 45,000% in many hospitals. We're not making this up, we are responding to it. It's been said that nobody just wakes up and just becomes trans. Okay, well, that's not what the literature says. In a report by Lisa Lippman, parents' reports of adolescents and young adults perceived to show signs of rapid onset of gender dysphoria. Nearly 70% of adolescents and young adults in the sample had at least one friend in the peer group who had declared a trans identity. There is a clear association and correlation between peer influence and these kind of ideations.
Will the gentleman yield?
No.
Are you suggesting
Hey,
that
I said
if
no.
you have a transgender
The gentleman
and
did
you're
not
gonna be
yield, Dr.
transgender?
Ruiz.
You're out of
Did
order.
not yield.
But since Dr. Reese
the
is
message
talking,
is
he
no
found
transgender
one
friends.
study. I reclaim my time. And yes.
Let's keep our decorum here now, come on. Recognize
Now,
Mr. Crenshaw.
Let's go ahead and I will address what the good doctor had said about the one study that he found. So the one study that he did find, actually 2 of those participants in there killed themselves, and it was not a randomized control study. So just like many of these studies that you could bring up, trust me, I've got notes on all of them. Now I'm not done correcting all the misinformation that's been put out. It was said earlier that this would ban procedures. No, it removes funding for hospitals that do them. Can we remove this person? All right. It was said earlier that we don't know anything about this. We don't know what these procedures are, or what the parents are thinking, what the kids are thinking. Isn't that kind of a good argument to press the pause button since we don't really know anything? Now, what we do know is that there's been multiple systematic reviews, the gold standards of evidence collection, that show that we don't know enough to keep going on something that carries such high risk. Now, look, you might not know that bananas are healthy for kids, but you also know that there's not much risk to giving them a banana. So it's not a big deal. This kind of stuff is a really big deal. And when every single piece of evidence shows that there's not a clear benefit associated with it, you just press pause. Heck, we're not even pressing pause. We're saying don't fund institutions that are actively doing it. We're doing way less than pressing pause. And that is directly related to another comment which said, you don't care that 70% of Americans disagree with you. You don't care. Well, that's quite a thing for a representative of Americans to say, but the thing is, we're talking about their use of taxpayer money. And so you do have to care just a little bit. It's been said that this threatens transgender youth. It hurts their mental health, that they're going to commit suicide because of it. Here's the thing, that declaration, doesn't coincide with the actual science. Doesn't actually coincide with the studies on this. What the studies actually show is that 70% of the people who propose that they are transgender already had other comorbidity psychopathies. Every single time. 70% of the time. That's a pretty big deal. Do you not care about that? When you're claiming that this is that refusing this kind of care is causing suicide, do you not care that those preconditions might have already been there? Is that not a fact that you would want to look at before you automatically propose permanent physiological change to someone? We are not the ones being incompassionate. We are not the ones being cruel. We are the ones saying, press pause, there's an extreme trend going on, and we don't have the science to back up its benefits. And you can't argue with that, but please try. I yield back.
I recognize Ms. Trahan. For what purpose do you,
I move to strike the last word.
gentlelady is recognized. 5 minutes.
You know, time and again, I've heard my colleagues across the aisle discuss the urgent need to address the youth mental health crisis in our country, yet they ignore the fact that a large body of medical literature demonstrates that with support at home, in school, and in communities, coupled with access to gender-affirming care, trans youth show improvements in mental health outcomes. A high prevalence of suicide ideation and attempts occur in transgender youth compared to their cisgender peers, but in transgender children who have been able to receive gender-affirming care, risk of suicide is reduced by 73%. Denying that truth means denying the existence of trans kids as a whole, and how dangerous is that? We should be working to increase access to health care for all children, not restrict the ability of children to define and express themselves. A ban on gender-affirming care is dangerous, it's misguided, and yes, it's cruel. And it is a shame that Republicans on this committee are, one, misrepresenting what gender-affirming care actually is, and using what should be a bipartisan piece of legislation to score cheap political points. Now, I want to emphasize that across pediatric practices, many young people who are not transgender access gender-affirming health care for one reason or another. For example, a Harvard Medical School study found that for decades, doctors have been using safe medications for cisgender children who go through puberty too early. For trans children, gender-affirming care is essential, medically necessary care that promotes their health and well-being. This evidence-based care is used to treat gender dysphoria, which is a serious medical condition characterized by clinically significant psychological distress associated with the difference between a person's gender and the sex they were assigned at birth. Gender-affirming hormone therapy and surgeries are deemed medically necessary treatments for gender dysphoria by the American Medical Association and other clinical policy-setting organizations. GAC is patient-centered and treats individuals holistically, aligning their outward physical traits with their gender identity. What my Republican colleagues are not saying is that this kind of care encompasses many facets. Social affirmation is considered gender-affirming care, where a transgender person adopts an affirming hairstyle, clothing, name, and pronouns. This affirming care occurs at any age, but what my colleagues may be referring to, gender-affirming surgeries, are overwhelmingly performed in adulthood. In fact, Boston Children's Hospital in my home state of Massachusetts only performs these procedures on consenting adults, contrary to misinformation that's peddled online, including by a witness who the majority invited to testify before this committee. Overall, gender-affirming care is comprehensive care that affirms the individual and meets them where they are. And by exaggerating the care that's actually being administered to trans children, we're opening them and healthcare professionals who work diligently to care for them to increase levels of hate, harassment, and threats. I've seen that already at Boston Children's Hospital, which has been the victim of numerous threats following the spread of misinformation about the services operated at their facility. Let me say something that should be obvious to my colleagues across the aisle. Embracing rhetoric that endangers our children's hospitals does nothing to protect our children. It does the opposite. It puts them at risk of not being able to access the life-saving care that these facilities offer. So let's stop with the partisan gamesmanship, the uncredentialed grandstanding, and let's get to work on funding programs that children's hospitals rely on to train the next generation of pediatric specialists. You can do it for your children, you can do it for mine, and the children that you hope to have someday. I yield back.
Gentlelady yields back. Anyone else seek recognition? Dr. Schreier, for what purpose do you seek recognition?
Mr. Chairman, I have an amendment at the desk.
Seeing no other people wanting to speak on the Ains, the gentlelady is recognized. The clerk will report.
Amendment to H.R. 3887, offered by Ms. Schreier of Washington.
Without objection, we dispense with the reading, and I don't have the script.
Thank you, Mr. Chairman.
Yeah, and I recognize Ms. Schreier for 5 minutes to explain her amendment.
Thank you, Mr. Chairman. I'm offering this amendment today because as a pediatrician, I know quite personally how important children's hospital graduate medical education is. This funding is vital. It funds the next generation of pediatricians. And I'll remind all of you that right now we have a shortage of pediatricians. Many kids don't have a medical home. We've had many retirements, and we need pediatricians and pediatric specialists more than ever. So we need more CHGME funding. And I'll add to this that in my home state, in Washington State, Seattle Children's receives $10 million annually in funds. This is 10% of their entire training and residency costs, and these costs add up, and they are training the next generation of pediatricians after medical school. I want to just offer up this amendment that simply strikes the preconditions put in by Mr. Crenshaw. It will preserve a clean reauthorization of CHGME, the same reauthorization that has been done successfully in a bipartisan fashion 5 times previously. It is simply inappropriate to threaten funding for children's hospitals to score political points or to have members of Congress try to make medical decisions and get in the middle of medical decision-making between parents and children and doctors. And so this is an amendment to strike the preconditions in the other bill to have a clean reauthorization of CHGME funding. I encourage my colleagues to vote for this amendment and vote no on the previously presented bill. Thank you. Yield back.
The gentlelady yields back. Anyone wants to speak on the? Recognize Mr. Crenshaw. 5 minutes.
Chairman, I move to strike the last word.
Gentleman's recognized.
I oppose this amendment on the grounds that it would strike my amendment, so seems obvious. But I want to address a study that was brought up earlier that would supposedly support the idea that there's some benefit to this. I'll read the rebuttal. A careful look at that. This was the study brought up earlier, by the way, which claims that there's 73% lower odds of suicidality after these treatments. But a closer look at the study's data shows that the kids who received hormonal interventions did no better by the end of the study than at the beginning. The researchers' claim about improvement was based on the fact that the kids in the control group who received psychotherapy but not hormones got worse relative to the hormone group. But even this isn't accurate, as 80% of the control group dropped out by the end of the study. And a likely reason for the dramatic loss to follow up is that many, or perhaps all of the non-hormone therapy kids improved without gender-affirming drugs. It's quite possible that if the researchers had actually followed up with all the participants, we'd see a pretty different outcome. There was another study proposed that said that indicated that it was within a 2-year window. Well, we're not talking about a 2-year window. We're talking about the rest of someone's life. Right? These aren't changes that can just be reversed. These are major physiological changes. I don't understand why there's no compassion for that. Kids who really don't know how to process some of the things that they feel, and parents that have been subsumed by this radical ideology. Doctors are supposed to rely on systematic reviews. Remember at the last hearing when that Yale doctor couldn't name one study? I at least appreciate my colleagues naming a couple studies so that I could debate with them on those. That one couldn't name one. She just kept saying standards of care. Standards of care are derived from evidence. You derive standards from evidence. You collect evidence over the course of a long period of time with a large pool of patients. And then you aggregate all of that evidence through systematic reviews. Now, every single systematic review says the same thing, that there's little to no benefit to these therapies, and yet very, very high risks. There's been a lot of talk about the suicidal potential because they don't receive these therapies, but again, roughly 70% of US teens who present to gender clinics have comorbid psychiatric diagnoses that precede the onset of gender issues. That's a really important fact. And it's just a fact. It's not an opinion. It's just a fact that helps us look at this problem, I think, a little bit more holistically and without any emotion, without any politics. No, for us, this isn't about politics. We keep being accused of that. But the truth of the matter is we're simply responding to a very radical trend. That's all that's happening here. It's been said over and over again that we shouldn't be getting in between the patient and the doctor. I might remind everyone that most of these bills that we've passed in a bipartisan way today regulate medicine between a doctor and a patient in one form or another. Right? Obviously, the government is in the business of it. And if, by the way, if you don't believe that the federal government should be in the business of it, then why are we giving money to children's hospitals in the first place? Your argument has that logical end, just to be clear. Now, look, of course we want to make sure that our children's hospitals' GME programs are funded. This bill does that. This bill does that while also preserving long-standing medical standards of care that have been proven time and time again, while prohibiting the kind of care that has not been proven, that has actually been proven the opposite. This should really not be controversial. It really should not. This was not controversial just very long ago. We didn't create this culture war, folks. We're just responding to it. And I yield back or yield to any of my colleagues.
Gentleman yields back. Anyone else seeking recognition on the amendment?
Chairman, I move to strike the last word on the Schreier amendment.
Recognize the gentleman, 5 minutes.
Thank you. And whatever time I have left, I'll yield it to the author of the amendment, Ms. Schreier, Dr. Schreier. I want to take this opportunity to express my extreme disappointment at the hyper-partisan Children's Hospital CHGME bill that is noticed today. Holding funding for pediatric specialties hostage on the backs of trans children who are seeking necessary and appropriate care is politics at its ugliest, at its worst. When we talk about gender-affirming care, it feels like the humanity of trans people is lost along the way. But let's not forget, we are talking about our kids. And all of the science from respected sources tells us that gender-affirming care is life-saving. For example, research shows hormone therapy can reduce suicidal ideation. One study even found that after 1 year of gender-affirming treatment, the average level of suicidality was 1/4 of what it was before treatment. This issue is about respecting the humanity of all children. This is about believing them when they say that they need help and trusting doctors to provide the care that they need. I asked my colleagues to consider how enraged they would be if they were told they could not pursue the very care that would save their kid's life. Who are you to make that call? Who are you to get the audacity to make that decision for kids, parents, and their doctors? I'm grateful to my colleague, Congresswoman Dr. Schreier, for introducing her amendment that would strip harmful language banning gender-affirming care from CHGME reauthorization proposal put forth today. I urge my colleagues to support this amendment to stand up for the dignity of our trans children and to move a clean reauthorization that will allow us to support the pediatric care workforce. And I yield the balance of my time to Dr. Schreier.
Thank you, Representative Cardenas. I simply wanted to say that funding for children's hospitals is on the line here. It's at risk. We know that Mr. Crenshaw's bill will not pass in the Senate, and it will not get signed into law. And if we want to support our children's hospitals, this is the way to do it. We vote for this amendment, we do a clean reauthorization, our children's hospitals get funded, and we have a new generation of pediatricians. It is that simple. I encourage my colleagues to vote for this, and I yield back.
Dr. Schreier, will you yield?
It's my time, and I'm yielding to Mr. Pallone.
I'll be quick. I think that just to separate this issue at the time, I think what Dr. Schreier is trying to do here is to make the point that, you know, the funding for these children's hospitals, for pediatricians, for residency programs is all at risk. I mean, I just know when I'm back home, you know, I think a lot of people think, oh, everybody wants to give money for kids, children's hospitals, such a great thing. You know, I don't know how much the federal component is, but Mr. Crenshaw said, well, maybe the federal government shouldn't fund children's hospitals. I don't think he means that, but you know what I mean. In other words, if this becomes an issue, then why are we doing it? Well, I mean, the problem that we have to face here is that increasingly hospitals, whether it be from the federal funds or from private donors, all this controversy that's brought into this debate makes people not want to give, makes people not want to become residents, makes people not want to become pediatricians. it has a damaging impact. And all she's really saying here is, let's get rid of this. Let's not bring this into the issue of whether or not we're going to fund children's hospitals, because, you know, the whole program of pediatricians, residencies, children's hospitals, it's all at risk. And that's the reality, Dr. Shar, and I really appreciate you bringing it up. I think you're trying to essentially say, let's separate this issue from the funding, because it never has been part of the funding before, and all it's going to do is make it much more difficult to operate these facilities, to get doctors involved, to get donors involved, to fund children's hospitals. And that's a real concern. So I yield back.
I yield the balance of my time to my colleague from New Hampshire.
Just very briefly, I just wanted to correct the record when our colleagues said they are not obsessed with these cultural issues. We are going to the floor now to vote on this very issue on the NDAA. So you are obsessed with this cultural issue. I support parents, I support the funding of graduate medical education, and I yield back.
Vote on this one.
I yield back.
Gentleman yields. We're seeing no other members wishing to speak on the amendment. We're going to vote on the amendment, and a roll call has been requested. So please call the roll.
Chair Guthrie. Burgess. Latta. Latta votes no. Griffith. Griffith votes no. Bilirakis.
You know if they're going to.
Bilirakis votes no. Johnson. Johnson votes no. Bouchon.
No.
Bouchon votes no. Hudson. Carter. Dunn. Dunn votes no. Pence. Pence votes no. Crenshaw. Crenshaw votes no. Joyce. Joyce votes no. Harshbarger. Harshbarger votes no. Miller Meeks. Miller Meeks votes no. Obernolte. Obernolte votes no. Eshue. Ms. Eshue. Eshue votes aye. Sarbanes. Sarbanes votes aye. Cardenas. Cardenas votes aye. Ruiz. Ruiz votes aye. Dingell. Dingell votes aye. Custer. Custer votes aye. Kelly. Kelly votes aye. Batagun. Batagun votes aye. Blunt Rochester. Craig. Craig votes aye. Schreier. Schreier votes aye. Trahan. Trahan votes aye. Pallone. Pallone votes aye. Chair Rogers. Chair Rogers votes no.
Any other members? How is Mr. Guthrie reported?
Chair Guthrie is not recorded. Guthrie votes no.
Any other? Seeing no other members, the clerk will report the result.
Don't worry, we won't. Don't worry, we won't.
Chair, on that vote, there were 12 yeas and 14 noes.
12 yeas and 14 noes. The amendment is not agreed to. Seeing no further amendments, the vote will be now on the ains, on the in nature of a substitute, and this will be a voice vote. And all those in favor say aye. Aye. All those against say no. The ayes have it, and the amendment is agreed to. And now we will have a roll call vote has been requested on final passage of the bill as amended. The clerk will report the roll. Not yet. You're good.
Chair Guthrie. Chair Guthrie votes aye. Burgess. Latta. Latta votes aye. Griffith. Griffith votes aye. Bilirakis. Bilirakis votes aye. Johnson. Johnson votes aye. Bouchon.
Aye, and I want to recognize that Ms. Trahan has held her amendment to the full committee. Thank you for that. I vote aye.
Hudson. Carter. Carter votes aye. Dunn. Dunn votes aye. Pence. Pence votes aye. Crenshaw. Crenshaw votes aye. Joyce. Joyce votes aye. Harshbarger. Harshbarger votes aye. Miller Meeks. Miller Meeks votes aye. Obernolte. Obernolte votes aye. Eshue. Eshue votes no. Sarbanes. Sarbanes votes no. Cardenas. Cardenas votes no. Ruiz. Ruiz votes no. Dingell. Dingell votes no. Custer. Custer votes no. Kelly. Kelly votes no. Badagan. Badagan votes no. Blunt Rochester. Craig. Craig votes no. Schreier. Schreier votes no. Trahan. Trahan votes no. Pallone. Pallone votes no. Chair Rogers. Chair Rogers votes aye.
Are there any other members wishing to have their vote recorded? Seeing none, the ayes have it. The bill is agreed to and forwarded to the full committee. Well, hold on. The clerk will report the roll.
Chair, on that vote, there were 15 ayes and 12 nays.
The ayes have it. The bill is agreed to and forwarded to the full committee. At this point, I ask unanimous consent that the documents on the staff list be added to the record. Without objection, so ordered. Without objection, the staff is authorized to make technical and conforming changes to the legislation approved by the subcommittee today, so ordered. Without objection, the subcommittee stands adjourned.